Okay, so uh, good day everyone. My name is Dr. Babawali, the Concept Academy, and today we are going to be reviewing the multi-system part of our Step 2 CK. So we are going to be starting with shock. I know all of us we are very familiar with shock. It's just uh, a clinical situation in which you have reduced perfusion to the tissues, and they are not getting enough blood. They are not able to utilize oxygen for their metabolism. So what are the type of shock that we have? Um, there are a lot of them. We are very familiar with them. The hypovolemic, the cardiogenic, obstructive, distributive, and yeah, so that's the four major class. So what you have to have at the back of your mind first in the questions 10, you know, is you have to look out for the hypotension. That is the first thing. So if you see a patient that is hypotensive and the patient is now tachycardic, you can think, okay, you can entertain the possibility of the patient being in shock, hypotension, and tachycardia. So there is a catch about the tachycardia, which we are going to see shortly. So most of the time, people in shock, they usually have a low blood pressure. And when there's a low blood pressure, the cardiac output drops. So the cardiac output drops, and some of the other parameter changes also occur, which includes the pulmonary capillary wedge pressure, the peripheral vascular resistance, the heart rate, right? So let's take them one by one and see the parameter changes. So for hypovolemic means, you know, the individual is losing blood or the person is losing fluid. So it could be in form of trauma, blood loss from hemorrhage, obstetric emergencies, the person is having ectopic pregnancy that was ruptured, the person is losing blood, or the person has burns injury that is causing fluid loss. All these things is going to lead to hypovolemia. And what is going to happen to the cardiac output? It is going to drop. What is going to happen to the pulmonary capillary wedge pressure? So this is a reflection of the pressure in the left side of the atrium. So when there is reduction in the total blood volume in circulation, of course, you expect the pulmonary capillary wedge pressure to drop because you are going to have a reduction in venous return to the left side of the heart. So ideally, we should also have what you call the central venous pressure, right? So that's why I don't typically like using these to explain. So I think I have to go uh, and use the step one, to explain it. Please just give me a minute. Let me open the step one so I can use that. I prefer that compared to this. Okay, so um, I just don't say all those things up there, and we're just saying everything we're talking about. Yeah, so the first type, hypovolemic shock, blood loss, dehydration, burn injury, volume depletion. That's the mechanism. And what happens to the pressure? So the pressure in the right side of the heart is, reflected with the central venous pressure, while that at the left side is the pulmonary capillary wedge pressure. We have the cardiac output, the systemic vascular resistance, and of course, the mixed venous oxygen saturation. So this talks about the amount of oxygen that you find returning to the heart via the right, side of the heart, the blood that is, emptying into the right side of the heart from the SVC and the IVC. So that is the SVO2. Very important um, parameter you need to pay attention to. So for the hypovolemic shock, no fluid at all in the body. You are losing fluid. So there's volume depletion. You expect all the pressures to go down, right? Central venous pressure comes down. Pulmonary capillary wedge pressure comes down. The left side, the right side. Cardiac output drops. And what is going to happen? Your systemic sympathetic nervous drive, rather, the sympathetic nervous drive is going to come into play to help increase the blood pressure. So they are going to try to, vasoconstrict the vessel, particularly the arterioles, and you are going to have an increase in the systemic vascular resistance. But this is not still going to solve the problem, or else you take care of the hemorrhage, the dehydration of the blood injury, and the SVO2 is going to drop. So most of the time, the SVO2 drops. It is only in some conditions that you are going to have, normalization or increase in the SVO2. So the only thing that increases in the hypovolemic is the systemic vascular resistance, just to increase the blood pressure. So don't forget, what you need to remember is the drop in the CVP and the PCWP. These two is important. And of course, the drop in the cardiac output. Now, the next is the cardiogenic shock. Cardiogenic shock arises when you have any pathology involving the left side of the heart. There's a myocardial infarction, there's congestive heart failure, mitral stenosis, mitral problem or arrhythmia that is preventing the left side of the heart to contract well. So what is going to happen? If the left side cannot contract well, there is going to be pooling of blood in the atrium distal to the left side of the heart. Like, so you are going to have pooling of blood in the left ventricle, in the left atrium, and of course, this is going to reflect as an elevation of your PCWP, right? So it means that if your PCWP is elevated, you are going to be having backflow of blood, from the pulmonary to the right side, right ventricle, right atrium, then to the SVC. So you are going to also be having an elevation in your CVP, your central venous pressure. Of course, because you cannot push blood out of the left ventricle, the cardiac output drops. And this drop in the cardiac output is going to bring about a drop in the blood pressure. The body is going to try to respond to that by elevating your systemic vascular resistance. And of course, the SVO2 also drops. So that is a picture in cardiogenic, unlike in hypovolemic where everything drops, your CVP, your PCP. But in cardiogenic, both of them are elevated, right? So we pay attention to that. Then for obstructive, so obstructive means you have like an obstruction to blood flow. There's something that is blocking blood flow out of the heart. Either there's a pulmonary embolism, there's kinking of the veins, either from tension pneumothorax, or probably you have a compression on the heart itself, like cardiac tamponade. So somebody having a pulmonary embolism means that the person cannot, allow blood to move from the right ventricle, into the left side. So you are going to be having blood pooling distal to the pulmonary embolism, to the right ventricle, the right atrium, and also your systemic vascular, the veins rather. So you are going to be having an elevation in the CVP in that. But blood is not getting to the left. So you don't expect your PCWP to be elevated. So it's going to drop, particularly in PE and tension pneumothorax. So in tension pneumothorax, you just have kinking of uh your veins. Superior vena cava, inferior vena cava, they are kinked by this tensioning of the the hair that is trapped within the thorax, causes a shift in the mediastinum. That shift in the mediastinum kinks the vessels in the mediastinum. So you have a kinking of your SVC, IVC, and you cannot deliver blood into the right side. So it means the blood is going to be pulling in the veins. So causing an elevation of your CVP. But the blood is not going to get to the left. So your PCWP drops. And of course, your cardiac output drop, your systemic vascular resistance increase. And, this is a mistake. Your SVO2 should drop here. It is a mistake. Now, the only one that is different from the others in this obstructive shock is the cardiac tamponade. And what you need to be careful of in cardiac tamponade, because I cannot start explaining the mechanism of cardiac tamponade. I know we all know it. So you have like more like a compression on the heart, due to fluid retention within the pericardium, like the covering of the heart. So and once, because the pericardium covers the entire portion of the heart, it means that all the entire portion of the heart is going to be getting compressed. And you feel the effect of cardiac tamponade more during diastole when the heart is supposed to be relaxing. So that means that you are going to be having an equilibration of the diastolic pressure. So the right side is compressed, the left side is compressed. If they are both compressed, it means you cannot empty into the right side, you cannot empty into the left side. So you are going to be having blood pulling this proximal to the right side, blood pulling proximal to the right side. So that means you are going to have both elevation of the CVP and elevation of the PCWP in cardiac tamponade, which is different from what you have in PE and tension, in which you only have pulling in the right side. Nothing is getting to the left. But in cardiac tamponade, both CVP and PCWP is elevated, just like what you have in cardiogenic shock. And the only way you can separate cardiogenic shock from your cardiac tamponade is just a clinical presentation. Of course, you expect the triad in cardiac tamponade, the elevated JVP, the muffled heart sound, and the hypotension. So um, once you see muffled heart sound and you can see the underlying pathology, maybe there's a pleural effusion or something, that leads into that, you suspect cardiac tamponade. Then the last is distributive. So distributive is very different from the other ones, right? The other ones, they have low cardiac output. It is only in distributive that you have an elevated cardiac output. So particularly the ones that is caused by sepsis and anaphylaxis. So there is an elevation of the cardiac output, right? Cardiac output increase because the pathophysiology of the shock in sepsis and anaphylaxis is vasodilation mediated. So you have release of cytokines in sepsis and anaphylaxis, like histamine and the likes, that causes vasodilation of the vessel. And when there's vasodilation, you are reducing the afterload, from the left side. So you are going to have an increase in the cardiac output. And the SVR is going to drop. So once you see a question and you look at the parameters and you are seeing drop in the SVR, you know that this is likely to be one of those distributive shock, right? Then you look at the cardiac output. Is it elevated or not? If it's elevated, you can think of the ones that requires the cytokines, like sepsis or anaphylaxis. If it is not elevated, then it has to be CNS injury. It has to be a neurogenic shock. Because in neurogenic shock, the cause of the vasodilation is not due to cytokines. The cause of the vasodilation there is due to an interruption of your sympathetic nervous system. So if this sympathetic nervous system are out, there's nothing to mediate vasoconstriction, so there's going to be vasodilation, right? But your heart rate is also down in CNS injury, in neurogenic shock, because your sympathetic adrenergic drive helps in increasing the heart rate. So because of the drop in heart rate, the drop in the systemic vascular resistance, you are going to have a drop in the cardiac output in CNS injury. And all of them is also going to cause a drop in the central venous pressure, right? And another thing you have to pay attention to in them is an increase in the SVO2. So the reason why the SVO2 increases in CNS injury is because in CNS injury, there's a cutoff of the sympathetic chain. Metabolism reduces. The tissues are not taking any oxygen from the pulmonary system, so from the capillary. So it means that all the oxygen in the capillary is going to get to the veins, and there's going to be an increase in the SVO2. But for sepsis and anaphylaxis, it is due to the increased cardiac output. So the fact that the cardiac output is very increased means that you are going to be having a very fast blood flow across the capillaries, giving the tissues little time to extract oxygen from these capillaries. So the SVO2 is going to be increased. So I know what I'm just saying, it's more like a revision to us. We all know that. So it's not something we are learning for the first time. So that's why I'm a little bit hasty with my explanation. So for the hypovolemic, just think about fluid loss. So just replete with isotonic solution. Just give normal saline or you give your ringers lactate. And if you have given 1 liter of that, the next thing is to continue with blood, right? Initiate blood transfusion. For cardiogenic, most of the time you want to support the heart in contracting. Maybe you give ionotropes, dobutamine, mirinone, or people in heart failure, you can further give them this intra-aortic balloon pumping just to pump more blood out of the heart. Then for the obstructive, you need to manage according to the cause. So if it's cardiac tamponade, you have to maybe, do pericardiocentesis depending on the extent, or you create a pericardial window, to relieve that tamponade. If it's tension pneumothorax, you need to insert your needle at the second intercostal space, mid-clavicular line. Insert your needle and do your needle decompression. If it's massive PE, what do you do? Anybody? If it's massive PE, what do we do?
Thrombolysis.
We thrombolize that patient. So for sepsis, just correct the infection. If there's any, focus of infection, just give your IV antibiotics, give your intravenous fluid support. Then you can obtain your culture to ascertain your diagnosis. That's what you do for sepsis. And for anaphylactic shock, what you want to remember is just giving your high-end epinephrine. Just give your high-end epinephrine. That's what you are going to see in the question. You can give adjunct, antihistamine, and steroid, you know. And sometimes you can also have systemic inflammatory response syndrome. This is more like a criteria, the SIRS criteria, temperature more than 37, less than 35, the leukocyte count elevated, your respiratory rate, you know, and the like. So many things can cause SIRS syndrome. So it could be from pancreatitis, bone trauma. This can lead to sepsis, can lead to septic shock. So just treat the underlying cause. And for neurogenic brain or spinal cord injury, you just have to, there's little you can do. Either you go for neurosurgery, and as you are going for the neurosurgery, you need to, start some conservative treatment. Not conservative, like what I mean is supportive treatment. You know, support the collapsed cardiovascular structure. Give vasopressors, give fluid just to maintain that BP, because you know that in neurogenic shock, the cardiac output falls, heart rate falls, blood pressure falls. So give vasopressor to maintain the blood pressure, and also give fluid also to help restore the blood pressure. So the heart rate is usually the first sign to change in hemorrhagic shock. So pay attention to that. It's not the blood pressure, but actually the heart rate. It is a heart rate. And the blood pressure will start dropping when you have lost about 1.5 liter of blood. Somebody's trying to say something.
Yes, Dr. Babawala is with those distributive shock.
Mm-hmm.
um, I always try to figure out why the SVO2 is reduced. Because I know that the reduced total peripheral resistance because of this cytokine that is pulling of blood in the vessels.
Yeah.
So the systems are not getting enough blood, are not getting enough oxygen and nutrients and so on and so forth.
Mm-hmm.
So that probably will trigger reflex sympathetic activity that
Okay.
probably increase heart rate and everything that result in increase in the heart cardiac output, right?
Yeah. So
Okay.
what are you saying exactly, Dr. Antonia? Sorry, I'm a little bit
Yeah,
lost.
why that SVO, it always confuses me.
Is
Why the
increased.
SVO
Yeah.
is
Okay, this
low.
is it. See, this is it. Ask yourself, what is the two condition that cause, what are the three conditions that cause elevation of your SVO2? Just tell me. What are the three conditions I share with increase in the SVO2? What are they?
It's not the distributive shock,
The distributive shock, which includes,
the
which
septic
includes,
shock and the neurogenic.
yeah. So
Yeah.
septic shock, anaphylactic shock, and neurogenic shock, right? Now,
Yes.
so
Yes.
the anaphylactic and the septic, they have the same mechanism. What is
Mm-hmm.
causing the SVO2 increase is because of the vasodilation with increased cardiac output. There is cytokines involved, histamine, prostaglandin.
Mm-hmm.
You vasodilate, you have an increase in the cardiac output. Now, just
Mm-hmm.
picture that blood is flowing across something very fast.
Mm-hmm.
Do you think they are going to be able to have time to extract, enough oxygen? No, no, because of that high
Enough of
cardiac output.
oxygen.
Yes, because of the thing is,
Mm-hmm.
some of the blood is going to flow across them fast. Some of them is going to extravasate into the
Okay.
tissues, you know.
Okay.
But because of that high flow, they do not have enough time to extract the oxygen, you know, and you are going to be having a lot of oxygen being returned to the veins. Do you get
Okay.
that? Do you get that? That is for
Yes.
septic and anaphylactic.
Yeah.
But
Okay.
for neurogenic, you know that neurogenic does not have high cardiac output. So that's where you have to be careful. Do you get?
Yes.
But they have
Yes.
reduction in the heart rate, they have reduction in cardiac output, and a cutoff of the sympathetic nervous system. Do you know the reason
Yes.
why you have high metabolism in thyroid, in hyperthyroidism? Do you know why?
The increase the activity sensitivity of the catecholamines.
Okay, you are not talking. Okay, that's the role of cortisol. That's what cortisol will help you do, increase the sensitivity. Like what your thyroid hormones do is just to activate, those beta receptors. So you have a lot of
Yes.
sympathetic activity. That's why the mainstay of treating symptoms of hyperthyroidism is what? Giving beta blockers.
That,
If you have
that
not given that one, you have done nothing. You give your beta blockers,
mm-hmm.
number one. Now, the same thing is happening in neurogenic shock. you have cut off sympathetic nervous system. So what do you think will happen to the level of metabolism? It's going to drop.
Yes.
In hyperthyroidism, there's increased sympathetic function, there's increased metabolism. They are consuming oxygen. But here, you have cut off sympathetic chain, nothing to trigger, metabolism. The cells are just cold and they are doing nothing. Would they
Mm-hmm.
will they utilize oxygen for anything? No.
No.
So it means you are going to be having a lot of oxygen going back to the veins.
Yes.
So so that is that. What I just want to leave
Okay.
you with respect to neurogenic is that once you are saying hypotension and you are seeing bradycardia, you are not seeing that reflex tachycardia, you are seeing the bradycardia. Let's go and pick your
Yes.
let's go and pick your
Neurogen.
neurogenic. You see somebody that's having hypotension, reflex tachycardia, fever, increase SVO2, go and pick your sepsis. You know,
Sepsis.
you see a patient that's having hypotension, the reflex tachycardia, CVP is elevated, PCWP is elevated, that is your cardiogenic shock. Just go and pick your
Mhm.
cardiogenic shock. It can also occur in cardiac tamponade. You see a patient
Yes.
that's having hypotension, reflex tachycardia, you see the SVP, it is dropped. You see the PCWP, it is dropped. It means there's no fluid in that circulation. Hemorrhagic shock,
Mm.
hypovolemic shock. You can see there is something we can think of. You see a patient has hypotension, reflex tachycardia. You check your CVP, your right side, it is elevated. You see your PCWP, it is low. You know that this is likely to be an obstructive shock, particularly probably a pulmonary embolism or a what? A
Mhm.
tension pneumothorax. Do you get it?
Mhm.
That is it.
Yeah.
So moving on to
Okay. So
postoperative.
in obstructive shock, they have low SVO2.
Yes. So in the
Okay.
other ones, all the other ones, there's low SVO2. Do you get it? So because you have increased heart rate and all those things, so that's it. Um. So don't worry, Dr. Antonia. Like once you have our question, we can just ask the question at the end of the explanation, so that we can move faster.
Okay. Okay. Okay.
Yeah. So
Okay.
postoperative fever, this occurs in 40% of all postoperative patients. So what you just need to take home here is that people can have fever after surgery. Now, most of the time, the fever that can happen at any time after surgery, most of the time they are related to drugs. Probably the person is responding to the antibiotics. The person has a response to part of the anesthetic agent that the person has used. Like malignant hyperthermia, like drug fever, like maybe transfusion reaction. All those ones can happen at any time. So the drug reactions, transfusion reaction, anesthetics, antibiotics, they can happen at any time. But the ones that have some particular timing where they occur, you know, uh, the ones that happen at day 1 to 3 post-operation, the 3 to 4, the 4 to 5, and the 7+. Now, the way to look at it is just look at it in terms of the speed of travel. If somebody wants to travel by wind, by walking, by water, which one do we think is going to be the fastest? It's going to be wind. If you want to travel by airplane, it's the fastest. So that's the one that will come first. So the post-operative, day 1 to 3, you are saying fever. Think about those things that are related to air, like the person having pneumonia or having atelectasis. So post-operative fever, 1 to 3 after operation, think of atelectasis or pneumonia. And what do you want to do to prevent it? Encourage early mobilization. Because if you're trying to walk more, you try to, ventilate and you keep your airway open. The alveoli is opening and they are closing, right? So that will prevent the collapse. Early mobilization. Use of the incentive spirometry. You see people at the end of surgery, they will give them that something that look like blow to be blowing just to keep the airway patent. Atelectasis. Pneumonia too, you can prevent by giving the antibiotics. Post-operative 3 to 4. So after hair, it's better for me to use water, maybe boats, or I use yacht, or I use ship, you know. So you think about things related to water, UTIs. So you don't want to leave your catheter inside too. Maybe within 1 week, remove your catheter. The 4 to 5, you think about walking. So I'm walking. What can happen when somebody is walking? When somebody is not walking. DVT, pulmonary embolism. DVT, pulmonary embolism. DVT, pulmonary embolism. And from our knowledge of respiration, respiratory system, what do we say is the best preventive measure that helps to protect against developing PE? Anybody remembers? Or DVT?
Early
Early
mobilization.
mobilization. Just be
Early
walking. Get out
mobilization.
of bed. So early mobilization is going to help you prevent both atelectasis and what? DVT. So then we can now say give subcutaneous heparin, then wear your compression stocks. Then post operative day 7 and above, think about your surgical site infections. So you have to encourage regular dressing changes. You remember when we're in the hospital, we see them change the dressing. We change the dressing time to time, because you want to promote faster healing of the wound, and you don't also want to allow for surgical site infection. And of course, you have to give like an antibiotic cover to reduce that. So this is a key fact. Endometritis is a cause of postoperative fever after cesarean section, and usually occur between postoperative day 2 to 10. So O and G stuff are always a different stuff. So endometritis can occur 2 to 10, 2 to 10, after cesarean section. Okay. So if somebody develops fever after administration of allothane or choline, raise your suspicion for malignant hyperthermia. I'm going to leave us with a statement. With respect to malignant hyperthermia, do not forget the fever, do not forget the rigidity, do not forget the end tidal CO2. So what happens to the end tidal CO2 level in people with malignant hyperthermia? Anybody remembers?
I think it's increased.
Yeah, so it's increased, because the respiration too is not fantastic. So they are not able to, blow out enough CO2. And that is one. And again, the thing is, because of the increased metabolism, hypercontraction of the muscles, they are generating a lot of CO2. So your entire CO2 is going to be elevated. Even though they might be tachypneic, but the amount of CO2 that is being generated is just overwhelming. So your entire CO2 level increases. That might be the clincher you are going to see. I'm serious. After demonstrating that this person has taken allothane, has taken choline, or any of the inhaled anesthetic agents, you are now seeing fever. You are seeing rigidity. You are seeing features of maybe AKI or something like end organ problems. Think about malignant hyperthermia. So, um, so what you just do is just give your dantrolene and cooling to bring down the body temperature. Everything is due to the hypercontraction. The hypercontraction is what is giving the heat. The hypercontraction is what is breaking down the muscles, releasing myoglobin. Myoglobin traveling to the kidneys, causing AKI, explaining the electrolyte derangement. That's just the way to look at it. So moving on to fever of unknown origin, I think we need to solve one or two questions before I go. Okay, so this is a 25-year-old woman who comes to the emergency department 1 hour after sudden onset of diffuse abdominal pain and nausea. Okay, she has no history of serious illness. The menses occurs at regular interval. Her last menstrual period was 6 weeks ago. Sexually active with two sexual partners and uses OCPs inconsistently. She's pale and diaphoretic. Her temperature is 37.7. Respiration is okay. Blood pressure, respiration is elevated. Blood pressure is low. Abdominal examination shows diffuse abdominal tenderness. Pelvic examination shows a normal appearing vagina, cervix, and uterus with right adnexal tenderness. Hemoglobin is low. Leukocyte is 10,000. I say this is elevated. And it's normal. You can say it's normal. I think what's the range? Is it 4,500 to 11,000, depending on what we are using? So let's leave that. Platelet is 350. That's okay. Result of a pregnancy test are pending. Which of following is the most appropriate next step in management? So from our knowledge of 1G, what do we think this guy is having? This patient is having?
A ruptured ectopic pregnancy.
Lecture pregnancy, because we can see the hypotension, we can see the tachycardia. That means there's a shock ongoing. And we can see the patient has right adnexia tenderness. And of course, there's also diffuse abdominal tenderness, means it has ruptured into the peritoneum. So there's diffuse abdominal tenderness. So think about ruptured ectopic. Although the pregnancy test would have helped us more, So what's the next step? What do you want to do? First thing to do.
Um, Resuscitate this patient.
Resuscitate this patient. So don't ever go and pick exploratory laparoscopy.
Yeah.
Resuscitate that patient first before you take him. You know.
So you administer Ringer's factor.
Yep. Correct. So, an 82-year-old man is brought to the emergency department from a nursing home with altered mental status. According to his caretaker, he was disoriented and was shouting obscenities at his co-resident. So there's an altered sensorium already. Over the past 2 days, he has a foul-smelling urine. Temperature is elevated, pulse is elevated, BP is low. He's oriented to person but not place and time. Extremities are warm and dry. Other than a weak pulse, cardiopulmonary examination is unremarkable. Placement of a Foley catheter yield cloudy urine with a foul odor. This patient is likely to have which of the following hemodynamic profile? What's our diagnosis? That's the first thing before you know what to go and pick.
Septic shock
This is a septic shock.
from UTI.
Evidence by
Elevated,
So false smell,
elevated temperature,
false
tachycardia.
exactly.
and then
So
blood pressure is low.
exactly. Yeah. So there's an elevated temperature, there is tachycardia, there's hypotension, and we are able to demonstrate the focus, which is the foul smelling urine. So UTI. So what is the clinical picture we expect? Cardiac output, what should it be for septic shock?
Increased.
So the pulmonary capillary wedge and the CVP, what should they be?
Normal.
Hmm? Hmm?
Pulmonary
Reduced.
Is it normal
pressure.
anywhere? It is not normal anywhere. Any
No,
formation
it's not. It's reduced.
Reduced.
is reduced. The systemic vascular resistance
Reduced.
reduced. So that means that the best option to pick is going to be D. Okay, that's all.
Yes.
Sure. So you can see the way to look at questions. Have your diagnosis in mind. Know what you are, because your diagnosis is going to help you, to the option, right? You know what you are going to be thinking, like the line you are going to be thinking with. But the thing is, yeah, you might not be able to make diagnosis for all the questions. If you can make your diagnosis, you can just look at the option and see what each option represents and see if you can link it to the question. So that's another strategy to solve questions. So, um, so do I have anything on post-operative fever? No. So moving on to fever of an unknown origin. So this is just a situation in which you have elevated temperature at 38.3 degrees Celsius for at least 3 weeks. That is undiagnosed. So somebody has been coming, to clinic for 3 weeks, and the person has been having this temperature reading for 3 weeks, and we don't know the cause. Or somebody has this temperature reading more than 38.3 after at least 1 week of hospitalization, and we don't know the cause. That is what you call fever of unknown origin. Now, when it comes to fever of unknown origin, three causes comes to mind. Either you are dealing with an infection, occult infection, or you are dealing with a malignancy, or you are dealing with an autoimmune disease. That is it. Then you can have the miscellaneous drug fever, factitious, fever, so many other things that are just atypical. So the three things that you come to your mind that you are going to be investigating along is what? Infection, autoimmune disease, malignancy. So what are the infections we are talking about? Tuberculosis. You know that somebody can have tuberculosis and you don't know. Endocarditis, especially the archaic organisms, occult abscess, abdominal abscess, prostatic abscess, osteomyelitis, catheteral infection, sinusitis. Now, the thing is, you don't need to cram all these things. You will not be asked. I'm serious. You don't need to cram anything. In fact, by the time you even look at the option, even if they bring it, you'll be able to figure it out. And people that have HIV, they can have some infection too that will be silent. We remember that when we were discussing our HIV, we said, they can have Mycobacterium avium complex. Sometimes it's asymptomatic, just like histoplasmosis. It is asymptomatic, and sometimes cytomegalovirus too can be asymptomatic. So, you can have histoplasmosis and the person will not have anything. The person can just be having a low-grade cough. non-specific symptoms of anything. You don't know what is causing the cough, but from histoplasmosis. Mycobacterium avium, they can just have maybe a focal lymphadenitis somewhere. No diarrhea, no chest finding, no cavity anywhere, asymptomatic. So you have to investigate along that line. Neoplastic. So you don't need to think about this cancer. It can be any cancer. Can be any cancer. Autoimmune can be still disease, can be SLE. So still disease, just to talk about it, so you expect 3 triad to make diagnosis of still disease. The individual must have high fever, must have a joint pain, and must have salmon-colored bumpy rash. Now, this could mimic probably, SLE could mimic rheumatoid arthritis. If you do your ANA and your RF, both of them is going to be negative. Your antinuclear is going to be negative. Rheumatoid factor is going to be negative. If you do your blood work, you are going to be seeing neutrophilic leukocytosis. Neutrophilic leukocytosis. And the person can have some systemic symptoms like hepatosplenomegaly. So somebody having high fever, arthralgia for at least 2 weeks, salmon-colored bumpy rash, having hepatosplenomegaly with negative RF, negative ANA, think about still disease. So SLE, cryoglobulinemia, this is actually with hepatitis C, and you can see the triad of fatigue. So most of the time they have fatigue, they have arthralgia, and they have a palpable purpura. So you see an individual is having fatigue, arthralgia, palpable purpura. Think about cryoglobulinemia. Polyarthritis nodosa is another autoimmune disease. Any of the connective tissue disease, Marfan, granulomatous disease, sarcoidosis, and the likes. Then miscellaneous could be a PE somewhere, could be a DVT. DVT will trigger inflammation, so they can have fever. It could be an hot IBD somewhere. The person might be taking alcohol, alcoholic hepatitis, drug fever, factitious fever. In which the person is a person that is faking the stuff. So that is that. And sometimes it could be idiopathic. So if it's idiopathic, it's of good prognosis. You have investigated, you may not see anything, then it's good because it's going to resolve with time. So how do you confirm the diagnosis? You just confirm the presence of the fever, right? You do your blood check and please. Okay, so sorry about that. So yeah, so just confirm the presence of the fever, take a detailed history. Family history, you want to see if there's family history of any autoimmune disease. Social history, the person drinking, that could cause alcoholic hepatitis, the sexual history, because you can have HIV, and the individual can develop some of those HIV actually disease, occupational history, like what does the person do, healthcare worker, they can be exposed to so many things and the like. So the diet, exposure like histoplasmosis, travel, tuberculosis, histoplasmosis, everything. So then you start, doing your laboratory investigation. The first thing that you have in mind is infection, right? So do your basic complete blood count with the differential, do your ESR with the CRT protein. Both of them are going to be elevated in, infections. You can do your serum protein electrophoresis, multiple myeloma. That's a cause of what's it called? Malignancy, that could explain the occult fever. You can do your blood culture, depending on how the patient presents, right? You can do your sputum culture if you are thinking tuberculosis, gram stain, you can do your analysis, PPT. So it just depends on the way the patient present. Then you can also investigate for your autoimmune disease by doing your check for HANA, check for your rheumatoid factor. And you can also obtain imaging, and you must obtain X-ray of the chest. You can detect tuberculosis, histoplasmosis from there, and you must also, after you've done your chest X-ray, also do your CT scan of the chest, abdomen, and the pelvis to see if there's any occult abscess, any occult lesion that you are missing. So you are going to be, seeing some of them on your CT. So you are just trying to do like a mirroring just to see whatever is going on in that body. Chest X-ray, your CT of the chest the abdomen and pelvis. Don't forget that. Don't forget that. It's done. In fever of unknown origin. You don't need to do like bone marrow biopsy because it's yield, very low yield. And the nuclear medicine and laparoscopy are second line after CT. But trust me, you won't get to this. This is what they want you to, because how many times do you do nuclear medicine and laparoscopy? So, but X-ray and your CT scan, don't forget that. Don't ever forget. You see, you are looking at three things. You are looking at the chest, you are looking at the abdomen, you are looking at the pelvis. It could be a prostatic abscess, sit in your pelvis. It could be like abdominal abscess, sit in the abdomen. There could be a malignancy, lung, liver cancer, renal cancer, abdomen, CT scan, histoplasma tuberculosis, anything, lung cancer, anything. Then depending case by case, you can also do some serologic testing to see for some particular infections like Coxiella, Bartonella, Brucella, because you can't culture these guys. So that's just by the way. It's not really very important for us to start cramming all these things because we are not going to be asked. So if the person is on any drug, because drug fever can be a cause, just stop the drug. Stop that drug, right? If the person is on catheter, because you can have catheter infection, remove the catheter. Remove any indwelling catheter line because they are potential source of infection. And people that have a negative workup, the idiopathic one, they have a very good prognosis because it's going to resolve within months to years. So let me see what we have here. Okay, this is not, is it a question? This is a very long question. Okay, so let me see. Okay, going on like this. So, so this is more like a case. The reason for this person's visit is follow-up 1 week after undergoing evaluation for persistent fever. So 4-week history of daily fevers and chills. The fever is present throughout the day and it is associated with feelings of fatigue and malaise. And the individual reports resolution of the fever with use of over-the-counter naproxen. Now, I must mention something. If the fever resolves after 3 days of administration of naproxen, with naproxen, think about malignancy as a cause. So if it doesn't resolve, it could be an infection. So that is that. So if the person reports no other symptoms, no recent sick contact, travel, hospitalization, 2 visits to the clinic in the last 6 weeks, and fever is documented at both visits. At the last visit, blood and urine samples were collected and chest X-ray was performed. Results to be discussed at current visit. 5-year history of hypertension. Medications include amlodipine, naproxen, and vaccinations up to date. Allergies, no known drug allergy. Family history, the mother has, we don't need that. Smoked 1 pack of cigarette daily for 20 years, quit at the age of 42. How old is he now? He is no age, don't have it. Okay. The temperature is elevated, pulse is okay, respiration is okay, PP okay. Weight is okay. 100 kg, okay. Appearance, no acute distress. Skin rash, nothing. HEN, head, neck, and throat, okay. Pulmonary, okay. Cardiac, okay. Abdomen, okay. Extremity, okay. Neurologic, okay. Blood work is okay. Blood work is okay. Yeah. Everything looks okay. C-reactive protein is okay. Urinalysis is okay. Chest X-ray, no abnormality. Which of the following is the most appropriate next step in the management of this patient? So, what is our diagnosis, first of all?
The paresy of unknown origin now.
Pyrexia of unknown origin. This guy has been coming for 4 weeks and has been having the fever. So, and we need 3 weeks. So, this is pyrexia of unknown origin. So, what do you think you want to do for this patient afterward? I know this stuff is not well organized because of the way the question is. So,
It's long. I can't even pick a lot of the history.
yeah, but everything
Maybe
is normal.
6 times.
Yeah, so what do you want to
Everything
do?
is normal.
Mm-hmm. So, what do you want to
Okay.
do?
Do imaging.
CT scan.
That's very correct. So, do your CT scan of
Yeah.
your abdomen and pelvis. That's very correct.
Mm.
Okay. So sepsis. Sepsis is just when you have uh you know like a focus of infection causing the SIRS um what's it called? SIRS clinical picture or laboratory picture. So somebody having the SIRS criteria, which is the fever or hypothermia, having increased respiratory rate, having tachycardia, having changes in the blood work, leukocytosis or leukopenia. Any three of these, with a focus of infection, you call that sepsis, right? And you can have this with features of shock, hypotension, tachycardia. You call that septic shock. Particularly when the individual cannot, maintain the blood pressure after you have administered, unless you administer vasopressor, or the person is still having a a high lactate level, more than 2 milliequivalent per liter, after adequate fluid resuscitation. So you call that septic shock. So just to cut the story short, sepsis is just when you have infection in the blood, right? And um, it is a cause of warm shock, meaning because of the high cardiac output, you are going to notice that the extremities are going to be well perfused, so it's going to appear warm, right? But it is not effective because the tissues are not using them. It is a microbe that is taking over everything. So that's why effectiveness has to be defined in its terminology. Thank God we are not doing written exam that we have to be defining all those things. So the word effective has to be there. So it's not about that maybe blood is getting to the tissues now. Well, is it effective? Are they using it? No. So there's a warm shock, warm skin, and extremity. So it's different from the other types in which you are going to be seeing cold and clammy extremity. But in shock, that is distributive, it is going to be warm, skin and extremity. So you can see features of DIC, abnormal coagulation, ecchymosis, petechiae because of DIC. It's very common in septic shock. If you do your laboratory test, what do you see? Leukocytosis or leukopenia. I've talked about the SIRS criteria. Um, Evidence of reduced tissue perfusion, because with time, perfusion is going to drop, because once you have increased vascular permeability and you have a lot of fluid extravasating into the tissue, into the interstitial space, little is going to be getting to the tissues when the shock progresses. So you start having failure of the organs, MODS. So the kidney starts failing. You see elevated creatinine, abnormal liver function test, increased lactate because you are no longer using the aerobic pathway. The individual is going to start activating the anaerobic pathway. So lactate is going to start increasing because of the what? The anaerobic respiration. So abnormal coagulation studies, evidenced by maybe DIC, with increased INR, prolonged PPT, and all those things. So we know all those things. So if it gets to a point where the hypotension requires vasopressor to maintain the arterial blood pressure more than 65, the mean arterial blood pressure more than 65, you need to use vasopressor to get this. Or you're having elevated lactate more than 2 milliequivalent per liter, despite resuscitation, that is septic. So this is the major criteria to call it septic shock. You have to have you need to administer vasopressor to get mean arterial pressure of more than 65, or you are still having a persistently elevated lactate despite fluid resuscitation. So take culture from any sites that you think is likely going to be the focus. Blood, of course, you have to take blood, that's mandatory. So if the person might be having upper respiratory tract infection, just take your sputum, meningitis, CSF. If there's a wound, cellulitis and like, take the wound culture and urine. And all this should not delay antibiotic. You have to give prophylaxis antibiotic. That is the mainstay of treatment in septic shock. So sometimes if they are very down and you have a very poor consciousness, or the hemodynamic instability is very severe, you might need to admit them at SCU care. We remember in recipe, I gave us 4 indications for intubation. Anybody remembers anyone? Anybody remembers? So
For ventilation.
no, for intubation in the ICU. 14.
Intubation in the ICU.
Yeah,
Is
14.
it indications or what?
Indications, yeah.
For intubation in the ICU. Okay. To maintain airway.
Yeah, so if the person has a GCS score less than 8, you have to intubate. If the person has respiratory failure, evidence that maybe hypercapnia or hypoxemia less than 60, hypercapnia greater than 50, intubate. And the last is hemodynamic instability, intubate. After you intubate, you give empiric antibiotics, bombard with antibiotics and fluid, to maintain your MAP. Then you treat the underlying cause. So that's that about septic shock. Is very simple. Make your diagnosis. If there's a need to intubate, intubate. Give your antibiotics, give your fluid, and if there's a focus, treat that focus and eliminate it. So that is it. So I don't think okay, I've solved the question on it before. So malaria. We know we have 5 species of malaria: the Plasmodium falciparum, the Vivax, the Ovale, the Malaria, and the Knowlesi. The 3 that is important for our exam majorly is what? Falciparum, Vivax, and Ovale. But the baddest one is the falciparum. So that one is responsible for the highest mobility and mortality. And it's important to always remember that if you are traveling to a malaria endemic region, you have to use prophylaxis at least 2 weeks before you go. And when you come back, you use prophylaxis for 4 weeks after you come back. So, what are the typical presentation of somebody that has malaria? High fever. Malaria is not something that is new to us. So, high fever is going to be there. They are going to be, having tiredness, loss of appetite. They could have headache, sweating, diaphoresis. And the fever spike might be following a regular pattern, might be following every 2 days or every 3 days, depending on the species of malaria. So the fever spike can occur every 2 days if it's the P. malaria, if it's the P. vivax or the P. ovale. It could be occurring every 3 days if it's the P. malaria. But it could be irregular for the severe one, which is what? The P. falciparum. Could just the burst of the merozoites from the red blood cell can just be happening irregularly, not predictable. So that's the P. falciparum. And people with the P. falciparum typically develop the more severe type of malaria, right? Severe malaria. So, but if you say somebody has severe malaria, the person has to have hyperpyrexia, high fever, very high fever, greater than 40. They are prostrated. They cannot stand. They cannot walk. They are just lying in bed. Impaired consciousness. Pulmonary edema due to damage to the vessels of the lungs. Pulmonary edema. They can start having, acidosis, hyperventilation, bleeding, DIC. They can have bleeding, coagulopathy. They can have AKI. They can have injury to the liver, elevated liver enzyme. So once you are seeing organ involvement, like the lungs, the liver, the kidneys, you are suspecting a more severe form of malaria. So, but if you are seeing someone that has malaria and the person is having a rash, that is not malaria. Malaria doesn't cause the rash. It doesn't cause the skin ulcer. No eosinophilia, no lymphadenopathy, no neck sickness. So all these ones means alternate diagnosis. So what do? You just have to do your blood smear, right? Do your GIMSA or your Rice-10 blood smear, the tick and the film, and the tick and the thin, the tick and the thin blood film to identify the organism. What are you doing? So with the tick, you just want to quantify the organism and see, okay, what am I dealing with? Plasmodium, fine. But what is now going to tell you that are you dealing with Plasmodium falciparum, Ovale, Vivax is when you now do your thin film. So your tick film is going to identify the organism for you, that this is Plasmodium, this is the amount of Plasmodium you have. But the thin is going to tell you the particular species of the Plasmodium that is infecting the individual. If you do other blood work, you are going to be seeing pneumocytic, pneumochromic anemia, reticulocytosis because of why do we have reticulocytosis? Anybody?
That's hemolysis.
Yes, there's hemolysis. So then, in some more advanced setting, we now have rapid antigen kits, to detect malaria. You can use a PCR, if somebody has altered mental status. So part of the ABCDE for the D which is more like a disability, you have to check for the glucose level to see if it's not hypoglycemia. So cerebral malaria is a form of severe malaria, and the individual is going to be having headache, going to be having seizures, altered sensorium, can have hemorrhages and the likes. So it can progress to trauma. So you have to coma. So you have to give intravenous artesunate to individuals with cerebral malaria to quickly take them out of that condition. So you have the complicated and the uncomplicated malaria. So malaria that's just associated with fever, just headache, loss of appetite, nothing involving the kidneys, nothing involving the lungs, nothing involving the liver, no acidosis, nothing, associated with convulsion or the likes. That is uncomplicated malaria. So what do you give? You give oral agent. That's the first thing. You give oral agent, oral anti-malaria. And usually we use chloroquine because of the resistance to chloroquine now. You don't use chloroquine again. So you can use mefloquine. We can use atovaquone proguanil, or we can use the artemisinin. So you usually use the artemisinin for very severe cases. So if somebody is having uncomplicated one, just give oral mefloquine, oral atovaquone proguanil. But if somebody is having severe malaria, like cerebral malaria, involvement of the liver, the kidneys, then you have to give intravenous artemisinin combination. So if you did your thin smear and you are seeing Vivax or Ovale, or you don't know the species, you have to add a primaquine to eradicate the hypnozoids in the liver. We know this. This one is basic step one stuff. So don't forget about the primaquine. For individuals that are traveling to endemic regions, they need to take prophylaxis, which we have talked about, which could be any of the oral one, atovaquone or proguanil. So just take it 2 weeks before you travel, 4 weeks after you travel. Protect the individual. So what are the contraindications to the use of some of those anti-malaria? So primaquine is the one you use for the hypnozoids, right, of Vivax and Obali. So you have to do a GCSPD assay, rule out GCSPD, because it can cause hemolysis. Mefloquine irritates the cerebral cortex, irritates the heart. So because it irritates the cerebral cortex, they can have seizures, they can have psychiatric issues. It irritates the heart, they can have conduction abnormalities. Atovaquone proguanil. So because of the proguanil, it sounds like pregnancy. So you don't use it in people that are pregnant, people that are breastfeeding, and also you don't give people with renal disease. Chloroquine can trigger psoriasis. Chloroquine can cause retinitis and the like. So it can cause itchiness. So, but we don't use chloroquine again. So, what are the complications of malaria? Just more like what we have talked about with respect to severe malaria. They can have severe malaria, acute, severe hemolytic anemia, renal impairment, non-cardiogenic pulmonary edema, hypoglycemia, and the like. So that's that about the complications. And all this is caused by the female Anopheles mosquito. So we have some other infections that can be caused by other mosquitoes, which are not the Anopheles. Okay, I have a question here. Let's just look at this. A 37-year-old woman comes to the emergency department due to 5 days history of fever, chills, malaise, headache, and fatigue. The patient temperature has fluctuated between 37 and 41. She has been taking ibuprofen, which improves the fever. The patient took a 7-day vacation to Southeast Asia a month ago. Temperature is 39.9. Other vitals, okay, pulse is elevated. On physical examination, the patient appears tired and has mild scleral tears. There are no oropharyngeal lesions, lymphadenopathy or rash. The lungs are clear on auscultation and no cardiac murmurs are present. The liver is slightly tender to palpation and the spleen tip is palpable below the left costal margin. Neurologic examination shows no sign of meningeal irritation, which is the first next step in diagnosis. So, what do we think this person is having?
Malaria infection.
Malaria, because
And
she had traveled
yeah,
to Southeast Asia.
east.
She has fever, actually with chills, malaise, headache, fatigue, and it appears that she's hemolyzing. There's scleral tears. So
Yes.
This is malaria. And so what are we doing next in the
Blood,
diagnosis? The what?
blood smear,
Blood smear.
blood smear.
Okay. So for the other mosquito borne, well, we know this very well. This is not something that is new to us. And the ones we are interested in is the Aedes mosquito. The Aedes mosquito, and most of what it causes, the chikungunya, the dengue, the Zika, they can present with rash, fever, and myalgia. So chikungunya is the first one, and chikungunya, what should raise your suspicion for chikungunya is if the patient is having this rash, maculopapular rash, having fever, having arthralgia with joint swelling. So the arthralgia with the joint swelling, the fever, the rash, myalgia. With history of exposure to these mosquitoes, think about chikungunya. So they notably have joint pain. The treatment is supportive. If the arthralgia is chronic, you can give what? Anybody remembers what you give if the arthralgia is chronic? Chikungunya.
Demand.
So you give your demand.
Demand.
So most of the time you don't see alteration in the blood work. You don't really see thrombocytopenia, leukocytosis, or anemia. It's not very common with chikungunya. But if you are seeing a patient having this rash, probably like petechiae rash, fever, arthralgia, myalgia, having retroorbital pain with alteration of the blood works, thrombocytopenia, anemia, leukocytosis or leukopenia, think about dengue fever. Think about dengue fever. Very important. And, dengue can affect, the liver, so they can have elevated LFT, probably from the bleeding and from reduced blood flow to the liver. They can have abnormalities in the liver, can have a low white blood cell count, thrombocytopenia, shock. Dengue can cause dengue shock syndrome. So because of the bleeding, so they can go into hemorrhagic shock. So what you do is you offer them supportive treatment, right? Give them fluid, administer blood if it's available, then you administer the dengue vaccine, which is a vaccine that is conjugated to the backbone of your yellow fever. So you give them the dengue vaccine. No vaccine for chikungunya, just avoid the mosquitoes. Treatment is supportive. If there is pain, give analgesics. They are dehydrated, give them fluid. Zika. Zika is another flavivirus, just like dengue. Both of them. Chikungunya is alpha virus. Dengue and Zika, they are flavid. And I used to say something about Zika. CPR, conjunctivitis, rash, and what? The pyrexia. That is the CPR. So a patient having conjunctivitis, having fever, having rash, think about Zika. It's transmitted sexually and it can be transmitted by the mosquito bite. It can be shared with Guillain-Barré. So it is not only Campylobacter jejuni that causes Guillain-Barré. Zika can also cause Guillain-Barré. And what do you see? Because of the fact that it can affect the fetus, you see MOM, MOM, MOM. So the motor problems, the O for the ocular. And what's the last M? Anybody remembers the last M?
Microcephaly.
Microencephaly, thank you. So microencephaly, the motor presentation like maybe paralysis or seizures. Then the O for the ocular abnormalities. And the imaging is going to show subcortical calcification with ventriculomegaly. But despite the ventriculomegaly, the head is still small because the cerebral parenchyma is the one that is reduced. The volume of the cerebral parenchyma is what is reduced, not the ventricle. So the ventricles are enlarged, but the cerebral parenchyma is reduced. So at the end of the day, the baby is going to be having microencephaly. So offer supportive treatment. The tick-borne infections. Lyme disease. Lyme disease is very, very important. We should not forget it. It's caused by a spirochete, which is what you call Borrelia burgdorferi, and it's transmitted by the Ixodes tick. So this Borrelia is transmitted by this Ixodes tick, and this tick also transmits through other infection that is anaplasmosis and what? Anybody remembers?
Ehrlichiosis.
No, Ixodes tick.
Oh, sorry.
Uh, Lyme disease and oh my goodness,
The acronym is BAB.
N1
Yes, babesiosis. Yes.
babesiosis.
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 So what transmits heliciosis? What's a tick? The Lone
Is
Star
Lone Star
is
tick.
static. So the exotic tick, Borrelia, anaplasmosis, and what? The Babesia. So
No
um
static.
yeah.
Babesiosis.
So you see it in the southeast part of the US. I think California also. I'm not really sure. You can check that. Southeast US, that's where you get, this guy. And I think we are going to discuss it. Yeah. So literacy is just a key fact. Lone static, and then to the south, central and south eastern part of the US, and the presentation is just constitutional. You don't know headache, fever, chills, whatever, can be anything. But one thing about them is that they don't typically cause a rash. So if you are not seeing rash and you are seeing all these constitutional symptoms, it can heighten, and the person has had a thick exposure, so it could be likely to be ehrlichiosis. So it can also cause leukopenia, thrombocytopenia, and elevated liver enzymes. And if you do your blood film, you are going to see the what? The morule in the what? In
Monocyte.
the monocyte. So just give your doxycycline. So most of those atypical guys, rickettsia, ehrlichiosis, anaplasmosis, they respond to doxycycline. So give your doxycycline, they're going to be fine. So back to the Lyme disease. So Lyme disease, what you just want to remember is just the three stage: the primary, the early disseminated, and the what? The late disseminated. So for the primary, we are just expecting the person to just have the typical rash, which like the target sign. Can see this outer erythematous, middle clear, inner erythematous. So this is classic for the localized stage of Lyme disease. And I'm going to still say it, but let me just say it here. Like at this stage now, you might not need to do any serology because your serology will start appearing about 1 to 2 weeks after what's it called, the rash has developed. So it's not very, very sensitive at that point. So yeah, it's clinical. But when you get to the late and the early disseminated, you can now be combining whatever you are seeing with your serology because you expect serology to be positive by that time. And what do you expect for the secondary or the early disseminated disease? So this rash starts migrating from the point of bite to other sites. You start seeing the rash appearing on other sites. You start seeing cardiac presentation, myocarditis leading to third degree heart block. You start seeing them having bilateral facial nerve palsy. Any patient with bilateral facial nerve palsy, that is Lyme disease until otherwise proven. You don't know anything in Lyme disease, know that. Bilateral trigeminal neuralgia is specific for what disease? Bilateral trigeminal neuralgia is specific for what disease?
Multiple sclerosis.
Multiple
MS.
sclerosis. Bilateral facial nerve palsy is specific for what disease? Lyme disease.
Lyme.
So that's the way to look at it. Don't forget the
Lyme
third degree
disease.
heart block. And again, at this point, they are going to be having migratory arthralgia, migratory myalgia. So feel myalgia here, feel muscle pain there, feel joint pain here, feel it there, migratory. Then at the tertiary stage, so that's when they now start having the encephalitis. So memory loss, mood changes, personality changes, difficulty speaking, and all those things. Then they have a chronic arthritis in the tertiary stage, which is bad. Chronic arthritis, an affectation of the brain parenchyma, personality changes, mood changes, memory loss, and the like. So how do you make a diagnosis? For the early, it is what? Clinical alone. Don't worry, you don't need to cram anything. It's clinical, just move. And the early and the late, you look at the symptoms. You are seeing bilateral facial nerve palsy, you are seeing, myocarditis, third degree heart block, and the person at that tick exposure lives in area where those ticks are endemic. This is likely to be with the chronic arthralgia, and the myalgia. This is likely to be Lyme disease. You can confirm with serology. Check your IgM, check your IgG. You don't need to cram anything. So just know that IgM or IgG will be positive. especially IgG, because at that time it will have, you know, gone for some time. So, and what is the test you use for the serology? You do your ELISA. You do your ELISA, right? So check for your IgM and your IgG. Now, if you get a positive test or the result is equivocal, you are not sure, you don't know if it's positive or negative, you proceed to do your Western blot for confirmation. This is high yield stuff. This is what? High yield stuff. So for the early or the localized disease, this is clinical. For the early disseminated or the late disseminated, you do your what? Serology, starting with ELISA. If it's positive or equivocal, you proceed to what? To do your Western blot. If it's negative, you stop. But if you get a positive result or equivocal result, do your Western blot to confirm. Whatever you can do. But you must never start with Western blot first because of high risk of false positive results. What do? You have made your diagnosis, look for the tick. If you can see the tick, remove it with a forceps. Please don't use your hand. You will see forceps in the question, in the option. Remove with forceps and disinfect that area. It's as simple as that. Then you commence your treatment, right? So if the person is having early disease, just give your doxy, just like what you give in ehrlichiosis, just like what you give in rickettsia. Give your doxy. But if the patient is less than 8 years or the patient is pregnant, give your what? Amoxicillin. So if the patient is less than 8 years or pregnant, give amoxicillin. If the patient is less than 8 years and you are not seeing amoxicillin and you are seeing doxycycline, pick it. But because you can give young patients short courses of doxycycline, you can still give them short courses. For more advanced disease, we are seeing hypertension of the heart, hypertension of the brain, severe joint problem. This is likely to be either early disseminated or late disseminated. You are not going to be giving doxy or amoxicillin. So you give your IV ceftriaxone immediately, right? So that is that. So if a patient has the characteristic rash, arthralgia, or the tick bite in an acquired in an endemic area, you can give your empiric therapy. So which is your doxy or your amoxicillin, and you also have to encourage, and working in all those bushes where you have the tick to prevent the condition. So this could be a question. They paint a scenario of someone with Lyme disease, and they ask you, what is the best preventive strategy? So that should be what? Avoiding tick bites. So you might need to give prophylaxis. And what is a prophylaxis? One single dose of doxy. Now, some criteria need to be met. But most of the time, you don't need the last one because there's no way you'll be able to calculate it, which is a local rate of infection of ticks with public. There's no way you can know this. So most of the time, don't put that at your mind. Don't put that at the back of your mind. But it's good to know it. The local rate of infection at that particular region, with the ticks having this Borrelia burgdorferi is more than 20%. But the three essential one is that the tick must have been attached for more than 36 hours or 36 hours. So how do you demonstrate this? The person will tell you that the person, the question is going to tell you that the person has gone for hiking or the person has gone for a trip in the bush of this endemic area for like maybe 4 days or 5 days or like 3 days. You know that, okay, this is more than 36 hours. The person must have had contact with the tick for more than 36 hours. So that is settled. Then you start your prophylaxis. But before you start, you ensure that this individual has no contraindication to the doxycycline that you are giving. Ensure that the patient is not pregnant. Ensure that the person doesn't have any photosensitivity rash when he uses doxycycline. So, if the person doesn't have any contraindication to doxycycline, the person had exposure to that tick for at least 36 hours, you start it within 72 hours of removal of the tick. So, you start your prophylaxis within 72 hours of tick removal once the person meets this criteria. So what is the criteria? The person had gone to the area where there's tick, and the person has stayed there for more than 36 hours, and the person doesn't have contraindication to doxycycline. It's as simple as that. Just make sure you start it within 72 hours. So, tick testing is a common incorrect answer choice. It has no effect on management. Out of everything we have been discussing now, have we said we are going to test for the tick for presence of the bugdophery? No. So tick testing is a incorrect answer choice. So either you remove the tick, disinfect that area, or probably if it's early, it's clinical, you start your treatment, or if it's late or early disseminated or late disseminated, you start your workup, serology with ELISA, then go to your Western blot, you now start your treatment. So that is the way it works. Please, hope is clear to us.
Please, I have a question.
Okay. Dr.
So
Mariam.
if a patient is coming in, let's say at 18 hours, and he went to the mountain, blah blah blah. So the option would be to remove the tick, right, and
Yes.
observe, or you
Yes.
treat with the cycling.
So you because that's 18 hours, it's not up to 36 hours. So you
It's
can
six.
just observe.
Yes.
You can just observe, right? So if the
Okay.
erythema rash, erythema migrans develops, give your doxycycline or your amoxicillin. Do you understand?
Okay.
If the
Thank
rash,
you.
if the rash have not developed after the 36 hours, then start your prophylaxis with your doxy.
Uh,
Do you understand?
okay.
That's the way it works.
Yeah.
So I think I have like a question. I thought I have a question. Okay. A 24-year-old man comes to the
So we
emergency
can still
department.
give the
Eh?
hello, Dr. Babu. You say for a child that is less than 8 years old, you can
Yeah.
still give a short course of
Mhm.
Hi.
Please, anybody can hear Dr. Antonia. Dr. Antonia, the network is
Hello?
from your own, no, not from my own side.
Yeah, I can hear you. I can hear you.
So what did you say?
I said for a child that's less than 8 years old, you can still give doxycycline short course if they come with
Yes.
the clinicals.
Absolutely.
Yeah?
Absolutely. Yeah. Yeah.
Okay. Okay.
So let's quickly look at this. I don't think this is related, but let's see if we can remember. Let's just look at it. A 24-year-old man comes to the emergency department due to few hours of fever with rigor, headache, and myalgia. While at urgent care center last night, he was diagnosed with syphilis and received a dose of intramuscular penicillin G. So, the patient has a history of HIV, CD4 count 540, not taking ART. He continued to have unprotected sexual intercourse with multiple partner. He does not smoke, no alcohol intake. Temperature is elevated, blood pressure is low, pulse is elevated. Patient is diaphoretic and appears uncomfortable. There is a diffuse faint macular rash involving the palm and sole. Genital examination shows a non-tender ulcer with induration and several enlarged inguinal lymph nodes, which often is the most likely cause of the patient's current condition. Anybody. This is not related to what we have
Is
done.
this this
Penicillin.
Jerry Hirschman
Yeah, so that
reaction?
is a
I'm
Jerry-Rivan
not
reaction. You can see that he's having syphilis. He had penicillin. There's lysis of those organisms,
oh,
and that's the reason why he's having the fever, the chills, the rigor with the hypotension. It's like he's already having shock
oh,
already. So
yeah.
So that's rapid lysis of the spirochete. So that's just by the way. So the
Okay.
reason why I put it is because this can also occur with Borrelia. True or false?
True, because the
It
spirochetes.
is a spirochete. You don't have to be. You see, that's just the way USMLE will just set questions because it's based on understanding. So it has to be spirochete. Any of the spirochete, Borrelia, syphilis, all of them, leptospira. It could be leptospira that will be there. So same mechanism. A 20-year-old woman comes to the office due to headache, fever, myalgia, fatigue. She has no known sick contact. The patient recently returned from a summer internship as an herborist at a New Jersey nature preserve. She has a monogamous sexual relationship with her partner and she uses an intrauterine device for contraception. Temperature is elevated, blood pressure is normal, pulse is normal, oropharyngeal examination is normal, no cervical lymphadenopathy is present. There is a 4 cm flat annular lesion on the right lower abdomen with no scaling raised border in duration of prevalence, which are following is the best next step in the management. I'm not sure, maybe they showed us the rash. Okay, so this is the rash. And we have this question. So, what are we going to do? Anybody?
Oral doxycycline.
Why? No catch. No
Because
catch.
It's still
the
like
rash,
clinical
like the rash is already there now.
clinical
And they
stage.
didn't give us timing actually. They didn't mention anything like timing.
Do we even need
Not
time?
the time actually, just
Dr.
Yeah,
the
Dr.
exactly.
Miriam, do we need time? We don't need time.
No.
What we are
there's
seeing
no
the
time.
rash. We are seeing the rash. So what does that tell you?
Stage 1.
That is stage 1. That is stage 1. So you are not seeing anything related to stage 2 or stage 3. So this stage 1, your diagnosis is clinical, right? And the next thing you do is what? To give your drug. So if they told us that this person is having arthritis or this person is having heart block, what would you have done?
Ceftriaxone.
Exercise.
Okay, ceftriaxone.
Oh,
What if?
serology. We do serology.
Yes. So you do your serology, starting with your ELISA, right? Then
Yeah,
you proceed to do your what? Your
Western.
Western blots. So with positive, start your treatment. Very easy.
Mm.
So let's see. Um, I think this one is still testing the medication. Okay, that's not. So this man is pregnant now. So what drug are we giving?
Amoxicillin.
Amoxicillin. Okay. A 28-year-old woman comes to the office due to an episode of lightheadedness followed by a syncopal episode. She has had several days of headache, malaise, and myalgia, but no vomiting or diarrhea. Patient has no history of similar symptoms. She was diagnosed with chlamydia cystitis 3 weeks ago, and she took 1 dose of azithro. The patient has no chronic medical problems or no family history of sudden cardiac death. She lives in rural Massachusetts and she has not traveled recently. Temperature is 37, blood pressure is okay, pulse is low. No orthostatic blood pressure changes are present. Cardiopulmonary auscultation reveals no heart murmur. The right thigh has 2 erythematous skin lesions. ECG shows sinus reading with 2 to 1 atrioventricular block. Which of following is the most likely cause of this patient's current condition? So which one are we picking? Spirochetes?
Spirochetes.
Yeah. Okay. But we'll get the gist.
Yes.
So let's be very careful with the stage 2 and the stage 3. Stage 1, clinical, start your treatment. Stage 2, stage 3, you might need to do some investigations. So you can see, I'm not the one. Early disease presented with consistent symptoms and exposure risk factors should be diagnosed with serology. So don't make that mistake. Don't make the mistake, please. I'm emphasizing it. Now, babesiosis, babesial infection. Very straightforward. We don't have to stress ourselves. The person gets infected with the what's it called? The tick, which is the exotic tick. The exotic tick, release the organism, which is the what's it called? The babesial spirochete, and afterwards, the person starts developing features of hemolysis. Eyes is jaundice, everywhere is yellow. They could have maybe DIC, features of hemolytic anemia, reticulocytosis, and you do your blood work. You are seeing your Maltese cross picture on your smear. That is what? Babesial infection. And one thing they can ask you is, what is the underlying risk factor for this person developing this? So you don't want to forget this triad. Asplenia, majorly. So if the person is having some immunocompromised state, malignancy, or asplenic condition, they can develop the basial infection because the spleen helps to eradicate encapsulated organism alongside with the basia. So anybody that lost the spleen is highly predisposed to developing the issue. So don't forget, hemolytic anemia, jaundice, pallor with your blood film seeing the Maltese cross. You know the Maltese cross, we know it. I don't need to show us again. Think about me, please here. How do you treat? Just remember your AA, your azithromycin and your atovaquone. Your oral azithromycin and your atovaquone. But if it's severe, IV azithromycin. So it's just like people with PCP. If it's severe, what are we using? IV what? We are not following me.
IV Septrin.
IV
IV
Septrin.
Septrin.
Very good. IV Septrin. So same thing works here. I think I have a question. A 32-year-old man comes to the emergency department due to 5 days history of high fever, chills, sweat. Also has malaria, fatigue, and dark urine. What does that tell us? Hemolysis. Patient has no medical history other than splenectomy, risk factor, 10 years ago. He drinks alcohol on several occasions, blah, 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 blah. He went camping on New England, probably where you have some of those tick. It should be maybe the southeastern part of the US or something. And they found 2 ticks on his leg when they returned home. Temperature is elevated, blood pressure is normal, pulse is elevated. There's jaundice, no lymphadenopathy or rash. There's hepatomegaly. Hemoglobin is down. There's reticulocytosis. Platelet is down. Reticulocyte is 12,000 elevated, and you have a elevated bilirubin, right? Liver markers are slightly elevated. Lactate dehydrogenase is elevated. Which of the following will help confirm the diagnosis? Before we even see the option, what's the answer?
Babesiosis.
Yeah. So what investigation will help us confirm?
Smear, blood smear.
Blood smear. So that should be B. Very easy. Very, very easy. Okay. So moving on to Rocky Mountain spotted fever, and that is the one that is caused by Rickettsia rickettii. And the causative vector is what? The American dog tick that you call Demercantor. So Demercantor is a dog tick that transmits Rickettsia rickettii. So tick is Rickettsia rickettii. Louse is Rickettsia.
Proazeki.
Good job. Good job. So Rickettsia proazeki is a louse. Rickettsia rickettii is a tick. So the one we are most likely going to be hurt is the Rickettsia rickettii. You have to know it. Rocky Mountain spotted fever. So spotted fever means you are going to be seeing some spotting like petechial lesions that will start in the hand, in the wrist, and the ankle, and move downward to the sole and the palm, and from there they move to the trunk. You see, once you see that, I don't need to be looking for region. I already know what I'm thinking, because how many regions do I want to cram? It's good to know the region if you can do it. AMVC, Arkansas, Missouri, Virginia, and North Carolina. AMVC, Arkansas, Missouri, Virginia, and North Carolina. So, how do they present? Constitutional symptoms: headache, fever, rash. You see, that is a 3. Headache, fever, and a rash. You now ask yourself, what is this rash? You are now seeing petechial rash involving the palm and the sole. Or they tell you the starting, that is starting from the wrist, starting from the ankle, and is moving to the distal area. What's the distal area to the ankle? The sole. What's the distal area to the wrist? The palm. A rash involving the palm and the sole is likely to be rickettsia, syphilis, or hand and foot disease. But you look at the rash, this one is petechial. I cannot be thinking of hand and foot. I cannot be thinking about syphilis. Syphilis should be macropapular. Hand and foot should be what? What type of rash is hand and foot? Anybody?
Coxsackie.
Yeah. So what type of rash do you expect?
It's I think it's a macro vesicular.
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 This thing should be
Vesicular.
coming towards point because you already know the disease that you are comparing Kozaki with. What disease do you compare Kozaki with?
That's a lot.
I know. But you see,
That's a lot.
the reason why I said that is there was already a patterning to the way we learnt that stuff. You get? There's already a pattern to the way we learnt it. Coxsackie goes hand in hand with another infection. What infection is that? Eh? Hello?
Pharyngitis.
No. We said that infection, we said that, one is anterior, the other is posterior. Like once you see vesicle in the mouth, just
HSV.
HSV,
Vesicular
HSV.
infection.
You see, once you have a pattern into your learning, there'll be so many things that you'll be able to retain. I'm serious. So Coxsackie and HSV, both of them they are together. Just the position. One is posterior, one is anterior. So you are expecting vesicular rash. So because the nature of the rash will help you. So but take a rash, palm and sole, think about Rickettsia prowazekii, empty Rickettsia rickettii. So it can also progress to DIC, and it can affect the brain, meningitis causing other cells, or even encephalitis. So it is a clinical diagnosis. So if they tell you what is the next step after they have described the symptoms, the person had to travel to all this area, had fever, the rash, which is particularly, they will show us a picture, headache, and the rash started in the ankle, the wrist, and moved to the palm and the sole. And the next thing is, what do you want to do? What do you want to give this patient? I've said it, rickettsia. What do you give?
Doxy.
You give Doxy. Or they can ask you, what is the best next step? So what is the best next step? Anybody?
Mm.
The diagnosis is clinical. You do nothing. Do you understand? So most of the time it's clinical diagnosis. But sometimes if you want to confirm, you might need to do biopsy. But we want to be biopsying everybody with rickettsia? No. But if they tell us that, how do you confirm? You cannot go for biopsy or your indirect immunofluorescence. But put at the back of your mind that your diagnosis is clinical diagnosis. It is a clinical diagnosis. So you give your empiric therapy with Doxy. You don't even wait for your biopsy or your anything. You start empirically with your Doxy, right? So because it's fatal if it's not treated, it can lead to encephalitis or meningitis. So if the person is pregnant, you can use within the first 2 trimesters of pregnancy, because you can use Doxy in pregnant people. So you administer chlorphenicol. If it's not available, just use your Doxy like that. So that's the way it works. So another that we have here is, okay, I thought I have a question. I don't have a question. Infectious mononucleosis. So infectious mononucleosis is very easy to identify. The question is just going to paint a situation of somebody within age of like 5 to 15 years. Most of the time they are males 5 to 15 years, adolescents, that develops fever, develops fatigue. Please, fever and fatigue with pharyngitis. You now look at this pharyngitis. Is it exudative? Yes. Okay. There's tonsillar enlargement too. They now tell you the next thing I will do is to look at the abdomen. Is there hepatosplenomegaly? Once there's hepatosplenomegaly, just be deleting gas or whatever stuff we are thinking of, because gas will not cause hepatosplenomegaly. So once you are seeing the fever, the sore throat, the fatigue, maculopapular rash, cervical lymphadenopathy with hepatosplenomegaly, think about infectious mononucleosis. Look at the age. It's not somebody that's elderly. It is just 5 to 15 years. Think about infectious mononucleosis. They can also cause bilateral upper lid edema just from the inflammatory response. Older people, they can have mesenteric hepatinitis mimicking appendicitis. Not very important. Don't forget, people with infectious mononucleosis, sometimes the patients might think this is gas infection, and the person will use amoxicillin. And if you use amoxicillin, for a patient that has infectious mononucleosis, there's a likelihood, that the individual is going to develop a rash. So that's another way the question can come. Person is presented with, infectious mononucleosis, thinks it's gas, and uses, amoxicillin and develops a rash. So that further solidifies your diagnosis. Okay. So these are the differentials. The most important one here is CMV. That's the most important one here. So what is your best next test? So the best next test is to do your heterophile antibody or your monospot testing. So it may be negative in the first few weeks after your symptoms begin. So if you are doing it too early, you can confirm with your HBV specific antibody test. So if you suspect somebody having infectious mononucleosis and you did your heterophile antibody test, monospot test is negative, you can do HBV specific antibody. So if it's negative, okay, you cannot think of something else, right? You can think of something like CMV. It could be CMV infection. It could be HIV too, acute HIV. I'm going to talk about acute HIV shortly. So if you do your blood film, what are you going to see? You are going to see, because Epstein-Barr infects your B cells. So there's hyperproliferation of your what? Your B cells, because it gains entry through the CD21 on the B cells. But you are going to have abnormal differentiation of your T cells. They become atypical, they are enlarged, and they try to attack those B cells. So as you are seeing your relative lymphocytosis, which is what? Elevated B cells, you're also going to be seeing atypical T lymphocytes that are going to be looking irregular and enlarged. And at least there'll be like 10% of the total, T cell counts. So that is suggestive of infectious mononucleosis. So because of the affectation of the liver, there could be elevated transaminase level, elevated alkaline phosphatase, and total bilirubin. So don't forget, the infection is basically B cell proliferation. So people make that mistake. They just remember the atypical lymphocytes and they think that, okay, it is a T lymphocyte that is hyperproliferating. No, it is a B lymphocyte that is hyperproliferating. But you have abnormal differentiation of your T lymphocyte trying to attack those B cells. So how do you treat? There's no antiviral that you give. It is supportive. It is supportive. So there's some indication for use of corticosteroid, and the way me I've learned it is to what? Have the blood abnormalities at the back of my mind. So HATT. So any blood abnormality like hemolytic anemia or thrombocytopenia, I have to give my corticosteroids. If there's impending airway collapse, airway obstruction from the enlargement of the tonsils, I have to give my corticosteroids. So we remember that Epstein-Barr can be a cause of autoimmune hemolytic anemia. We have done hematology, right? No response.
Yes, we have.
So what antibody do you see in autoimmune hemolytic anemia from Epstein-Barr? Anybody?
What antibody?
Mm-hmm. Do you know? Do you know
It's
what
not,
form of
um, I think IG,
Okay.
IG,
what form? No, this is it.
IgM.
This is what you do. How many type of autoimmune hemolytic anemia do you have?
You have warm
Is
and
it
cold.
the cold and the one type?
The warm and the cold. So
Yes.
which one is associated with Epstein-Barr?
The warm.
Well,
So all those things we are forgetting small. It is the cold, right? So
cold.
mycoplasma, HBV, infectious mononucleosis, and mycoplasma. It is what? It is
It's cold.
the
It's
cold.
cold.
So uh
SLE,
so
malignancies. Yeah.
okay. So I think we'll be doing our revision ourselves. So don't let me delay us with that. So what are the
Sorry, Dr. Baba,
complications?
when heterophile antibodies is also positive in CMV.
The what?
The heterophile antibody
Yes.
is it positive in
Okay,
CMV?
in
Yeah.
CMV,
Okay.
no, it is not possible in CMV. They have a negative monospot test. It is only in HPV that your heterophile antibody is positive.
It's
But they
positive.
can present like,
Like them.
yeah. So what are the complications? CNF infection. It can cause meningitis, encephalitis, you know, Guillain-Barré. It can be a cause of tracheomyelitis. I know we know all these things, so we don't need to be worried about it. Can cause splenic rupture. So that's why an individual with infection mononucleosis, tell them to abstain from contact sport for at least 4 weeks so that they don't rupture their spleen. Because once they rupture their spleen, they develop the care sign, which is left shoulder pain. You know that, oh, the spleen is already ruptured, is irritating the peritoneum. That's why we have this referred left shoulder pain. They can cause upper airway obstruction, and that's an indication to use steroids because of the tonsil enlargement. They can have a superimposed bacterial infection, which is gas. They can have fulminant hepatic necrosis because of the enlargement of the liver. It can outgrow the blood supply. There's necrosis. And that's the commonest cause of death in males. So if they ask you, facial mononeucleosis, what's the commonest cause of death? Fulminant hepatic necrosis. They can have autoimmune hemolytic anemia, which is a cold type. IgM is going to be positive. If there's hemolytic anemia, use your corticosteroids. If there's thrombocytopenia, use your corticosteroid. If there's upper airway obstruction, use your corticosteroid. Epstein-Barr is a cause of nasopharyngeal carcinoma. So, moving on to HIV. HIV, we know is an. Do I have any question? Okay, I think I have one question. A 15-year-old boy is brought to the clinic due to fatigue, malaise, fever, sore throat for the past 6 days. The patient has been in bed most of the time, uninterested in reading or playing video games due to tiredness. He has no chronic medical condition, takes no meds, is sexually active and uses condom inconsistently. He does not smoke, use alcohol, temperature is elevated, vitals are okay. Physical examination shows pharyngeal hyperemia with exudates, along with cervical and axillary lymphadenopathy. Breath sound are normal, heart sounds okay. There's mild hepatosplenomegaly. Joints have a normal range of motion. There's no skin rash. A rapid cerebral antigen is negative. Which of all is the most appropriate management of this patient? So, what are we going for?
Refrain from sports,
Yeah,
active sports.
that's good. A 19-year-old man comes to the office due to 2 weeks history of fever, fatigue, and sore throat. There's no diarrhea or rash. The patient has no significant medical history. He does not use, okay, you occasionally smoke and take alcohol, smokes marijuana, sexually active with one partner. The temperature is 39 degrees Celsius. Vitals is normal. Physical examination shows lactosis with white exudates. There's enlarged tender mobile nodes which are palpable along the cervical, axillary, and inguinal chains. Which of the following tests is most likely to yield the diagnosis in this patient? So, what are we
The
doing?
B,
The what?
hetero, the heterophile antibody test.
The retrofile antibody test. So, maybe we should take a break. We'll come back and, do HIV. Okay? So, let us come back by, this is, so let's just come back around 4:05. 4:05. Okay?
All right.
So, for the HIV, we have to remember that it is an RNA virus that has two genomes, two RNA strands, and it can be transmitted sexually and through sharing infected body fluid, maybe from needles, transfusion, and the like. So we need to remember the way the genome looks like. We have the two RNA strands. We have the matrix protein, which is a P17, and the capsid protein, which is a P24. So the one that is of diagnostic value is a capsid protein P24, right? And we have the envelope protein, two major envelope protein, which is what? The GP41, which is a transmembrane protein that spans across the membrane. And the ones that is attached to the outer surface is a GP120, which is docking glycoprotein. So you need interaction of this glycoprotein with the CD4 receptors on the macrophages or the T cells for the HIV to cause infection. So these collectively are known as envelope protein. This is the genome. This capsid protein and the matrix protein are known as the GAG protein. And we have the pole enzymes, which includes the reverse transcriptase, the polymer, the protease enzyme, and the integrase. So we have talked about the genome, the diploid genome of two RNA, three structural gene, the envelope gene, GP120 and 41. GP120 allows attachment to the CD4 plus T cells or the macrophages, and the GP41 allows for fusion and entry. The GAG gene encodes P24 and P17, P24 for the capsid for diagnosis, P17 for the matrix. Then the pole, which are the enzymes, reverse transcriptase, integrase, and protease. So we have to also remind ourselves the function of those enzymes. we know that the reverse transcriptase helps to convert the RNA to DNA, right? So you convert RNA to DNA and you integrate that DNA into the DNA of the host, which is the T cell or the macrophage. So that's what you need the integrase for. Then why the virus is replicating itself, it needs to split the proteins into smaller subunits so that it can form new variants. That's why you need the protease enzyme. So if you inhibit any of these, you can stop the replication, the function of HIV virus, and you can treat the virus. So don't forget that the virus binds to the CD4 as well as this co-receptor, which could be CCR5 or the CXCR4 to cause infection. So it's binding to the CD4 plus, which you see on the T cell and on the macrophage. And after binding to this, it will bind to a co-receptor, which could be CCR5 on the macrophage or on the T cell. And that is basically for any infection. Or it binds to CXCR4. You only find this one, on the T cell, and that's usually for late infection. So anybody with the CCR5 mutation have no issue. Once you have CCR5 mutation that is homozygous, you have developed immunity to HIV because there's no way it can gain entry into the T cell and the macrophage. But if there's heterozygote, so it should just run a slower course. It won't be as rapid as a normal person. So pay attention to the CCR5 mutations. We know the way it's transmitted: sexual transmission, mother to child, blood, via needles or blood transfusion. So that's that. We don't need to be cramming this value. It's of no use. Nobody's going to access. And we should remember that fluid that is non-bloody cannot transmit HIV. So what can only transmit HIV is maybe semen, vaginal secretion, and blood. But anything outside that cannot transmit HIV. Urine, feces, sweat, they do not transmit HIV. You can even kiss somebody with HIV, provided that you are initiating the kiss and the person that's being kissed has the HIV, both of you does not have mouth sore or ulcer, that can allow for bloody exchange. So, how do you monitor this progression? You use the CD4 count and the viral load. So CD4 count is the most important because it's the indication for immunosuppression. It tells you how the disease is progressing, the risk of developing opportunistic infection, and it tells you when you are going to start your prophylaxis against the opportunistic infections, and also informs you about the response to the ART drugs. Your viral load only tells you your response to the ART. Okay, just check it every 3 to 4 months to see how is the person responding to the ART. Are the viral loads coming down? Your viral load also tells you the risk of transmissibility. So an individual with a high viral load has a very high chance of transmitting the virus. So that also offers some prognostic information. Now, what is the stage of HIV? Basically, we have like 3 basic stage, the acute HIV, the chronic, and the AIDS. So now let me just show us this graph in case it's very unlikely because this is not step 1. So, but we never can tell. So it's good to just have a look. So on the y-axis, we have the CD4 and the CD8 count. And on the x-axis, we have the timing, the duration in terms of months to years, right? And the first thing I just want us to look is that focus more on the first thing to look out for is the HIV RNA. Because if somebody gets infected with HIV today, what do we think is going to be present in the blood first? Anybody knows?
The antigen,
Yeah,
the
so
virus. Sorry. Yeah.
I know what you mean. So the genome is what you are going to see for before you see cell conversion. So the RNA is the first thing that will appear. So that's why you are saying that, at the point of infection here, you see your RNA, peaking. So you don't need to cram the way it appears. You don't need to cram it. So if they show you this graph and you're asked to label or just identify a point, you just look at it. Okay, this one that is starting from the point of infection, this is likely to be the HIV RNA. I don't need to pay attention to the way it's going. I'm okay. Now, when the HIV RNA starts replicating, they start attacking which cells? Anybody? The what? The
The
CD4
CD4 cells.
cells.
The
So they
CD4
start
cells.
attacking the CD4 cells. So that means that I expect a drop in the CD4 cells as the HIV RNA is replicating. So I come up here and I notice that there's a drop in this. So this one is dropping from about 1,000, dropping. So this is likely to be the CD4 cells. So you can see that very easy. You don't need to cram it. This is the CD4 curve. This is the HIV RNA curve. Now, after some time, we are going to pass the window period. So, which is the point where after infection, you start developing antibody response. So, the point between infection to the onset of antibody development is what you call the window period. So, and what is the antibody that we are developed that is being formed? So, you are forming your anti-envelope. So, antibody against the envelope, is going to be formed. So, and you see that, after some time from the infection. So now, after about, usually it takes about like maybe a month or so before the antibody starts appearing, right? So we don't have the curve for the P24 antigen. If we have a curve for the P24 antigen, the P24 antigen starts appearing at about 2 weeks. So that one is going to be starting around here. But because we don't have it, which is good for us, the antibody start developing about a month. So the distance between the point of primary infection and the onset of the antibody appearance is what we call the window period. So, and that is about 1 month, and you start having your antibody peaking. So we are not going to call this HIV RNA because it is not peaking at the point of infection. This is peaking at the point of infection. So this is after 1 month. So this is likely to be the antibody against the envelope, right? Then we now look at the CD8 cells. Now, when it gets to a point when the HIV RNA is proliferating massively, it will get to a point that your CD8 plus is now going to respond that, what is this virus that is attacking my CD4 cell, destroying them? Then your CD8 will now come in, spike up in order to attack the HIV virus. Then later, all this replication will now stop. Your HIV RNA will stop proliferating. So to keep a plateau. So that is where you call your clinical latency. So at that point, your HIV is not proliferating as rapidly as it usually proliferates in the early phase. So in the early phase, it proliferates acutely, and that brings about the acute HIV infection. After the acute, it becomes quiescent, quietens, and you have the clinical latency period before it now gets to 8, and you have a sharp rise in the RNA again. So the fate of the CD4 cell is going to keep coming down. That's the fate of the CD4 cell. It will get to a point, your CD8 will play too, but to get to a point, they will be tired of the HIV infection. That's what you call the exhaustion, and they will start dying too. So, and they will fall. So that is the fate of all these things. Now, let us look at the presentation. So within like 2 to 4 weeks after exposure, you have what you call the acute HIV. So in most people, it is asymptomatic, but in some people, they can show symptoms. Now, what are the symptoms you are going to see? I have it here. So I think I have it here. Oh no, I don't have it. Yeah, that is so sad. But I have it somewhere here. No. Okay, so what you just see is just a few weeks, like 2 to 4 weeks after infection, at this point of replication of the virus. So this is your window period from here to here is window period, right? Are we following me?
Yeah.
Yes.
Because this is
Yes.
where the antibodies start developing. Then after that, you have your what's it called? Your acute infection. So about 2 to 4, your acute infection will have started around 2 weeks though. even before your antibodies start appearing, it will have started around 2 weeks here. So, you just have this hyperproliferation of HIV, and the individual start having some non-constitutional symptoms like fever, like sore throat. So that is why acute HIV is part of differential for what? For infectious mononucleosis, because it can cause fever, it can cause sore throat, they can have cervical lymphadenopathy, they can have a rash. You can see all what you have in infectious mononucleosis, except the hepatosplenomegaly. They have a fever, they have sore throat, cervical lymphadenopathy, rash, they are fatigued, headache. They can have some mouth ulcers too. That is why when we are talking about um, causes of this chancre ulcers in GI, HIV is part. They can have painful mouth ulcers, and they can have some, GI symptoms. But the commonest one are fever, sore throat, and the lymphadenopathy with the rash. So once you see somebody that having rash, extend it to the palm and sole, lymphadenopathy, sore throat, think about acute HIV. And at this point, what is classic? At this point, you have abnormal proliferation of the viral HIV RNA. It is elevated, but seroconversion has not begun. At what point does seroconversion begins? Anybody?
After 1 month.
After 1 month. Good job. And your acute HIV begins after 2 weeks. Very easy. Then after the HIV, acute HIV, what next? Your chronic HIV. So it becomes clinically latent. So all these things disappears. But you can have some little stuff like that's when they can develop maybe oral thrush, but somebody can develop oral thrush and people in the external environment don't know. So it's not something that is clinically evident like that. It's only when the person opens his mouth and what's this? So it's not going to be causing like a distress or something. So usually it's asymptomatic for about 8 to 10 years. But sometimes they can develop persistent generalized lymphadenopathy. They can develop thrush, vaginitis, which is candidial infection. That is why candidial causing oral thrush, candidial causing vulvovaginitis, they are not AIDS defining illnesses. Don't ever make that mistake of picking oral thrush or candida vaginitis as a defining illness. You have missed it, because they can be present in somebody with chronic HIV that have not even developed AIDS. So they can develop seborrheic dermatitis. We said it in the seborrheic dermatitis class. We said there's very common in people with HIV, people with Parkinson, right? So that is that. Then later, after like 8 years to 10 years, they will now start developing AIDS. So if you see someone with candidal vulvovaginitis, candidal thrush, somebody that's having oral hairy leukoplakia, don't call that HIV. Don't call that AIDS. You can call it HIV, but don't call it AIDS. Now, so AIDS is now when you have CD4 count less than 200, or any AIDS defining infection. So somebody having AIDS defining infection, the criteria is about 3. So, or your total T cell is less than 14%. So, if the total lymphocytes, accounted for by the T cell is less than 14% of total, or the person is having CD4 cell count less than 200 or any AIDS defining illness, you can say that this person has AIDS, right? I hope you are following. So, that is very, very important for us to pay attention to. And we already know that the CD4 cell count guides us to the possibility of the opportunistic infections. So don't forget about that. So if they don't receive treatment, they die of the complication of HIV. We already know this. So how do you make the diagnosis? These are the stuff you need to know. The first thing you want to do is to do a combination immunoassay, which is combining your HIV antibody and your P24 antigen. Before I go further, it's important for us to remember that we have 2 basic types of HIV type 1 and type 2. Type 1 is worldwide. Type 2 is native to West Africa, right? So if you are doing your what's it called? Sorry, just a minute, please. Just a minute. So if you are doing your diagnosis, you have to combine the antibody test with your P24 antigen combination immunoassay, right? And you check if it's negative or positive, right? So if it's negative, you know that the person doesn't have HIV, you move on. But if it's positive, now, what you should have at the back of your mind is that it can be positive if any one of these is present. It can be positive if the person has HIV-1 antibody, or the person has HIV-2 antibody, or the person has P24 antigen. Now, if you remember the timing, I said the P24 antigen becomes positive after 2 weeks. The antibodies start appearing after what? 1 month. So it means that if we do this thing in someone that has HIV, but the HIV just, developed a week ago, do you think we're going to get a positive test?
No.
For the anti, no,
We're not going to get
no,
antibody. We're not going to get
even for the
positive test for
one,
anything.
no,
Anything.
yes.
So so what I'm just trying to, um, illustrate here is that you need time, at least 2 weeks, so that one of them will be positive. And which one is that? P24, right? And again, another thing I want to say is that you can get a positive test if any one of them is present. You don't have to have the 3 of them or the 2 of them. If anyone is present, you get a positive test. So that's why you have to move from your combination immunoassay to your differentiation immunoassay to know what you are dealing with. And there are 4 different possibilities. You can have positive HIV-1 antibody, negative HIV-2 antibody. So if you have positive, so that means that what you are dealing with HIV-1. You can have negative HIV-1, positive HIV-2. It means what you are dealing with is HIV-2. You can have positive for both. It means both of them is present. Excuse me. And you can have negative for both. So if we have negative for both, what do we think is happening here? Anybody? And I just want to see the way we are following. If it's negative for both, what do you think is happening?
There is no serial conversion yet.
Okay. And what brought us here?
Um, positive P24.
Yeah, good. That's very good, Dr. Antonia. So it is a positive P24 that is bringing us here. But it doesn't still mean that this person doesn't have HIV. So what do you do straight? You just do your HIV-1 NAT because this one is the best. Because this one doesn't work with time. Because we have said it that once somebody gets infected with HIV, immediately RNA will be present. So just go and do your NAT to check for HIV-1. So if you have a positive NAT for HIV-1, you know that is acute HIV-1 infection. If your NAT is negative, it is likely to be HIV-2 infection. The reason why we don't have HIV-2 NAT is I don't know. It's not yet been developed. So most of the time, you just assume that if you can have a positive combination immunoassay and you're having negative of both of them here for the indeterminate differentiation, it's likely to be P24 antigen of HIV-2 that is bringing you here. So that is if you have done your HIV-1 NAT and it's negative. So you can say that, it's likely to be P24 antigen of HIV-2 that is bringing us here. So you just assume that this person has HIV-2, So that is that. So what's the best next step we have talked about? We have talked about the confirmatory. So, but there are some special scenarios. For example, if you do it early, somebody early HIV infection. So what you do is that you do a combination like this, and you now add your PCR or your NAT with it, because definitely your PCR will catch it. There's no way your PCR will not catch it. So, but the reason why you don't go straight to PCR is because it's very expensive. So you can see here they said it might not be positive until 2 weeks post-infection. But for people that have perinatal HIV, just like I've been teaching it in the step 1, if somebody has perinatal HIV and you want to test the baby, the newborn, you don't go and be doing combination. You have done nothing, because the mother antibodies will have crossed to the baby. So the baby might have the antibodies and doesn't mean that the baby is positive. So what you want to check is that the baby, does it have the HIV genome? And how do you ascertain that? By doing your NAT. So for babies, just do their NAT. If it's positive, they have it. If it's negative, they don't have it. We have talked about the criteria for HIV, for AIDS. Now, the next thing for our step 2 is what? Screening. You cannot joke with screening in your step. If you don't know screening, forget about your exam, because you are going to see a lot of screening questions. You have to have them spinal level. Screening, they don't joke with it, because that's the primary preventive strategy, for infection. So number 1, anybody between the age of 15 to 64 years, regardless of a sexual history, do a one-time screening for HIV. So if I'm 15 years and above, 15 to 64, at least this bracket, do a what? One-time HIV screening. Now, anybody that is high risk for HIV, they have to be doing it annually. Intravenous drug abusers, their own partners. Intravenous drug abuser and their partners, both of them, they are high risk. Do it. Sex workers, of course. Sex partners of HIV positive people. Men that have sex with men. In fact, men that have sex with men, they had the highest body. They carry the highest body of HIV infection in the US. Why heterosexual is in the world, but men having sex with men have the highest burden of HIV in the US. So that is important to know, and you have to do annual screening for high risk patients. Then there are some situations where you have to do routine screening. Now, when we say routine, it means that per event you do it. What is this event I'm talking about? Somebody gets pregnant and comes for perinatal perinatal visit. You have to do HIV screening. It's part of the basic routine test you do. Somebody develops a new STI, syphilis, gonorrhea, chlamydia. You have to PID from chlamydia, gonorrhea, trichomoniasis. You have to screen for STI because the risk of having STIs in them is very high. So I'm going to still show us that table and we are going to see it. I think it's still down. Oh, I have missed it. Okay. So there's a table here. Yeah. So people that have people that are uncircumcised, so a male that is circumcised, they have a very high risk of developing HIV because if you do not remove the prepuce, there's a high chance of friction injury during sexual intercourse. So there's high chance of getting the virus. People that have concurrent STIs, because the area where the STI is going to be flooded with a lot of macrophages. So that individual can easily transmit the infection to another person and can also easily receive new infection. So that is why you screen anybody with STI for HIV. So people with new STIs, screen them. People that come for perinatal screening, that are pregnant, screen them. People that get exposed to infected body fluid, so you get exposed to blood containing HIV, screen yourself for HIV. So all these things happen per event. So get pregnant again after 1 year, screen again. Get new STI again after 6 months, screen again. Get exposed to needle prick injury or body fluid, of someone that has HIV, screen again. So these ones are routine, not the annual one. The annual is for what? The high risk people. So you can see that I'm emphasizing this thing so that we can have an understanding. Very important. So what are the opportunistic infections? There's a lot of them. And I know we already know this from our step one. We don't need to cram anything, we just, have to familiarize ourselves with them. I think I gave us an acronym here, like my happy Kaposi, and that's what I've been using. My happy Kaposi sarcoma. Just remember the first two will always be there when you have CD4 counters and 500. You always have the first two, which is the one that will make create whitish lesion in the mouth. Candidial that you can scrape off, and the ones that you cannot scrape off, which is the oral hairy leukoplakia. Most of the time, don't worry about differentiating. They will give you maybe like histology, like KOH mounting result to separate your candidate. Once you are saying hyphae, regardless of if it's scrappable or not scrappable, pick your candidate. So don't rely alone on the scrappable, the unscrappable. So then my happy, tuberculosis for the man. Tuberculosis, happy, papilloma, human papilloma. So squamous cell, then the HSV sarcoma, we know, how they are going to present. I've talked about it in dermatology. For count less than 200, you talk about the infection affecting the brain and the lungs. The two that affect the lungs is what? PCP and what? Histoplasma. That's the way to just learn it. Histoplasma and PCP. The one that affect the brain, your JC virus, and what? The HIV-associated dementia. They can have HIV-associated dementia and HIV-associated nephropathy. And this is going to cause focal segmented glomerulosclerosis. Then the other ones appear when there's less than 100. Other, just put them other. But there's some specific one. The one that occurs when it's less than 50 is in microbacterium behavior, while the other ones is less than 100. Okay. How do you manage and prevent HIV? So once somebody has HIV, the prognosis is what? You have to take ART lifelong. You don't argue it. You are pregnant, you are not pregnant, you take it. Adherence is crucial because of high risk of persistence. So sometimes you might need to, start genotyping. You might need to do like a resistant testing, which is genotyping, to see if that particular strain of HIV doesn't have some mutations, that can prevent response to some of those medications. So you are going to access the sequence gene for the reverse transcriptase for the integrase and see if there's no mutation before you now know the best drug to start. But you have a standard of treatment. You use two NRT, two NRT hides with an integrase inhibitor. That's the standard. That is the standard, you know. So at the point of diagnosis, you measure the viral load by doing your PCR RNA, and you also measure the CD4 count. Then you now continue every 3 to 4 months. So that's why you see them, they screen them every 3 to 4 months afterwards. And we already know the reason why you are doing the viral load, right? You want to assess response to therapy because you expect it to drop to at least less than 50. So if you're having an increased value or value greater than 50 after 4 months of treatment, you know that you have to change that regimen. That regimen you are using is not working. So your aim is to reduce the viral load or to make it undetectable at least less than 20 per microliter. So once it's less than 20, you can say that, yeah, you have done a good job. And this person has a very low chance of transmitting it. Another reason is because you want to assess treatment as a prevention. So once you are able to bring it to less than 20, you know that the transmission risk is highly reduced. So what is the initial regimen? 2 nucleoside or nucleotide reverse transcriptase inhibitor plus 1 integrase. That is what you want to use. It is superior to the other one, which is the NNRI or your protease inhibitor. So these are all the drugs. We are going to look at them one by one and just focus on the major important part. So we have the NRT, which could be nucleoside or the nucleotide. So the only nucleotide reverse transcriptase inhibitor, which is the one with the T nucleotide, is what? Tenofovir. The other ones are what? The nucleoside. So what's the acronym to remember them? ADELS. ADELZS. So A for abacavir, E for didanosine, E for emtricitabine, L for lamivudine, Z for zidovudine, S for stavudine. And before I move, we have to remember that tenofovir has 2 forms. So we have to be careful. The best one you want to pick is what? Tenofovir alafenamide. That's the best. But the common one is the TDF. Tenofovir disoproxil fumarate. The tenofovir disoproxil fumarate is associated with kidney injury and bone loss. So that's why you want to prefer the other form, which is tenofovir alafenamide. So how they work? They just inhibit the DNA polymerase because they lack the 3' OH group, and it brings about chain termination. I know we remember this from our step 1. I don't need to be explaining that again. So because of the fact that they inhibit DNA polymerase, which is a very important enzyme in the mitochondrial activity, there's failure of the mitochondrial activity and there's lactic acidosis because you cannot do oxidative phosphorylation again. So there's lactic acidosis. It can cause elevated CK, and I have programmed in my mind that whenever I see a favorite, no, sorry, this I'm that thing again. So I thought I was talking about the NS, the other one. So I've programmed in my mind that anywhere I see the danosine is toxic to the nerves and toxic to the pancreas. So the danosine is a cause of pancreatitis and peripheral neuropathy. And anywhere I see zidovudine is toxic to the bone marrow. The danosine is toxic to the nerves and the pancreas. Zidovudine is toxic to the bone marrow. So zidovudine can cause megaloblastic anemia and bone marrow suppression. And we already know abacavir, the hypersensitivity. So somebody use abacavir and start developing rash, GI symptoms, you think about abacavir sensitivity. Then for the nucleotide reverse transcriptase inhibitor, the acronym is TREND. The T stands for nothing. The R stands for ripivirine, but it's not common. It's not very common. The E is very common, which is efavirenz. The N is nevirapine, is very common, and the D is a delaviridine. So I have it at the back of my mind that delaviridine and efavirenz do not ever use in pregnancy. Don't ever use in pregnancy. DE. Don't ever. Delaviridine, efavirenz, don't use them in pregnancy. They are teratogenic. And anywhere I see efavirenz, I don't want to use it in pregnancy. And I know that it can be a cause of neurologic problems, anxiety, insomnia, vivid dreams, confusion, mood changes, depression. Efavirenz is implicated. Don't forget, efavirenz and delaviridine are contraindicated in pregnancy. So what is common to all of them, the trend, is that they are hepatotoxic. All of them, they're hepatotoxic. And they can have some effect on cytochrome P450 mechanisms. So they are hepatotoxic. They can cause rash, Steven Johnson rash, hepatotoxic, and they have some specific ones, which is the pregnancy and what the CNS problems. So the way they work is they bind to an allosteric site of reverse transcriptase. They bind to allosteric site of reverse transcriptase and inhibit it. Unlike this, that affect DNA polymerase. But sorry, they affect reverse transcriptase inhibitor too, but they don't bind to the site. So they can affect DNA polymerase too. That's why they can cause bacterial mitochondrial toxicity. But for their anti-HIV effect is more of the reverse transcriptase inhibition. So I know we know it. They forcibly, incorporate these drugs into the HIV forcibly incorporate this drug into the chain and is going to terminate. But this drug, they will directly go and bind to another site of reverse transcriptase and inhibit it non-competitively. So that is that. So for the integrase, you just want to remember the gravine, the ratigrave, the luchgrave. Once you see that, that's integrase. And they prevent integration of the DNA into the whole cell DNA. That's just it. Integration of the viral DNA into the whole cell DNA. That's what they stop. And they have a very peculiar side effect of weight gain. The protease inhibitors are the Navil, the Pinavil, Indanavil, Ritonavil, Saquinavil, and the likes. And of course, they prevent the protease effect. And once you take out the protease effect, you cannot cleave new virions. So there will be immature virions. That's the stuff. The HIV virus cannot mature to form new progeny. So it can cause hyperlipidemia, it can cause hyperglycemia, leading to insulin resistance. And we have some specific side effects for each of them. Like, for example, Indanavil can cause stone, crystal-induced nephropathy. You don't want to forget that about Indanavil. Indanavil is a cause of stone, nephrolithiasis. And okay, generalized a general side effect is what? The insulin resistance and the lipodystrophy. So you don't want to forget that. We have the entry inhibitors. So two major drugs in the M3 entry inhibitors, the miraviroc and the enfuviritide. So miraviroc inhibits docking. Enfuviritide inhibits viral fusion. So enfuviritide, fusion, enfuviritide. And what is the protein involved in fusion? GP41. So enfuviritide binds to GP41 and prevents fusion. While miraviroc inhibits CCR5. It inhibits CCR5. So there's no way you can dock, the HIV virus on the CD4 cells to gain entry. Then we have the boosting agent. So boosting agents are just agents that you use to prolong the half-life of the other drugs. For example, cobicistat and some protease inhibitors like ritonavir, because they inhibit CYP3A. So it means that once you use a drug with ritonavir, or once you combine a drug with cobicistat, or once you combine a drug with saquinavir, This ritonavir and sacubitril are protease inhibitors. So once you combine any drug with them, that drug is going to have a prolonged activity because ritonavir and sacubitril is going to inhibit CYP3A and it will prevent this CYP to metabolize those drugs and they will stay long, working. So what is immune reconstitution syndrome? This is just a situation in which you start your heart and you have a boosting of an improvement of your immune system, and this causing like a flare-up of some underlying opportunistic infection. And what are these 3 opportunistic infections you have to know? Cryptococcus, mycobacterium meningitis, and CMV retinitis. So if you suspect anybody has HIV and you have ruled out this infection, you can start your heart. But if they have any of these infections, you must treat this infection first. At least start your treatment for this infection for 2 weeks before you initiate your heart, so that you don't trigger the immune reconstitution syndrome. Because if you don't do that and you give the person the heart and the heart improves the immunity, the CD4 cells start rising. That can, mount an attack on this, and you are going to have a flare of this presentation. So the person is just going to start presenting with cryptococcus, presenting with TB meningitis, then with CMV retinitis. So the approach is to wait. You start the treatment for this first before you start your heart. That's important for us to remember. So what are the prophylaxis? So NPHCT. We might not need this acronym, to be honest. It's not really very important. What I'm just going to say is that it is only 2 of these 5 that you need to screen for serology before you start treatment. For the other ones, once you see the CD4 count is less than a particular level, start their treatment immediately. So when it's less than 50, we already know the mark. This one is basic. Once it's less than 100, toxo. It's less than 150, histoplasmosis. Less than 200, PCP. So we have been saying this PCP for a long time. PCP is less than 200, toxo is less than 100, mark is less than 50. Then coccidioidomycosis is less than 250. So the ones that have the 50-50, apart from mark, are the fungal. So coccidioidomycosis is less than 250, histoplasmosis is less than 150, PCP is less than 200, toxoplasmosis is less than 100, and your mark is less than 50. Now, the ones that you need to screen for your serology before you start anything is your CT. So you need to do your CT scanning for your serology before you start their treatment. So CT scan for coccidioidomycosis for the C part and the T for the toxoplasmosis. So you scan for their serology, obtain IgG for toxo, obtain IgG or IgM for coccidioidomycosis. If it's positive, then you can now start your prophylaxis. So for coccidioidomycosis, you give fluconazole. For toxo, you give what? Anybody remembers what you give for toxo? Prophylaxis.
Sulfadoxine pyrimethamine.
What?
Sulfadoxine pyrimethamine.
Sulfadoxine pyrimethamine. Good job. But if you want to treat, what do you give?
Azithromycin.
If you want to treat it, what do you give?
Trimethoprim sulfamethoxazole as well.
No. So if you
Septrin.
confirm that the person has HIV and the person you have confirmed the diagnosis of toxo, what do you give?
Trimethoprim
You treat
sulfamethoxazole.
sulfadoxine.
Azithromycin.
No. You see, if you are giving prophylaxis for toxo, you give your septrin. It's trimethoprim sulfa. But if you are not giving prophylaxis, but you want to treat because you have confirmed that toxo is there and you want to treat, what you give is sulfadiazine pyrimethamine.
I thought it was the other way around. Yeah.
So you are not giving trimethoprim sulfamethoxazole. It's not septrin. Do we get it?
Yes.
Yeah.
Very important you keep that.
Do you say you do a CT scan before
No,
the
the CT that I'm talking
serology.
about is just to allow you remember. So what I mean by CT is just the acronym
Serology.
CT,
Oh,
coccidioidomycosis and toxo.
okay.
And this the screening you are doing is what? IgG or IgM. So if it's positive, then you now know what to do. And don't forget you are giving fluconazole for coccidio. For toxo, you are giving what? Septrin. So now the prophylaxis doesn't stop here. That's a mistake I myself make sometimes. The prophylaxis doesn't stop here. The prophylaxis continues with your vaccine, right? So if an individual has CD4 count less than 200, of course, you are not going to be giving the live vaccine like MMR, varicella. You are not going to be doing that. You're only going to start this if it's more than 200. But if it's still less than 200, you can start some other ones, which is what? Your pneumococcal. You can never forget that. Pneumococcal. If you remember when we were talking about indication for pneumococcal, we said, anybody remembers them? Anybody remembers part of it? Or we have forgotten? We have
What's your
forgotten.
question? What's your question? I didn't get your question.
So, like I was asking for the indications for
No, no.
pneumococcal
What's
vaccine.
your question?
Pneumococcal vaccine indication.
Okay. As
Asplenic
clinic
patient.
patients,
Okay.
um, cochlear implants,
Very
CSA
good.
greater than 65.
Very good. Very
Mhm.
good. Age less than 5. Age greater than 65.
Yes.
Cochlear implants.
5 years, yes.
Um, basal skull rupture.
CSF leak
CSF
as
leakage from basal skull rupture.
yeah.
Asplenia, immunosuppression. You get,
Mm-hmm.
you give them pneumococcal. Influenza too is similar. Chronic infection and immunosuppression. You give them annual influenza. Meningococcal too, and of course hepatitis A and B. So all these ones that I have highlighted, they are important. So in addition to all this, you have to give your vaccines. Don't forget. Do not forget. Now, your PEP is in two forms. When you say PEP, when people just mix them up, it means two different things. It can be pre-exposure or post-exposure. Now, if you are using pre-exposure, that what you are trying to do is that you know that what you want to do is going to make you get exposed to HIV, right? So and you are using the drug, so you call that the PEP. Now, the drug you are going to be using for PEP is different from post-exposure because in post-exposure you get exposed unintentionally. So you are going to be using different drugs. You are using lesser drug if it's PEP from pre-exposure compared to the post-exposure. So, but in the pre-exposure, you are prepared. So, what you are using is your tenofovir M3-citabine combination. So, what class of drugs are these ones?
Non-nucleotide reverse transcriptase.
The what? Non-nucleotide? Did you say?
The nucleoside.
Yeah, these
Yes.
are the nucleotides.
Yeah. Tenofovir M3-citabine.
So, tenofovir is a nucleotide.
Okay, yeah, yeah. It's nucleoside.
Tenofovir is a
Mm-hmm.
nucleotide. M3-citabine is a non-nucleotide. Is a nucleoside. Tenofovir is a nucleotide.
Nucleoside.
M3-citabine is a
Nu-
nucleoside. Now, I've said it before we start. I said that the standard regimen is to give a 2 NRT with an integrase. That is your standard regimen. So if you want to give pre-exposure now, you remove your integrase. So you just give your 2 NRT, and the 2 is tenofovir and M3-citabine. Now, what are the indications for your pre-exposure? Somebody that wants to, indulge in high risk behavior, having sex with somebody, you are HIV negative, you're not having sex with somebody that is HIV positive, sex workers, or having HIV positive sex partners, you know, male having sex with male, intravenous drug abusers, and all these people, they are what? They are HIV negative. So that's an indication. So if you are the person that takes drugs intravenously from time to time, you can be using your PEP. You are the type that have sex with male, so per intercourse, be taking your PEP. If you are going for sex work, be taking your PEP. If you want to have sex with your HIV infected partner, be taking your PEP. So that's the way they designed the pre-exposure. Now, the regimen is tenofovir and emtricitabine, which is taken as long as the indication is met. So it means that if you want to continue with that activity till Jesus come, they will be taking it till Jesus come. That's the way it works. So don't forget, and don't forget the side effect of this combination, the disoproxil fumarate. It can cause what? Bone loss and what? Anyone there? Oh, we have slept. Hello?
Kidney injury.
Kidney injury. So the tenofovir alafenamide is the one that is safer. So now moving on to the post-exposure. So for the post-exposure, it's just like normal accident. Probably somebody just had sex with somebody that has HIV and the person did not even know that the person, is having sex with has HIV. Maybe mistakenly they did not use condom or something, or they get exposed to needle, just accident that's not intentional. Think about those things. So that's when you need to use or you get splashed by blood that causes HIV, so you have to take your post exposure. And that one is what? Your tenofovir emtricitabine, but you are adding your integrase to that one. You can see the difference. So what you just do is that you test that person. So once that accident happens, test the person immediately to know the HIV status. Commence the medication for 28 days. That's your PEP. Then after 6 weeks, repeat the test. Then repeat after 3 months. Post exposure. That is the way. So these are another point that they wait for us. And if you see this in your exam, you should be smiling. Other people will be sweating. You will be smiling. Perinatal transmission of HIV because you are going to see it. So what you just want to ask yourself is that how many load does this mother have? What is a viral load? That's what you use to partition it. Is it less than 100? Is it more than 1,000? You see, once it is more than 1,000, just go and do CCR. Like, don't listen to any registrar. Don't listen to any consultant. You just tell the consultant, sir, I want to section this woman because this woman has viral copy of 1,000. You'll be correct anywhere in the world. Once the viral copy is more than 1,000, do a cesarean section. If the viral copy is less than 100, you can try vaginal delivery. So trust me, they are not going to put you in between. It's going to be anyway. But if it's less than 1,000, you can still do vagina. You can still try vagina. But it is absolute indication for CS when it's more than 1,000. And you are safe to do vagina when it's less than 100. So that's the first thing you want to look at in the question. What is the viral load of this mother saying? Now, that is the first thing, to look out for. And I want to be sure that I'm not looking at so and if the viral copy is less than 100, you don't give the mother IV intrapartum zidovudine. You don't administer any intrapartum medication again. But if you are doing a cesarean section and the viral copy is more than 1,000, you have to also give the mother IV intrapartum zidovudine. So very, very important. Now, what is now going to determine if the newborn is going to determine how and how much the newborn is going to receive depends on the viral copy of the mother as well. So you have to have it at the back of your mind that once the mother is HIV positive, regardless of the count, that child that they wants to deliver will get a drug. There's no escape route. Even if the count is 2, the child will still get something. The child will still get something. But if the mother count is less than 100, do your vaginal, don't give intrapartum zidovudine. If it's more than 1,000, go on section, give intrapartum zidovudine. For the child, you now separate. Is it less than 50? Is it more than 50? If it's less than 50, it means that the child is not going to be taking a lot of drug. Just give the child zidovudine for 4 to 6 weeks after birth. But if it's more than 50, you have to give the child New Zealand. So the child has to go to New Zealand once the copy is more than 50. I mean in the mother, not in the child. So once the viral copy of the mother is more than 50, the child has to go to New Zealand, which is what? Taking N, Z, and L. So you are giving your nevirapine, you are giving your zidovudine, and you are giving your lamivudine. So they will say that you can give a 2 or 3 drug combination. So either you give maybe nevirapine and zidovudine, or you give nevirapine, zidovudine, and lamivudine. Anyone you want to give. Please, is this algorithm clear to us?
Yeah.
Yes.
Good job. So the key fact here, I don't want to skip them. Peak exposure prophylaxis. I have mentioned the drug is just 2 drug that you are giving. And you want to give the tenofovir alafenamide because less risk of kidney injury, less risk of bone loss. So it's very effective in people which engage in high risk, practices like IV drug use, male having sex with male, and anybody having mononucleotide syndrome that is having a very, very terrible sexual history, consider HIV screening. That's it. Consider HIV screening. Now, you have to give everybody with HIV lifelong antiretroviral drug, regardless of the CD4 count. Okay. I think maybe we should take another break, or let's solve question before we take a break. Let's solve question so that we can consolidate what we have learned. I think I should have some questions. A 35-year-old man comes to the employee health service 30 minutes after a work-related incident. She works as a phlebotomist, and she reports that blood splashed into her right eye when she was drawing blood from a 30-year-old male patient. Immediately following the incident, she flushed her eye with water for several minutes. The patient from whom she drew the blood was admitted for multisystem, weight loss, and night sweats. He is an intravenous drug user and is sexually active with several male and female partners. Do you think that person is an high risk?
Yes.
The phlebotomist
Yes.
has no history of serious illness and takes no medication. Her immunization are up to date. Physical examination shows no abnormality. In addition to drawing her blood for viral serologies, which of the following is the most appropriate next step in the management? So what do you want to do for this patient?
Post-exposure prophylaxis.
Post-exposure
Hello.
prophylaxis.
Yeah.
Very good job. So
Yes.
which one are we now giving?
The first one.
The first one.
The first one,
Good job. So
two
so after you have
narrative
given
and it.
the post-exposure prophylaxis, what next do you now do?
You monitor with
HIV testing
because,
after.
yeah, at
You do
6 weeks
your HIV
and
testing.
reports.
So you do
Yeah,
HIV testing on the spot. You
before
do
you start, yes. Then
you
6 weeks after, and
then
then
3 months.
3 months after.
Good job. A 28-year-old man is brought to the emergency department by his partner because of 12-hour history of increased drowsiness. During the past week, he has also had fatigue and headaches. So drowsiness, fatigue, and headaches. No history of serious illness. Takes some medication. Is very lethargic and ill. Fever is present. Vitals normal. There is cervical axillary and inguinal lymphadenopathy. Neurologic examination shows no focal findings. Hemoglobin is okay. Leukocyte is okay. CD4 count is 42. An MRI scan of the head shows enlarged ventricles, bilateral gelatinous pseudocyst at the basal ganglia, no mass lesions. A lumbar puncture is performed and a cerebral spinal fluid staining with mucicamine shows organisms with prominent red capsules. Screening and confirmatory test for HIV are positive. Which of the following is the most appropriate next step in the treatment of this patient? Anybody?
You start the patient on antiretroviral, um, antifungal, and antiretroviral. You have to treat the fungal infection.
So, you know that, Dr. Antonia, I said it. Like, once you have the question, interpret whatever findings you are seeing. They said a
Mm.
lumbar puncture is done and shows mucicamine, shows organism with prominent red capsule. What is that diagnosis there?
That's in cryptococcus.
That is
That's good.
Cryptococcus. Now, I gave us three organisms: Cryptococcus, CMV retinitis, and tuberculosis. And I talked us about the what? The immune reconstitution, you know,
Syndrome.
syndrome.
Yeah.
And I said, what?
You
What are you
treat
going to do
Yeah,
first?
you
you need to
treat
treat the
first for
infection
2 weeks before you start
before
Exactly.
harm.
ART.
Yes.
So, what's the
To
best answer
avoid
to pick?
infections.
So, what's the best answer to pick?
Antifungal therapy only.
Antifungal therapy.
Antifungal therapy only. Very, very important stuff. Please let us pay attention to it. Okay? So,
You're rushing today.
the what?
You're rushing today.
I'm rushing.
Hmm.
I'm not rushing now. If I took my time to explain it, Dr. Antonia.
Yeah, you do, sure.
But I said, okay, that was why I was asking, do we understand? So that if there's any part
Hmm.
that is not clear, you know, I just want us to finish everything in the video. So,
Okay.
so, uh, I think maybe we should go for a break and we meet by, this is 5:05 my time. Let's meet by 5:20, right? Is that okay?
Okay.
Okay.
Yes.
Okay. Um, so moving on to cytomegalovirus. It's important for us to remember that this guy is very common in people with HIV, and um, it usually causes problem in people that have immunocompromised state, you know, and um, it can be transmitted through any body fluid like sexual contact, breast milk, organ transplant, anything. So it's very common in people that undergo some form of transplant or people with HIV/AIDS, particularly when their CD4 count is less than 50 and their viral load is as high as 10,000. Um, there are a lot of clinical presentation that you can have from CMV infection. CMV retinitis is one of them, in which on fundoscopy you are going to be seeing the pizza pie appearance. And we said we are going to be seeing areas of hemorrhage sandwiched with fluffy opacity. So once you are seeing opacity with hemorrhage, that's a pizza pie appearance, which is classic for CMV retinitis. It can cause GI and hepatobiliary involvement. And what I just want us to have in mind is if you see anybody with some background immunosuppression having bloody diarrhea, just go and pick CMV. It can cause linear ulcers, in the esophagus. It can cause pneumonitis, which is one of the common cause of death in people that are immunosuppressed. And don't forget the cough is going to be not productive because this is not a typical cause of pneumonia. It can affect the CNS and they can have transmyelitis, they can have encephalitis. Please, I don't have time. I would have loved to talk about transmyelitis, but please, if you don't know transmyelitis, go and look at the way it presents. It can destabilize somebody. If you don't know it, you don't know it. If you know it, you know it. So, um, it can, be associated with periventricular calcification. So pay attention to all those pattern of calcification. Once you are seeing periventricular calcification, just go and pick your CMV. Once you are seeing subcortical calcification, think about your Zika. Intracranial calcification, think about your Toxo. What do you see on biopsy? Just a large eosinophilic inclusion, whole high appearance. That's classic for CMV infection. Just treat with your ganciclovir or your valganciclovir or foscarnet. You don't want to use foscarnet in people that are having renal issues. Yeah. So moving on to central line, arterial bloodstream infection. Do I have a question here? I think I do. Okay. So, a 45-year-old woman comes to the emergency department due to 3 days history of fever, malaria, difficulty in breathing on exertion, dry cough, abdominal pain, and watery diarrhea. Okay. Our loose stool this morning were accompanied by bright red blood. patient underwent halogenic renal transplantation 6 months ago and is currently taking tacrolimus, mycophenolate, bread. 2 months ago, she developed severe leukopenia that resolved later after discontinuing Semtrin and valganciclovir. She does not use tobacco or alcohol. Temperature is elevated. Vitals okay. Physical examination shows bilateral lung crackles and diffuse abdominal tenderness. Gross blood is seen on rectal examination. Lab as follows. Okay. So analysis is normal. Chest X-ray reveals bilateral interstitial infiltration. Which of the following is the most likely cause of this patient's current condition? So what are we picking?
CMV.
CMV. Why?
There's a history of transplant in this patient.
Good.
Also, sometimes I had loose watery soda, I had black red blood.
Exactly.
They
So don't
also
get
have lung infections too.
exactly.
Signs of lung infection on the
So some
patient.
people will have thought that okay, bilateral lung, right, blah 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 blah. They will have gone for PCP, right? But what we explain the blood stool, right? So your CMV can explain both. A previously healthy 28-year-old woman comes to a physician because of low abdominal pain and prolonged vaginal discharge for the past 5 days. Menses occur at irregular interval. She is sexually active with a new partner who she met 3 months ago and they use condoms inconsistently. She had a normal pap smear 5 months ago. She drinks beer every other day. Temperature is elevated. Examination shows low abdominal tenderness and bilateral inguinal lymphadenopathy. Pelvic examination is notable for adnexal and uterine tenderness and small amount of bloody cervical discharge. Lab shows leukocyte count of 14,500 and ESR of 90. A spot urinary pregnancy test is negative. An endocervical swab is obtained for NAT. The patient is started on ceftriaxone, doxy, and metronidazole. Which of one is the most appropriate next step in the management? Okay, let's see the option. Yeah. So, do we get the history, or I should show us the question again?
Yes, you said the history of a new partner, right? Abdominal pain, vaginal discharge, um, sexual partner 3 months ago, inconsistent use of condom, um, HIV screening, because there's possibility of STI, so you need to screen this patient for HIV.
Okay, please, 1 minute. Dr. Olushola, yeah. So, so sorry about that. Please, I'm very sorry about that. So Dr. Antonia, what's your conclusion?
HIV screening
HIV screening.
testing.
So why? Can you tell everybody so that we can all learn from you?
There's possibility of STI in this question from what they showed.
Good job. Good job. You're applying the concept. So I think everything is just, related. We can just solve a lot of questions. We don't really have much time. So the central line associated bloodstream infection, it's not very complex. It just means that somebody develops infection 48 hours after central line placement. That's what it means. And it's very important for us to know the two types of the central lines that we have. The tunneled and the non-tunneled. The tunneled. Please, just 1 minute. Hello everyone, I'm very sorry about the interruption. Please, I'm so sorry. So don't forget the fact that the lines, they could be tunneled or they could be non-tunneled. So and they can be placed at different sites. You could place them at the femoral, the jugular, and the subclavian. And the one that is most associated with the risk of infection is femoral because that is closer to the pelvic region. I think that's the most important point you have to pick. And we also have to be familiar with the organisms involved. So you have to think about the gram-positive that are very close to the skin, like the coagulase negative staph and the staph aureus. So staph aureus and the coagulase negative staph. So the coagulase negative staph and the staph aureus, they are very, very close to the skin, and they can gain entry into the catheter and cause the infection. Also, the fungi like Candida, you have to remember, as well as Pseudomonas. So those are the important ones. Candidial infection, Pseudomonas, the Staph aureus, and the coagulase negative, which is the Staph epidermidis. So people with the catheter inserted at the femoral region, they usually have high risk of getting infected with the gram-positives, the gram-negative, particularly Pseudomonas, as well as the Candida. So you have to give them prophylaxis against the three, and we're going to talk about that shortly. So what's the history like? So most of the time, you just notice that the catheter is going to be painful, it's going to be red, warm. There could be purulent discharge, depending on the implicating organisms. You'll see some discharge at the exit sites of the tunnels. So you don't need to worry about the specifics of each of them. Just know that sometimes it can get disseminated and lead to sepsis, in which the person starts presenting with hypotension, autosensorium, fever. So how do you make your diagnosis? Of course, you are going to do like a paired blood culture. So you are trying to compare what you culture at the peripheral site to what you culture at the central site. You are going to compare what you culture at the peripheral site to what you culture at the central site and see if you are able to demonstrate same organism. So if you are able to demonstrate same organism, then you know that you are likely having a catheter site infection. So you get a sample from the peripheral vein and a sample for the central line, and you culture them at the same time. You can also obtain a central blood, a complete blood count, your EUCR, liver function test, just to see if there's any affectation of all these organs, or if the person has any comorbidity involving all these organs. Now, how do you interpret your culture? So number one criteria is that you have to isolate the same organism from the central line and the peripheral vein, and you must have a greater concentration at the central line culture. You see, once this is present, you can make diagnosis of a catheter site infection. Or you isolate both infection, both organism from both sides, and you're able to demonstrate at least greater than 15 colony forming unit of the organism from the catheter site. So isolation of same organism from the catheter side, from the catheter tip and the peripheral vein, but you have greater than 15 colony forming unit at the central catheter. Or when you culture the same organism, but you have a yield 2 hours earlier in the central line than the peripheral vein. So three things. You have a greater concentration, the same organism throughout, but you have a greater concentration in the central line culture. You have greater than 15 colony forming, at least greater than 15 colony forming units at the central line, or you have a 2 hour early yield in the central line culture. So that is how you make your diagnosis. And for the tunneled one, you also have to have some clinical evidence in which you are seeing inflammation sign, which is the redness, the purulence, the pain beyond 2 centimeters from the exit site, in the catheter. So because the tunneled one is usually passed underneath the skin, it's usually tunneled underneath the skin to reduce the risk of infection. So most of the time, once you see a tunnel catheter that is infected, most of the time you want to remove it because it shows that stuff cannot be salvaged. Once you see a tunneled catheter that is infected, please remove it. Don't try to salvage it. Just remove it. Remove it. So you want to place them on antibiotic immediately, but you have to start empiric. You don't wait for the result of your culture because there's a very, very high risk of sepsis. So don't wait for your culture. Just start empiric therapy immediately, depending on the catheter site. So because you already know that the vast majority of them is going to come from the gram-positive and gram-negative, you have to give antibiotics that will cover for both of them. And the commonest gram-negative is the Pseudomonas. So you can give, depending on the sensitivity for your gram-positive, you can give your nafcicillin. It can take care of your Staph aureus. But for the ones that are methicillin resistant, you can give your vancomycin. Then for the Pseudomonas, you can give your piperacin, tazobactam, you can give your fluoroquinolones, depending on susceptibility pattern, right? So, and if you are using femoral catheter, you know that you have to add fungal coverage, right? So you give capsofungin. So capsofungin is what you usually use for first line for the candida, but if you don't have capsofungin, you can use fluconazole. So these are the indications for the fungal coverage, femoral catheter, hematologic malignancy, bone marrow or solid organ transplant, prolonged use of antibiotics, people with total parenteral nutrition, and the like. So these are the indications for the. So anybody having some form of immunosuppression, most of the time they will restrict it to these first three. So any form of immunosuppression, just use that. So for catheter salvage and removal. So for the non-tunneled catheter, you have to remove it. But in some situation, probably the patient is very bad, needs that catheter to administer fluid, to keep the person hydrated, for blood transfusion or whatever reason you have sorry, not blood transfusion now, but just to keep for feeding and the likes. And you cannot do it, or maybe it's very difficult to get access somewhere else and you have to salvage. I don't know if you guys remember when we were in the hospital, you see some patients that are very edematous that you have to do like a central line for them. To collect blood sample is even very difficult. So that kind of individual, we want to salvage any line you have, provided it's non-tunneled. So, and you have ruled out that the person doesn't have some distant infection like metastasis, like endocarditis. Then you can salvage it, leave it inside too, despite the fact that it's infected, and administer your topical or systemic antibiotics. But if you have a tunnel catheter that is infected, please remove it. Remove it. So let us look at one question. 4 days after undergoing a transradial amputation of the left forearm following a crush injury in a workplace accident, a 29-year-old man develops fever and hemodynamic instability. His post-operative cause was uncomplicated. His current medication includes morphine and enoxaparin. He has a central venous catheter inserted into the right femoral vein and a padded compressive dressing over the amputation stump. His temperature is elevated, pulse is elevated, respiration is 20, blood pressure is low. Pulse oximetry on the room air shows an oxygen saturation of 96. Cardiopulmonary examination shows no abnormality. Examination of the amputation stump after removing the dressing shows erythema extending up to 1 cm around the surgical sutures, but no induration or swelling, no discharge, no crepitus. Purulent discharge and a fluctuant swelling are seen at the exit site of the femoral catheter, purulent discharge and the fluential swelling are seen at the exit site of femoral catheter. A swab of the purulent discharge is collected and blood samples are drawn simultaneously from the femoral central line and the right cubital fossa. So, of course, they want to confirm the diagnosis. Which of the following is the most appropriate empiric antimicrobial pharmacotherapy for this patient? Anybody?
Pyraceline, anti-pseudomonas versus a femoral catheter.
Mm-hmm.
Anti-pseudomonas because femoral catheter. Pseudomonas.
So, which one are you picking?
Piperacillin, tazobactam.
But I said that it will
But
not. Eh?
I thought that the femoral catheter is for fungal coverage. You use fungal coverage.
No, I said once you have a femoral
Yes.
catheter, there's a risk of the three. That's what I said. There's a risk of the three. So, but I said that commonly,
So,
I said once you have femoral
okay,
catheter,
go ahead.
once you have a femoral catheter, it is a three. That's what I said. It is a three. And I
Mm.
said that if it's not femoral, maybe other ones, the commonest you'll be thinking of is what? Your gram positive or your negative, which is going to be your staph and your pseudomonas. But once you see femoral, put in the three.
Mm.
It's going to be the three. If you see immunosuppression, of course you have to put in the three too.
Okay.
Because immunosuppression is going to allow for your candidate too. So constantly, your gram positive and your gram negative must be covered.
Okay. So
So yeah, I'm listening.
is C now. Vancos, epipine, and
Yeah, that's the answer. Okay. So moving on to thermal dysregulation, and we are starting with hypothermia. So hypothermia is just defined when the body temperature is less than 35. Usually when the temperature is less than 35, the body starts shivering, and the lesser you go, the badder it becomes. And you can classify it into degree. Between 32 to 35, this is mild. Between 28 to 32, that is moderate. Less than 28 is severe. Less than 28 is severe. Um, so there are different causes of hypothermia. It could be from heat loss. Either the person had a burn injury, had a trauma, blood loss, because trauma is going to cause blood loss. So, and blood helps to provide warmth. So from there, the person can be hypothermic because in burn injury, we are using the skin epidemic. So there's heat loss, and if you're exposed to a cold environment, it could be from impaired heat production, hypothyroidism, sympathetic cutoff, adrenal insufficiency. There's no cortisol, no increased metabolism, less heat, hypoglycemia. You can't metabolize glucose to generate heat. So impaired regulation. So this is very common in people with problem with the CNS. They can't regulate the temperature due to the CNS injury. So all these things, you don't need to cram them. Just look for them in the option. You are definitely going to, or in the question, you definitely identify one of them. So you don't need to, put it in your head. So just know that less than 32 degrees, you stop shivering. At less than 35, but not up to 32, they are still shivering. But once it gets to less than 32, the shivering mechanism stops. And that's when the individual starts getting confused because of problems with the CNS, problem with the heart. They can start developing deadly arrhythmias, confusion, lethargy, and the likes. And when it gets to less than 28, they enter coma. So between 32 to 28, it's more of CNS and cardiac problems, confusion, lethargy, dizziness, weakness, and arrhythmias. Less than 28, coma. So regardless of the etiology, so this is not the time to now start to be correcting glucose or to be correcting thyroid, to be giving levothyroxine. Regardless of the etiology, your treatment is directed to correcting the body temperature. So you have to elevate that body temperature. Very, very important. So if the person is exposed to a cold environment, cold water or something, or drowning, remove that wet clothing. take the patient away from that environment, cold environment, take the person away from that windy environment, remove the wet clothing, check the pulse. If the person doesn't have a pulse because the person had undergone cardiac arrhythmia that lead to cardiac arrest, you have to commence your CPR. Commence your CPR immediately because hypothermia is a cause of cardiac arrest. We remember the 5H. Do we remember the 5H and the 5Ts? Anybody? We are not talking.
Hypothermia,
No, I'm not saying we should.
hypotension,
I'm not saying we should list it. I just want to know.
hypoglycemia.
I just want to know if you remember it, Dr. Antonia.
Oh,
Okay. Um, so between, so that's that. So usually, if the temperature is between 32 to 35, just do a passive external rewarming. So basically, what you just do, just remove the wet clothing and cover the person with a blanket. You are not doing something active. You're just covering. But if you are trying to force, like warm air to the body, that's when you say active. So you are forcing warm air to the external surface of the body. So that is an active external rewarming. So if you are just covering with clothes, that is passive external rewarming. If you are forcing warm air to the skin, that is active external rewarming. So if you are forcing warm stuff into the body, that is active internal rewarming. So that's the way I want us to look at it. So you just get your pen and paper and arrange it. 30 to 35, that's mild. 28 to 32, that is moderate. Less than 28, that is severe. So here, they can now start having coma. Here, CNS and CVS. Here, just normal shivering. Shivering is lost here. So now, you still cover them with warm blanket. You can, administer a warm water bath. That is an active thing. Or you apply a forced warm hair blanket system. So that is active external rewarming, right? So then, when it's less than 28, so this is active internal rewarming. So you have to force warm fluid into the body. So either you give intravenous warm normal saline, you administer warm peritoneal or pleural lavage, or you do extracorporeal rewarming by using your hemodialysis machine or your extracorporeal ECMO machine. So ECMO machine, hemodialysis, setting line, pleural or peritoneal lab, all these ones will force the warmth into the body. So that is active internal rewarming, and you do it when the temperature is less than 28. Please hope we understand this, or it's looking like confusing stuff.
We understand.
Thank you. So there's something we call frostbite, and this usually affect the fingers or the toes, and it occurs when you start noticing like extreme freezing of the tissues of the fingers. And how are they going to present? They'll start having numbness, tingling sensation. The skin start appearing waxy and waxy, tingling, numb sensation in the extremities. Then you start seeing appearance of blisters. The extremity becomes swollen. You can have rupturing of the blisters with eventual necrosis. So initially, you just see that skin is changing in color. It's appearing numb. It is cold. It is changing in color into white, waxy. Then it is swollen, full of blisters. The blisters ruptures. There's necrosis. So once you are seeing that being demonstrated, waxy, white, blisters, edema, necrosis, just know that this is likely to be frostbite. It's a complication of hypothermia. It's very painful sometimes, and particularly when you are trying to thaw. So what you are doing is that when you thaw, it means that you are trying to reheat that cold finger by dipping into warm water, heated to about 37 to 39 degrees Celsius. So it's very painful. So as you are thawing, you have to give narcotics for the pain. You give narcotics for the pain. So then as you're also treating these people, you have to also monitor the ECG for arrhythmia, because don't forget, hypothermia is the cause of arrhythmia. So And there's a particular wave that you see in them that you call the J wave or the husband wave. I thought I have, oh my God, I thought I have a picture for the husband wave. So let me show us what it looks like. Husband, husband wave is more like a positive deflection at the end of a QRS complex. So we can see this positive deflection at the end of the QRS complex. That's the husband wave. So it's common in people that have hypothermia, but that's the ECG finding. They can also have bradycardia. The heart starts slowing down, and also a slow atrial fibrillation. So, so what do you just want to do? Monitor and aggressively replace fluids. For example, somebody has burn injury now, as a cause of trauma, replace the fluid. So you treat according to the underlying cause. After you have, done your initial resuscitation to bring up the temperature, then you now start treating the underlying cause, give fluids. So it's very easy. For example, if somebody has trauma or somebody has burn injury and the person is now having temperature less than 28, you already know that your fluid that you are giving will help both the temperature as well as the fluid loss. So replace with warm saline, monitor for electrolyte and acid base changes, and don't stop resuscitation effort until the patient has been rewarmed. Because some of them can be comatose. When it's less than 28 degrees, they can be comatose. So don't say that, this one don't die now. Keep your resuscitation, keep doing your resuscitation until the patient has been warm. So if the patient is now warm, as out of that hypothermia, and the patient doesn't still come back to life, you can now pronounce the person dead. So do not pronounce the person dead until you have rewarmed to at least 32 degrees Celsius, unless maybe potassium is more than 12. Someone that has potassium of 12 millicurie is dead. So this hyperkalemia is severe enough to kill somebody. So this is a very important key fact. Do not pronounce the person dead until you have been warmed to 32 degrees Celsius. Because when the person is less than like 28, the person can enter coma. So get the person to at least 32 before you can now say that, okay, I've tried my resuscitation, there's no improvement in the status, this person is likely dead. So let us look at a question here. Oh, I didn't remember to put in question what? Oh, I'm sorry about this. Probably that's an omission when I was gathering the question. Okay, so moving on to hypothermia, and this is when the body temperature is more than 40 degrees Celsius. That defines hypothermia. There are different causes of hypothermia. It could be from exposure, like people with malignant hypothermia, NMS, poison, withdrawal syndrome, environmental. So environmental is one thing that is commonly tested as heat stroke and heat exhaustion. So most of the time, what differentiates heat stroke and heat exhaustion is that in heat stroke, the temperature is usually more than 40. In heat exhaustion, it is 40 or less. In heat stroke, it is more than 40 most of the time. In heat stroke, there is no neurologic complication. The patient is not going to be confused. The patient is not going to be having seizures. But in heat stroke, the patient can have neurologic. But in heat exhaustion, there is no neurologic manifestation. In heat exhaustion, what is responsible to that is when you are exposed to a very, very high environmental temperature. But heat stroke can be classic or exertional. So the exertion is when the person is exposed to high heat and the person is also exerting. Maybe the person is running, the person is marching under the hot sun. So that is exertional. But for the classic, it's usually due to exposure to high temperature, and again the person has some problems with maintaining heat regulation. Probably the person is old, or the person has a damaged skin or something. So that is the heat exhaustion. You don't really need to waste your time learning the pathophysiology. What is important for you to delineate is the temperature and the presence of neurologic complications. So
Sorry, Steve, please can you come again?
yeah. So which part now is not clear, Dr. Mario?
You said heat stroke has neurologic manifestation and temperature is greater than 40, right?
Yes, That's correct. So each
Okay.
stroke, temperature is greater than 40, there's neurologic manifestation. Each exertion, temperature is 40 or less, no neurologic manifestation. No neurologic
Okay.
manifestation. Now, the reason why you need to differentiate between them is that you need to correct the hyperthermia in each stroke faster. In fact, you need to drop it by about 0.1 to 0.2 degrees Celsius, per minute or so. I can't remember classically, but you need to drop it fast. And that's why you do something like ice water immersion. Put the person inside hot water, bam. But for each exertion, there is no urgency like that. Do you get? Because in each stroke, you can see that the person is already having DIC. They can have DIC, they can have end organ damage, they can have AKI, they can have, because of dehydration, they can have so many problems. There's rhabdomyolysis, myoglobin in the kidneys, destroying everything. But in each exertion, you don't have much of the end organ issue, so there's no urgency. So you can just do evaporating cooling. You can give them fluids, cold chilled drink. Just take this coke and cool down. You get? But you can't be giving someone that has heat stroke coke. You have done nothing. So you have to insert that person in ice water. So infectious cause sepsis can cause hypothermia, meningitis, tetanus, all the infection, severe malaria, endocrine. All those things that can increase adrenergic discharge. So thyrostomy, leukocytoma, then DKA too, because of the increased metabolism. Then neurologic, these people will have problems regulating the temperature from the hypothalamus. So people with hypothalamic stroke, people with cerebrovascular accident, people with seizures, because if you're having seizure, you are contracting the muscles. So there's hypothermia. So it's your management is directed towards correcting the body temperature, regardless of the etiology, just like in hypothermia. So rapidly cool the patient with cold water, so cold water immersion, or ice for the heat stroke. You can apply one blanket for people that wet blanket for people with like heat exhaustion and something that is not urgent. And you can give benzo to reduce the shivering so that you don't further generate heat and rule out infection by your stuff. So don't forget NMS and serotonin syndrome. What separates serotonin syndrome and NMS? I know Dr. Babandi have told us what is that, clincher. Anybody remembers?
Clonus.
The clonus. So once you are saying
Clonus.
hypertonia with clonus, hyperreflexia, clonus, think about serotonin syndrome. So, and of course, you are going to get the history that the person has used some medications, ondansetron, tramadol, different SSRI and the likes. And NMS, the person has taken one of those antipsychotics and the person now developing the rigidity, the fever, the leukocytosis, whatever. So then you treat accordingly. So let's look at the question here and see. So, a previously healthy 44-year-old man is brought by his co-worker to the emergency department 45 minutes after he became lightheaded and collapsed while working in the boiler room of a factory. He does not lose consciousness. His co-worker reports that 30 minutes prior to collapsing, he told them he's nauseous and he has a headache. He appears lethargic. He is not oriented to time, place, and person. His temperature is 41 degrees C. Pulse is elevated, respiration is 22, blood pressure is 90. Examination shows equal and reactive pupil. Deep tendon reflex is +1 bilaterally. Infusion of normal saline is administered. Urinary catheter is inserted and dark brown urine is collected. So, the man just became lightheaded and collapsed while working in the boiler room of the factory. So he did not lose consciousness. But the co-worker reported that 30 minutes prior to collapsing, he told them he's nauseous and he had headache. He has fever 41, blood pressure is low, tendon reflex is +2. Then they start infusion of normal saline. Urinary catheter is inserted and there's a dark brown urine. Okay, so there's platelet count is low, hemoglobin is okay, white leukocyte is elevated, there's hyperkalemia, there's AKI, elevated liver enzymes, elevated creatine kinase. So which is the best next step in the management? Anybody?
Ice immersion.
So what is your
That's what
diagnosis?
I mentioned.
What is your
Heat,
diagnosis?
heat
Heat
stroke.
stroke.
Why are you picking heat
Heat
stroke?
stroke.
Why are you picking heat stroke?
Neurological manifestations.
Good job. And look at the temperature, 41. And the
Temperature.
person is already having end
Yeah.
organ. You can see the DIC.
Damage.
The platelet is already
Yes.
going down. You can see the hyperkalemia from the muscle breakdown. You can see the creatinine kinase from muscle breakdown. You can see elevated liver from the liver malfunctioning. You can see the AKI from the kidney. You can see. Once you see that, that's it. Just pick your answer, you go. So let us talk about
So,
bonds.
Dr. Babawale,
Yes, Dr.
sorry.
Bakari.
So, in heat exhaustion,
Mhm.
yeah, the exhaustion one. So it's just lethargy. They're weak,
Yeah, they could
kind of.
be, they
No
could be
neurological.
weak, though they'll still have elevated
Neurological.
body temperature. Do you get
Yeah, I
Dr. Anthony?
know.
They have
But
elevated.
apart from that, no end organ involvement,
There's no
right?
they can have nausea, they can have vomiting. Do you get?
Mm-hmm.
They can
Okay.
have features of dehydration. Do you get? But you won't really
Hmm.
have end organ stuff. And especially the cranial, the neurologic one would not be there. Neurologic is what you should look for. You see, once they tell you that the patient is alert, don't pick heat stroke. You get it, Dr. Antonio? Because
Yes.
the word stroke is relating to neurology. He's having a stroke. So, and what is telling that? There's a neurological involvement. So, bonds. Bonds, three type of bonds, majorly that we are concerned with: chemical, electrical, and thermal, right? And one of the deadly or the deadliest that you have to pay attention to is the chemical and the electrical. Forget about thermal. So these ones are the ones that you need to know. Thermal is there. It's important too. I'm just joking, but the ones that have some little catch is the chemical and the electrical bonds. So you have to know that if somebody get exposed to acid or alkali, they can have chemical bond, and the one that is most dangerous or more dangerous is the alkali, because alkali can cause liquefatic necrosis and it can penetrate into the systemic circulation as compared to acid. Acid is not like that. So both of them is going to cause pH abnormality. And what do you want to do? See, I don't want to know what the question is all about. Anytime you see that somebody is exposed to a chemical, USMLE wise, quote me anywhere. The best next step to do is to copiously irrigate. You can never be wrong. You can never copy. What is the chemical in the eyes, in the nose, in the skin, in anywhere? The next thing you want to do is to limit systemic absorption by copiously irrigating. Now, if it's electrical burn, the way I look at electrical burn is to picture that, okay, somebody gets exposed to high voltage. Once it gets into the body, the electrical energy gets converted to thermal energy. And the thermal energy destroys two major tissues. Destroys the muscle, destroys the blood vessel. You see, once you remember this, you are done with electrical burn. Destroys the muscle, destroys the vessel. Destroys the muscle, destroys the vessel. Now, what is it going to cause to the muscle? It is going to cause like damage to the muscle, injury to the muscle, lysis of the muscle. When there's lysis of the muscle, you start releasing cytokines, and you start having vasodilation, and you start having blood filling up that area, increased tension of the muscle, causing compartment syndrome. If it damages the blood vessel, it's going to damage the endothelium, it's going to activate thrombosis, and you're going to have ischemia. This ischemia can be worse if you are not quick with your resuscitation from a combination of the thrombosis and the compartment syndrome. Both of them can accelerate this limb ischemia, causing necrosis, and you might have to amputate. Now, don't forget that there's muscle destruction. When there's rhabdomyolysis, what do you think is going to be released? Anybody?
Myoglobin.
Myoglobulins that can injure the kidneys, causing AKI. What else?
Um,
Potassium.
Potassium. Potassium is
mhm.
released. electrolyte abnormality that can cause arrhythmias. You can see that you don't have to be a genius to remember everything that is here. So once there's muscle injury, rhabdomyolysis. So what you want to do is to do early prophylactic fasciotomy to prevent compartment syndrome. Now, you also have to do early debridement so that you don't, have too much rhabdomyolysis with myoglobin being released and getting into the kidneys to be causing AKI. You have to observe the pulse regularly because of thrombosis of the vessel causing limb ischemia, as well as because of compartment syndrome causing ischemia. Although the ischemia from compartment syndrome occurs later. It is neurologic complication that you are going to see first, which is pain, pulselessness, paresthesia, and pain. Then later you'll be seeing the pallor, pulselessness. So majority of the pulse problem comes from the thrombosis of the blood vessel. Then you're also going to assess for the kidney function because of the myoglobinuria that Dr. Antonia mentioned, causing AKI. The electrolyte abnormalities can cause arrhythmia. So plug in your ECG and monitor your electrolyte, especially potassium. You can see it's very easy. Very, very easy. So your question can come in that area. Now, how do you classify the bone? We have superficial thickness, which is the first degree. We have the second degree, but don't forget in our step 1, we further classify second degree into 2 classes: the superficial partial thickness and the deep partial thickness. Then you have the full thickness of the third degree and the fourth degree. Now, what is happening in the first degree? It is only the epidermis that is involved. And what you just have is what? Erythematous area, no blisters. No blisters. The level that we have blisters is at the level of the second degree, if you remember when I was explaining then. So if it's just first degree, you just have like erythema, that's all, and it's painful. Now, if it's superficial partial thickness or deep partial thickness, both of them are second degree, you are going to be having blisters. But what is going to differentiate them is the presence of what? Who remembers? Anybody remembers? What you said is going to differentiate them?
Pain.
Pain. Pain. So in an individual with superficial partial thickness, the sensory nerve endings are not gone. So there's going to be pain. But once the person develops blisters with loss of pain, you know that is a deep partial thickness bone injury. So your superficial partial thickness bone is extending to your papillary dermis. Your deep partial thickness bone is extending to your reticular dermis. Your full thickness bone and your fourth degree, what is going to be classic with them is what? There's going to be wide, leathery, charred skin. You see, once you are seeing this description, no blisters, but white, leathery, charred skin, you know that this is third degree or fourth degree. Third degree or fourth degree. And there's not going to be pain. And it means that for the full thickness, you have taken your entire epidermis and your dermis. It has gone beyond the reticular. It has taken it entirely as your full thickness. Fourth degree is when it has extended to the bone, the facial, or the muscle. Very easy stuff. Now, there's something I must mention. People with the second and the third degree usually have high risk of compartment syndrome from circumferential bone. So if they have a circumferential bone, which is second degree, so what we are trying to say is that that bone is encircling an organ. So if this is somebody's hand now, and you're having a bone injury that is like this, taking the entire circumference of the arm, that person is at high risk of developing compartment syndrome. So because if you have circumferential bone that is second or third degree, you have a very high risk of forming what we call HESCA. HESCA is a band of necrotic tissue from the bone injury, and they can compress on the lymphatics and the veins and the arteries, and from there the person will have compartment syndrome. So what you want to do immediately for that person is not fasciotomy, because compartment syndrome have not set in, but you want to prevent it. Because at that point, the person is going to be having edema, there's going to be pain, but it's not from compartment syndrome. It is from the compression of the vessels. So what you want to do is what we call escarotomy. If you see surgeon saying, go and do escarotomy, it means the person has a circumferential bone injury and you want to relieve that obstruction. Very important stuff. Now, somebody that has superficial Burn injury, you are scared of two organisms: your gram-positive, like your MRSA, and your pseudomonas. Forget this at your own risk. Please do not forget this. It's very dangerous. So if you have burn injury, think about infection from pseudomonas or gram-positive cocci, like your MRSA. Now, you already know how they are going to present. Your management of burn follows the ABCD approach, ATLS, ABCD approach. You want to check the airway. How is this airway? Can this person even talk? Can the person call my name? Airway is patent if the person can talk. If the airway is not patent, suction. If there is smoke, everything inside, you know that there's a high risk that this person is going to have inhalation injury. You want to intubate. You can see burnt, singe, nasal hair. You can see smoke. You can see carbonaceous sputum. This person is already likely going to have inhalation injury. You want to intubate. You know, so there's a high risk of carbon dioxide poisoning, particularly people that are, enclosed in a burning environment or building, you know. So assess the airway for inhalation injury. So ABC, still the first line. Check the airway, check the breathing. What's the breathing? Is the chest moving? Is the oxygenation adequate? Then your C is where you now start giving your fluid. And you calculate fluid based on the what? Parkland formula. 4 ml per kg per meter square. So you are going to assess the surface area of the burn. You check the person, where's the area that is burnt. But you have to know your calculation, before you can do that. Just know that for your head and for the upper limb, it is 4.5. Head, back and front, 4.5 front, 4.5 back. For the upper limb, 4.5 front, 4.5 back. Other part is 9. The chest 9, the back, the torso 9, front and back 9 9. Then the legs 9 9, the perineum 1. Please hope we understand this calculation because we are senior candidates now. I know we know all these things, right?
Yes.
Are we following? Yeah. So you now look, okay, what is the area
Yes.
that is burnt? What's the area that is burnt to? If it's only the torso that is burnt, that's 9% body surface area. So you just calculate 4 mil per kg per meter square. So 4 mil times the body weight times the surface area, 9%. You just multiply times the 9, you get your fluid volume that you are going to calculate. And the next thing for you to do is just to split it into 2. So you split it into 2. You want to give the first 50% within the first 8 hours and the next 50% over the next 16 hours. So then you catheterize that patient. And how you can know the person is out of the shock or burn injury or anything is when the person starts making urine. 1 mil per kg per hour. Please don't forget, urine output is the best assessment. That is the best assessment that person is recovering. So people that inhale smoke can get CO poisoning, can get cyanide poisoning, we know all these things. So you can do a chest x-ray because you are scared of ARDS, right? Check your carboxyhemoglobin level, lactate level. Then for the circumferential scar formation, due to obstruction of venous and lymphatic vascular compartment. So we've talked about that. Then what do you want to do? Now, you are doing fluid repletion for people with second and third degree, right? People with the first degree, just apply emollient. Because what they are going to be having is what? Erythematous skin. So just apply your emollient, aloe vera based emollient. Person is going to be fine. You don't need to give first degree antimicrobials because there's no denudation of the epidermis. So, but once the epidermis is exposed, then you can give your antimicrobials, which is mafenide acetate or sulfadiazine. This is not the time to be giving ceftriaxone. They are not proven to show any benefit. So the ones that you give is sulfadiazine or mafenide acetate. So you can perform an escharotomy to relieve obstructed vascular flow in the circumferential bone. Escharotomy, escharotomy, escharotomy. Then tetanus vaccination. Tetanus vaccination, because risk of tetanus and stress ulcer prophylaxis. We know this already. Cushing ulcer, colon ulcer. In this situation now, it is the colon ulcer. So give them PPIs. And of course, because of the pain, give them the analgesia. So let us look at the question before. So A 32-year-old woman is brought to the emergency department for evaluation of burn injury that she sustained after stumbling into a bonfire 1 hour ago. The patient has severe pain in her left hand and torso and minimal pain in the right arm. She does not smoke cigarette, takes some medication. Now let me look at the most important thing there. There are 2 tender blanchable erythema without blisters. There are 2 tender blanchable erythema without blisters. Over a 5/6. What class of burn injury is that? Anybody?
First.
First degree. Good job. Good job.
Yes.
That's very good. There's also an area of white, leathery skin and tissue necrosis encircling the right upper extremity just proximal to the elbow, which is dry and non-tender. An ECG shows sinus reading, blah, blah. Admission of intravenous fluid is begun. Which of the following is the most appropriate next step in the management? Now, oh, I think I have mixed up. Damn it. I think I've mixed up the option. And please, I'm coming. Okay, yeah, I've not mixed it up. So, which of the following is the most appropriate next step in management? Yeah, the answer is there. Good. So, what do we do? Anybody?
Soft tissue ultrasound.
Dr. Miriam.
I thought you said that. I thought you said that. It looks like the person has this circumferential.
There's also, I think that.
Dr. Antonia, you have lost your voice. Oh. The way you are sounding. You sound like, yeah.
No, I said there's also a full thickness bone too. There's an area of circumferential leathery, whatever. Yeah.
So what is that? What is that
So
telling you?
that's a full thickness bone. A circumferential bone. That's
So Dr. Miriam.
Second or third
degree. So
yes.
Dr. Miriam, somebody that is having circumferential bone, what are you thinking of?
Second or third degree.
Okay, yeah, second or third degree. But what is the person at risk of developing?
Okay, compartment syndrome. Okay, monitoring of peripheral pulses.
Very important stuff. So I know that it's because I did not interpret that second bond for us. That is why we did not pay attention to it. I purposely kept quiet. So that's why every single statement we have to interpret what it represents. So that one is just like a distraction. This one has nothing, but this one is a major problem. The encircling upper extremity. That upper extremity is gone. You see, if this eschar formation occurs in the abdomen, do you know how the patient is going to present? That patient will not breathe because by excretory movement of the abdomen, they are going to be feeling pain. So they'll just tell you that that patient is not breathing. It's because of that encircling eschar, that's compressing on the vessel. So we should pay attention to that. Let's do one more. 3 hours later, the patient is reassessed. Okay. The right arm is put in elevated position and physical examination of the extremity is performed. Examination shows reduced capillary return, pallor. Pulse oximetry shows O2 charge of 84. So what's the appropriate next step? Fasciotomy. Fantastic. So what has already happened?
Compartment syndrome
has already happened. They are too slow. So
mental syndrome.
Yeah. So examination of his right foot shows erythematous skin with multiple blisters, some of which have ruptured. The skin is tender to touch. What describes it? So what's our diagnosis?
Superficial partial.
Fantastic job. You can see that all these things are very easy. You just have to be analytical. Like your calmness and composure in the exam goes a long way. So that's why we have to practice with a lot of questions so that we can be, we can build our confidence. So just be very analytical. Look at it carefully. Pick your answer, move. So, let's just talk about drowning. It stops then. Okay, so now, drowning. People that suffer drowning, what essentially happens is that they suffer that initial panic. They try to hold their breath. And in the course of holding their breath, there's going to be hypoxia. This activates the respiratory drive, the hypoxia and the hypercapnia, and the respiratory drive overcomes the breath holding state, and they try to breathe. And in the course of trying to breathe, they aspirate fluid, the water, and there's laryngospasm leading to hypoxia. And when there's hypoxemia, the organs are going to fail. Majorly is what? The brain and the heart, because these ones cannot survive without oxygen. So the person is going to be having cerebral issues and cardiac problems. So because of the water exposure, there's going to be hypothermia, of course. Because of the difficulty in breathing, there's hypoxemia, and don't forget the CNS status, they can confusion, their loss of consciousness, they can have seizures. For the cardiac, they can have hypotension, poor cardiac contractility. So there's going to be hypotension, right? The pulse is going to be, there's going to be bradycardia, and so on. So there could be arrhythmias. Because of that. So I've explained the pathophysiology because the hypoxemia shuts down the brain function and the heart function almost immediately. Now, if they bring in a patient that is experiencing drowning and the patient is alert, the patient is not having any other sensorium, essentially non-fatal. So just observe for 8 hours. Observe for 8 hours, do your chest x-ray, see if there's any pulmonary edema, any ARDS. The patient is fine, discharge. But if it's fatal, you have to start with your primary and secondary survey. So ABCDE, check your airway, suction, intubate. The patient is having respiratory failure, intubate that patient. If the patient is hypothermic, what do? We are not talking.
Provide warmth.
Yeah,
Provide
Provide
warmth.
warmth.
Provide warmth.
one blanket.
In one blanket, intravenous normal saline that is warm.
One
Just
fluid.
resuscitate. Order your chest x-ray. Don't forget ARDS. Not to rule out ARDS. Because drowning is the cause of ARDS, pulmonary edema and the likes. Do your complete blood count, and of course, importantly, your arterial blood gas. The PO2. That's going to tell you if the person is out of the hypoxemia or not. So remove the wet clothes and rewarm. Remove the wet clothes and rewarm. Correct the hypoxemia by giving oxygen. It's part of what you have done with your ABCDE. Acidosis because of the hypoxemic state, right? If there's ARDS, do your NAPPV or intubate. Cardiac arrest from the hypothermia, do your what? CPR. Cardiac arrest can also come from the hypoxemia. All of them, do your cardiac arrest protocol, which is your CPR. Very easy. I'm not sure I have a question. Okay, I have one. So, a 3-year-old girl is brought to the emergency 20 minutes after she was found face down in the pool by her older brother. The siblings are playing outside in the garden with their grandparents. The brother reports that he went inside to get something to drink and discovered the sister floating in the pool when he returned. The grandfather took her out of the pool and called an ambulance. On arrival, the paramedic found that the girl was somnolent but spontaneously breathing. En route to the hospital, they initiated bag mask ventilation, 200% oxygen. She appeared lethargic. Temperature is 34, pulse is 80, respiration is 34, blood pressure is 90. Pulse oximetry is 100% on non-rebreather mask with oxygen saturation 88. There is no evidence of trauma to the head and neck. His lips appear bluish. Pupils are equal and reactive to light. Airway is clear. Pulmonary auscultation shows diffuse crackling and wheezing. Femoral pulses are palpable bilateral. Remember, again, shows normality. What is the most appropriate next step in the management? Anybody?
Administer intravenous warmed crystalloids.
Administer,
Um,
but this patient's
Endotracheal
temperature,
intubation. Oxygen is 88%.
yeah. So
Temperature is 34.
now, Dr. Miriam, you see, this is the approach. ABCD. You remember A, B, C, D. You have to get to A before you get to
Yeah,
C.
I didn't. I thought I saw oxygen was 100%.
See, they said
The
they were administering 100% and they were getting
Oh, okay,
saturation of
okay.
88.
Yeah,
That's not good.
yeah.
So what do?
You intubate.
Intubate that patient. Even if you want to give warm crystal love, blah, blah, the temperature is not very, very low like that. You remember the temperature
Mm.
you have to do that. Do you remember?
Yes.
What's the temperature? Dr. Antonia, remind us.
32.
This temperature is 34 for the patient, but
Yeah.
it's less than 35. But when it's 32 to 35, really warm.
We are tired. I said, what approach
I
is,
think it's 28.
what approach is intravenous warm? What approach is
Okay,
that?
sorry. That's that's
Prevalence
that's
point is
less than
less than
28.
28.
Yes. That's an active internal warming.
Warming.
So less than
Mm.
20, that's when you do that. So they just make sure they put something that looks good. That looks like, okay, if you tell your consider that I did this, they will not say that you killed the patient. That was what they did. But that's not still the best thing to do. So
Mm.
uh high altitude sickness, somebody that has sent, altitude of about 2,000 feet, or about 2005 millimeter meters. Anyone, you don't need to know the value. Don't worry yourself. The presentation will tell you. And three basic things that they can present with: acute motor sickness, high altitude pulmonary edema, and high altitude uh, cerebral edema. So for the acute motor sickness, what happens is that when somebody is ascending, the partial pressure of oxygen falls, and the person starts hyperventilating. They start trying to breathe a lot of air, and the presence of hyperventilating, the PCO2 drops, right? And there's going to be a state of respiratory alkalosis. Now, that alkalosis is bad for the brain. The person starts developing acute sickness features, which is dizziness, headache, fatigue, nausea, vomiting. Is due to the alkalosis. So once you are seeing someone that is ascending and says, headache, I'm tired, I want to vomit, I'm nauseous, acute mountain sickness. They are sick. It's like somebody is sick because you start having headache and you are tired, you are having vomiting, you are like sick. So mountain sickness. Now, as you go now, before I move further, to treat acute mountain sickness, that's why you give acetazolamide. What do you think acetazolamide is going to do with the level of bicarbonate in the blood? Is it going to increase it or reduce it?
Reduce it.
It will reduce it. That means you are taking care of the cause of the mountain sickness. So it makes sense to give acetazolamide to somebody with acute mountain sickness. Although the first thing you are going to tell the person is that mountain where they go, I beg, calm down. Chairman, I beg, please calm down first. You have to descend. We give you oxygen. Then we now administer acetazolamide. Right? Then it's a spectrum. It can develop, the person can develop high altitude pulmonary edema, and this is in relation to the hypoxia. So we know that the pulmonary vasculature responds to hypoxia by undergoing what?
Vasoconstriction.
Vasoconstriction. So there's going to be pulmonary hypertension, and you are going to have fluid extravasating into the pulmonary parenchyma. So causing like a pneumonia-like picture, like pulmonary edema-like picture. So you're going to having cough, dyspnea, hypoxia, crackles because of the fluid. But what's going to separate this from like pneumonia stuff is that if you do your leukocyte count, it's going to be elevated, but it's not going to be more than 14,000. So don't be deceived. So some people just say, now 14,000 be this now. A person having crackles, having hypoxia, fever. This is pneumonia. You might not see fever though, but don't be deceived that leukocytosis means infection. No. So they can have leukocytosis, but it's not going to be more than 14,000. Then the last is what? The high altitude cerebral edema. So it's the same pathophysiology. The brain is not getting enough oxygen. The brain vessels start vasodilating so that they can get more blood flow. The vessels are weak because of the inflammatory drive from the hypoxia, and you start having, blood extravasating into the tissues, causing cerebral edema. So you need to stabilize the vessels in a way, limiting the inflammation by giving DEXA. So that's why DEXA is good in HACE, which is high altitude cerebral edema. DEXA is a mainstay. So you descend, give oxygen. Usually you give them hyperbaric oxygen, 100%. In fact, hyperbaric is more than 100%. Like you are giving at a very high pressure. So hyperbaric oxygen with your DEXA, you take care of your high altitude cerebral edema. Then for your high pulmonary edema, tell them to descend, give them oxygen, hyperbaric oxygen. You can give them sildenafil or nifedipine to reduce the vasoconstriction, they are going to be fine. But supportive treatment, don't forget the oxygen. The headaches for the acute mountain sickness, give them NSAIDs for the headaches. Acetazolamide to reduce for the adjustments, and they'll be fine. So, the microbiology involved in bite, we should not forget. Pastorella for dogs especially. Capnocytophagus carnivorous, Patronella from cats, staph and strep. So, just by the way, I think we are done with mountain sickness. So let's go to a question. A 27-year-old man is brought to the mountain base, 400 meters. You can see that's more than 2005. You don't even need to cram it. And he has a 2-hour history of confusion, difficulty walking, decreased responsiveness. He has been participating in a 5-day hiking trip in which the group has ascended 1005 from the camp in 2 days. This morning, the 3rd day of the trip, the patient was found in his tent unable to respond to simple questions and having wet himself. The night before, he reported headaches, dizziness, nausea, lethargy. Temperature is 37.5, pulse is 85, respiration is 20, blood pressure is 135/85. Pulse oximetry in room air shows oxygen saturation of 89. Neurologic examination showed slurred speech and a ataxic gait. Kennick sign is absent. Further diagnostic study should be performed due to limited medical equipment. The most appropriate initial step in the management is the admission of which of following. So what do we think is happening here?
Mountain sickness.
Mm-hmm. Mm-hmm. Why are we saying mountain sickness?
She went for hiking.
Wait, there's a okay. Let me be sure that I'm not maybe do you want to say high altitude sickness?
Yes.
You know that if you are saying mountain sickness, you have kind of narrowed it out. You can have mountain sickness, you can have high altitude pulmonary edema, high altitude cerebral edema. Do you get?
Mm.
So which one are you saying? Are you
High
saying mountain?
altitude, high altitude cerebral edema.
Yeah, because
Yes.
your management.
Mm.
Do you know the reason why I quickly interrupted you? If you say this is
Mm.
mountain sickness, you are going to pick another thing. What are you going to pick?
Mm.
Acetazolamide.
Acetazolamide, and you'll be wrong.
Well, I wasn't going to pick it though because I saw some neurological manifestation.
Exactly. So
I was going to pick that.
that should change, your diagnosis. You will not say multi sickness anymore. It's going to be high
Mm.
altitude cerebral edema.
You
It's
didn't.
important.
Okay.
So what are you going to pick?
Dexamethasone.
Dexamethasone. You can see those guys are very tricky. So identify the symptomatology. Is it just having headache, nausea, vomiting, fatigue? That's mountain sickness. Lung problems, pulmonary edema. Cerebral problems, cerebral edema. And you manage accordingly. So that is the way it is. Okay.
Sorry, Chief. Apart from the supplemental oxygen for pulmonary edema, what else do you give?
So you give the 30% to the patient descent, you give the oxygen, then you can administer nifedipine or sildenafil. And why you are doing that is because you want to reduce the pulmonary hypertension. Do you get it?
Okay. Yes.
Yeah. Um. Sorry. Uh. It's just 1 minute. Okay. Um. Yeah. So um. So, so I've talked about the common microbiology of bites: Pasteurella, Capnos, Cytophagus, Canimurus, Bartonella, staph and strep. Those are the common microbiology, the organism present in the bite. So bite involving sharp teeth and deep puncture should not be sutured. Just open it, allow it to heal by secondary intention, and administer Haemoglobin and check for deep tissue infection like osteomyelitis. So because some of those organisms from the bite, like Canimurus and the Pasteurella, they are responsive to this amoxicillin. Yeah. So bite and stings. Bite and stings. What is the management? So we are going to be talking about two things. We are going to be talking about rabies and we are going to be talking about tetanus. So for rabies, very easy. Very, very easy. So they just tell you somebody gets bitten by an animal. You first have to identify that animal. Please, what animal are we dealing with? Am I dealing with an high risk animal or a low risk animal? What do you call a low risk animal? Cat and dog, domestic animals. But if the question start telling you bat, skunk, raccoon, those are wild animals that are high risk for transmitting rabies. Okay, somebody has been bitten by an animal. The next thing you want to do is to ask the owner, please, what is the vaccination status of your animal? If the animal is vaccinated, you do nothing. You are okay. Everybody's fine. If the animal is not vaccinated or you don't know the vaccination status of that animal, what you need to do immediately is to quarantine that animal for 10 days. So you quarantine the animal for 10 days and watch if that animal develops rabies. If the animal develops rabies within 10 days, then you have to give that individual prophylaxis. Now, the prophylaxis that individual is going to take depends on the immunization status of that individual, like the immunization status of that individual, if the person has been immunized or not. If the person has been previously immunized, the only thing you need to do is just to give like a booster vaccine. If the person has not been immunized before, you have to give both the vaccine and the immunoglobulin. Now, if it's the situation of wild animal, most of the time, the wild animal, they will tell you the question that the wild animal disappears. So you have to give prophylaxis. If the wild animal did not disappear, then you euthanize that wild animal. That means you open the brain of the animal, you do histology on the brain and check if there's rabies or not. So if there's rabies, give prophylaxis. If there's no rabies, don't give prophylaxis. I have explained this table with my words. Do we understand it or I should come again?
Please come again, please.
So identify the animal. Is it wild or domesticated? If it's domesticated, ask the vaccination status of the animal, if it's vaccinated or not. If the animal is vaccinated, you do nothing. If the animal is not vaccinated, then you have to quarantine the animal. You keep it in a place and watch it for 10 days. If the animal develops rabies, you give that individual prophylaxis. If the animal did not develop rabies, you do not do anything. Now, if the animal develops rabies and you want to vaccinate that individual, you now ask the individual, are you immunized or not? If the person tells you that he or she is immunized, then you have to give only the rabies vaccine. But if the person is not immunized, you give both the vaccine and the immunoglobulin. So that means that regardless of your vaccination status, that is why I don't like rabies. Regardless of your vaccination status, if you are bitten by an animal that is rabid, you will get something. You can't escape it. You will get something. So your vaccination is not actually 100% protection. So we have to be avoiding, cat or dog bite and say that should be I'm immunized, nothing will happen to me. You will still get something. If it's a wild animal, if the wild animal runs away, you treat as if the animal has the rabies and you vaccinate that individual. If the animal is available and you could lay your hands on the skunk, the fox, the bat, the raccoon, euthanize the raccoon, open up the brain, assess for rabies in the brain, you see the negri bodies. And if you can demonstrate the rabies, you know that, okay, I have to vaccinate this individual and you vaccinate. If there's no rabies, the individual is free to go. Do we understand that?
Please, I have a question. So, for the domestic animal, right? Even when the vaccination status of the animal is not known, we're quarantining the animal or the patient.
You quarantine the animal. It is the animal. You don't quarantine the patient. You watch if the animal is
Why?
going to develop rabies because you want to know if the source of the rabies is actually having the rabies. If you want to know if the source contact has the infection, do you understand? It's just like it's logical now, Dr. Miriam. I get pricked by a needle of somebody. Now, should I rush to go and take PEP? Why don't I calm down and ask the person, do you even have hepatitis? Or do you have HIV? Do you understand, Dr. Miriam?
Mm-hmm.
So you have
Yeah.
to ask, you have to find out from the dog, does this dog have rabies or not? You see, the reason why you
Okay.
are doing that quarantine is that if the dog has rabies, that dog will don't die, tete.
Exactly.
Yeah,
So,
the dog will have died. So if the dog is living, so the reason why you are quarantining is that if the dog actually has rabies, within 10 days, you will see signs and symptoms of the rabies. Do you understand? Because
okay.
it's possible that maybe
Yeah.
the dog got infected with rabies like maybe 3 days ago or something.
Mm,
So, but it's not
okay.
showing symptom currently. So quarantine and wait. So
Okay.
let's see what's going to happen in 10 days. If the dog did not present with signs and symptoms of rabies within 10 days, then it means that that dog no get rabies.
All right. Thanks.
Is it
Okay.
clear to you?
So, yeah. Okay, Dr. First, Dr. Babola also had a question. You said if it is a wild animal, you vaccinate the patient too. But if you also utilize the animal and there's no nigri but no signs of rabies, you let the patient go.
Yeah. You know, I gave you two situations. Can you lay your hands on the wild animal or not?
Oh, okay.
If you cannot lay your hands on the wild animal, then the next question you want to ask yourself is this individual that's having contact with this animal, is the person vaccinated or not? Because the person will get something. Because the wild animal don't go. So you just assume that the wild animal has it. Do you get it?
Yes.
So
Sorry, Chief. One more question. So, for the domestic, if the dog is not available, you just vaccinate the patient.
yeah. So if the dog is not available too, you ask for the individual status and you vaccinate accordingly.
Okay.
That's the way it goes. Yeah, that's correct. So let us look at maybe a question. Please, we should not miss this. Let us, because I want to be sure that we understand it. A 20-year-old man is brought to the emergency department for evaluation of an animal bite. He was hiking earlier that day when he was bitten by a raccoon. He says the attack was unprovoked and the animal ran away after the encounter. Immunization are up to date. Immunization shows that he has received 2 doses of DPT, blah, 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 blah. Now, he is in no apparent distress. Temperature is normal, blah, blah, blah. The wound is really, so the wound is thoroughly irrigated. What is the most next step in treating this patient? So what do we do for this patient?
Vaccine and immunoglobulin.
The
Yeah.
tetanus state of the patient and vaccinate.
The what?
Te- tetanus
Get the
care.
tetanus status of the patient, the immunization status of the patient, and then vaccinate.
Okay, so according to this question now, we have a scenario. What are we now picking now?
What is the
Rabies
scenario?
vaccination.
Rabies, immunoglobulin, and vaccine.
Uh,
And I'm not really sure why there's tetanus booster though.
Okay, you know what? Let me come back to this question after I've treated tetanus. So,
See, there's just, I'm so sorry, but Chief, can you scroll up a bit? Yes. So you're saying that we must give test because I'm seeing just an
no,
option
no,
of
no, no,
rabies,
no, no.
immunoglobulin.
You see, what I want to do is that I want you to be sure of your answer, and I want you to know why you are picking your answer, and you cannot
Okay.
do that now until we take the tetanus. Do you understand?
Oh,
So
all
let me
right.
just be quiet, and we do it when we take tetanus.
Rabies immunoglobulin and vaccine.
Yeah, we'll come back to it. 8-year-old boy is brought to the emergency department 3 hours after being beaten by the neighbor's dog. He was chasing the dog with a stick when it attacked him. He has fed the dog on multiple occasions and he has never been beaten before. The father saw the dog 2 hours after the incident and his behavior seemed normal. Vaccination, the last vaccination the boy was of varicella 2 years ago. He has never been immunized against rabies, not in distress. Examination of wound, I don't care about that. So the wound is okay. So what's the best next step in treating this patient?
Vaccine and immunoglobulin.
Any other option?
No, it's not that. Vaccine and immunoglobulin.
Hmm? It seems that we did not get this stuff. So
Please, can I read the question?
we are reading.
Yes.
An 8-year-old boy is brought to the emergency department 3 hours after beaten by his neighbor's dog. He was chasing the dog with a stick when it attacked him. He has fed the dog on multiple occasions and it has never bitten him before. His father saw the dog 2 hours after the incident and his behavior seemed normal. There is no personal or family history of serious illness in the family. The last vaccination of the boy received was against varicella 2 years ago. He has never been immunized against rabies. He is not in acute distress. Vital signs are within normal. Oh, so sorry. He's observed the dog for 10 days.
I mean, do we even need to be reading the remaining of the story, please? Do we need it?
Um,
We don't need
No,
it.
no, no. He's observed the dog for 10 days.
I mean,
mhm.
just observe the dog and decide what the dog is still there. So let's take the tetanus, then we'll go back to that. So um so somebody has a wound, and the next thing you want to ask yourself, is this wound clean or not? So most of the time, a clean wound will just be like an abrasion or a laceration. It's not going to have any debris in it. There's not going to be sound, not stone, foreign objects. Nothing is going to be attached to that wound. Then you can say that that wound is clean. But if there is gunshot injury, somebody has even laceration, but there's sand there, there's dust, there is a debris, foreign body. It's no longer clean. So after you have decided that, the next thing is now to stratify. Now, for the clean, now this one I have to use the table so that you can see what we are talking about. After you have identified, okay, this is clean, then the next thing you want to ask yourself, has this person taken the 3 lifetime toxoid of the tetanus? Have you taken the 3 dose? Yes. Okay. You have taken the 3 dose, you are immunized. Good man. Now, when was the last time you took your toxoid booster? Your toxoid booster. So your framework for clean wound should be within 10 years. If the person has not taken the booster within 10 years, I'm sorry, if the person has taken the booster after 10 years, for example, if you are meeting the person in 2010 and the last time the person took the booster was 1998, so that is more than 10 years. So that person has to get the Tdap, which is a vaccine. So the Tdap, which is going to be capital T, then you can get the diphtheria, the acellular pertussis, depending on what you want. If you can give the TD or your Tdap, but just make sure that your tetanus is there. So if the person has not taken the 3 lifetime toxoid, or the last time the person took the toxoid booster is more than 10 years, give the TD or the Tdap. Let me come again. Clean wound. You ask, have you taken your 3 doses of the toxoid? I have. Fine. Have you taken 3 doses of toxoid? No. The person has to take Tdap or TD. Okay. You ask, when was the last time you took your booster? I took my booster 11 years ago. That's more than 10. You give your Tdap or your TD. If the person takes it within 10 years, the person is okay. So, if the person has taken the 3 lifetime toxoid and the person has taken the booster within 10 years, the person is otherwise normal, no prophylaxis. Now, for other wound, that's so here you have to be careful. You have to be careful. There's some intricate cases here. Now, for other wound, which is a dirty word, you ask yourself the question again. Have you taken your 3 courses of the toxoid? Is it complete? If the 3 toxoid is complete, that is good. But if it is not complete and the person is having a dirty wound, the person has to take TD or TDAP plus the immunoglobulin. Can we see that we need to, calm down a little here? So, the person has a dirty wound and the person has not taken the 3 toxoid doses. So you have to give TDAP or TD with immunoglobulin. Now, if that is not the issue, but the issue is that the last time the person took the booster is more than 5 years. So it's just booster. It's just booster. Let me just give you. So in that situation, you just give only the TD or your TDAP. But if the person last took the booster within 5 years and the person has taken 3 lifetime toxoid, no prophylaxis. Please, does this make sense to us?
Chief, please. I'm a bit confused for these dirty wounds. But I have a question for the clean wounds. Let's say the person has had 3 lifetime toxoids, but no booster.
Yeah, you are still going to give TD or your TDAP.
Okay, so it has to be both.
No, you are going to give, like, I don't understand what you mean, but it has to be any one of them. Like, okay, I get what you're saying. Like, both of them have to be in, like,
Yeah, present.
present. Yes, both of them have to be present because as you are taking your toxin, you have to be taking your booster to maintain the immunity.
Okay.
Do you get now? So that is
Yeah.
it. Now for the
So
dirty,
for the dirty wound, is it like um okay, I get it. Okay.
so for the dirty, you ask, how long have you taken your 3 doses? That's the first question. Have you taken your 3 doses? Number one, before we even start talking. Have you taken your 3 doses? Okay, yes, I've taken. That's good. You proceed to the next question. But if the person has not taken the 3 doses, you just give your your vaccine, which is your TD, your TDAP, with the immunoglobulin. So you are providing both active and passive immunity. Because you know that you have zero tolerance if it's dirty. If it's dirty, there's a high chance of the tetanus. So you have to provide both active and passive immunity. Do you understand, Dr. Miriam? But if it's
Yes, I do.
if the lifetime 3-1 is satisfied, then you now ask, what about booster? But your limit for the booster is reduced to 5 years, not 10 years, like in clean. So you bring it down to 5 years. You know that if the person takes the booster within 6 years, for clean wound, you do not do anything. The person is okay. But for dirty wound, if it's
Yeah.
6 years ago, it's bad. So you still have to give your TD or your TDAP. So now, you don't worry. I will see if you understand it
Okay,
now.
so so
Mhm.
sorry for the dirty wounds. So it's either that the patient has not received the 3 full doses, or the booster is greater than 5 years, or does it have to be like the both? Like this patient has a dirty wound and has not received the
You know what? You know
immunizations
what?
at all and has not received
Let me
the
let me
booster
let
at
me
all.
let me transfer that question to Dr. Miriam and let me see how she's going to respond. I'm coming, Dr. Antonia. So, Dr. Miriam, if somebody has dirty
Yeah.
wound, and the
Mhm.
person has taken the person took the booster 4 years ago, and the person has not completed 3 course of the tetanus toxoid, what are you going to give?
You give your vaccine plus immunoglobulin.
Fine. So
But sorry, in real sense, do they give booster without completing the 3
no, they
lifetime
don't. They don't do
toxoid?
that. They don't do that. I'm just creating that
Okay,
situation for you.
yeah, I get. I
Do you
get.
understand? So ideally, of course, person where they remember to take booster, of course, it means that the person is even compliant with the 3 lifetime one. Do you
Yeah.
get it? So, Dr. Antonia, the first question is ask yourself: 3 lifetime, is it completed? If it's completed, good. If it's not completed, you have to give both passive and active. Now, After you have moved away from the booster and from the toxoid, from the 3 lifetime toxoid, you don't stop there. You still ask, when was the last time you took your booster? If the person took the booster after 5 years, like the last time the person took the booster was 5 years and like 6 years and more, then you have to give, your TD or your TDAP. Do you get it, Dr. Antonia? Hello?
Okay, what if the person has
Just give me any
yes?
situation. Give me one situation. Let me just answer you. Just give me
What
one
if the
scenario.
person
Eh? I can't hear how.
has not received booster? What if the not a dating wound has completed? Oh my god! Hello, can you hear me
Yes,
now?
yeah, I can now.
You said if the person has completed the three doses.
Mm-hmm.
If the person has like dating wound, if the person has not completed the 3 doses, you
Yes.
give both vaccine and
Yes.
globulin.
Yes.
If the
Yes.
person has completed the 3 doses,
Mm-hmm.
you don't give.
No,
Now,
if the person has completed the 3 doses, you now ask for the what?
has
The
he
booster.
received the booster? That's what I'm
Yes.
saying. So
Mm-hmm.
if the booster is more than 5 years,
Mm-hmm.
you give booster.
You give booster.
Now,
You give
what
booster.
if the person has not even received? You also give booster.
Yes. If the person has not
Mm.
received, give booster. You start it for the person. Do you understand?
Yes,
So now let's now go back to
yes.
question one. Marry the two knowledge together and answer question one. So make it no be like say at the rush, because I know that's what we are talking about the other time. Let Dr. Miriam answer it, and I will know that we are the one that answer it ourselves at our own pace. So, Dr. Miriam, over to you.
A 20-year-old man is brought to the emergency department for evaluation of an animal bite. He was hiking earlier that day when he was bitten by a raccoon. He says the attack was unprovoked and the animal ran away after the encounter. His immunizations are up to date. His immunization record shows he received 3 doses of DPT vaccine as a child and a um, DPT vaccine at the age of 16. He is in no apparent distress. His temperature is 36.9, pulse is 72, respirations are 18, blood pressure is normal. There is a wound on his left lower extremity with actively bleeding puncture sites. The wound is thoroughly irrigated with normal saline and cleansed with antiseptic, and a bandage is applied. Which of the following is the most appropriate next step in management? So he was bitten by a raccoon, wild animal. The raccoon ran away. So we're going to give him the um, prophylaxis regardless. He has not had any immunization for rabies, so we give um, vaccine and immunoglobulin for rabies.
Good job.
Then the wound is he has had 3 doses of DPT when he was a child. Then he now had another one again at 16, and he's 20 years old. So it's within, and it's a clean wound. So it's still within the 10 years frame. So you give just rabies vaccine and immunoglobulin.
Fantastic job. But the only error you made was that it is not a clean wound, but it doesn't change the answer. You see, animal bite
Oh,
is never a clean wound.
okay.
Animal
Okay.
bite is never a clean wound, so it's a dirty wound. So, but you did a very good job. So even if it's a dirty wound, it's still within 5 years. You get, because this is 4 years. Do you get? So you
Yes.
will still not
Okay,
give
yes.
your TDAP. So that was a very good, brilliant analysis. Okay. Um. So moving on to the bites and the stings. So the first is the bees and the wasps. They can cause anaphylaxis. We know how to manage anaphylaxis. We are senior people. The spiders, two spiders, black widow and brown recluse. So the way I picture it is that black widow is the one that will be making you shake. So they will cause muscle spasm. In fact, they can make the abdomen rigid. So if you see somebody having a bite and the person having a rigid abdomen with muscle spasms, seizures, think about the black widow. Now, the brown recluse, it sounds like necrosis. Recluse. Necrosis. So you start seeing brownish discoloration of the skin, necrosis, and what? DIC. You see, once you can remember this, I never see that question that you can't solve. You will get it. So how do you treat both? Usually for the black widow, you give your antivenin, right? Give your antivenin, and I don't want to talk about the other ones. Just give your antivenin. That's all. The only one that you might not give your venin stuff is maybe the brown recluse. For spider, for snake bites, any other thing, give your antivenin first. But for your brown recluse, because of the necrosis, give a cold compress to slow down the necrosis. Dapsone can also help, but make sure the person does not have GCPD. USMLE can be tricky. They'll put GCPD there and they will, you have to be careful. Don't pick Dapsone. So debridement to limit the necrosis. So don't forget, one compress, reduce the necrosis, debridement, Dapsone. Spiders. Scorpions. Now, scorpion will cause neuromuscular toxicity. They will cause motor problems. They will cause cranial nerve issues. Now, this scorpion causes like a failure of inactivation of the sodium channels. So you have hyperactivation of the sodium channels. It means that if you have hyperactivation of sodium channels in your autonomic nerves, you are going to be having hyper functioning of those nerves. So there's going to be tachycardia, increased heart rate, hypersalivation, increased sweating because they are working excessively. Just picture that the motor nerves, they are working excessively. What's going to happen? Jerking, seizures, fasciculation. Cranial nerves are working excessively. There's going to be problem with swallowing because of hypercontraction. You cannot swallow. Bulbar problems generally. Problem with the high blurry vision. Problem with the maybe 12th, the 10th and the 9th cranial nerve, they cannot swallow. Problem with oculomotor nerve, abnormal eye movement. So just picture it along that line. The cranial nerves, neuromuscular, autonomic. Autonomic, are just discharging. Increase heart rate, increase salivation, increase sweating. The motor, hyperjackiness, fasciculation, seizures. Cranial nerve dysfunction, dysphagia, abnormal eye movement. You can see very easy. Like just know the mechanism. So give your antivenin. Give your antivenin. If the person is having spasm, fasciculation, give your benzo, an analgesic for the pain. For the snakes, the crotaline snakes, they also cause necrosis, just like the brown recluse. They can cause DIC, just like the brown recluse, and distributive shock. So most of the time, they will not put both of them together so that you don't get confused, right? Because it could be any one of them. They can both present similarly. So give your antivenin for your snakes, which is the crotaline polyvalent immunofab, the FAB fragment of the immunoglobulin. That's the mainstay antivenin. Then you keep the limb above the heart. So it takes a longer time to travel to the heart. Never pick stuff like compression band, tourniquet, fascia. Never pick that. The only thing you are watching out for is what? Keep the limb elevated above the heart and antivenin. For people with dog bites, because they can develop tetanus, rabies, just like we said, an infection. So and that is automatically what? A dirty wound. Don't forget that. So give amoxiclav, right? Give amoxiclav. Sometimes, if they have injury to the hands and feet, you have to give the antibiotics too. People that are immunosuppressed, give them antibiotics. Then you might need to do imaging for people with cat bite because the teeth of the cat ones are smaller and they are sharper, so they can dislodge into the wound. So you have to be sure that there's no retained teeth fragments. Human infection. Person bite you for hand. Give amoxiclav because the human teeth contain a lot of microbes, Echinella, Kingella, and all those things. So give amoxiclav. Dog bite, cat bite, give amoxiclav. Human bite, give amoxiclav. Rodent, low risk of infection, don't give anything. Just local wound care. But people with the vibro infection, funificus from shellfish handling, probably they go to the sea, they handle salt water, they have a wound infection, and they suddenly tell us that they start developing necrosis with bullous formation. So you are thinking of necrotizing fasciitis because the cause of necrotizing fasciitis. So, think of vibrofunificus and you give IV doxy and ceftriaxone. Then you debride. Of course, you have to debride necrotizing fasciitis. It's very common in people with background liver disease, like hemochromatosis. So if you don't understand this, let us take a break. We'll come back in the next 15 minutes by 9:30, 10:30. We should be able
Chief,
to finish.
sorry, please.
We'll skip all this one.
Sorry to take us back.
Yeah. Some.
For the tetanus prophylaxis, if
Mhm.
the patient has had, the 3 lifetime toxoid, but the patient has no booster, you give your vaccine alone.
Yes. Give your vaccine alone.
Okay. Okay.
So, I'm talking about toxicology. I think the high yield ones to pay attention to. Just don't forget, in toxicology too, you have to do your ABCD, resuscitation, check the airway, check the breathing, check the circulation. You might need to, use your ECG to also help you with the finding. For example, people with TCA poisoning, they have some, ECG changes, widening QRS complex, um, QT interval prolongation, and the like. So that could, heighten your suspicion for some of those poisoning. And it's also good, to take note of the decontamination procedures, and major stuff you want to do is just to, if there's any clothing that they are wearing that is contaminated with the chemicals or this poison, you have to remove it. You might give them some items that can help them reduce the systemic absorption, which is activated charcoal. But you don't give activated charcoal to people that are um, that have ingested the metals. So this includes lithium, iron, lead. So people with iron poisoning, people with lead poisoning, lithium, you don't give charcoal. You don't give charcoal in people with acid-base poisoning. You don't give people with hydrocarbon poisoning or toxic alcohol poisoning like ethanol, ethylene glycol. You don't give them charcoal. So don't forget, acid-base, alcohol, hydrocarbons, and the metals, they don't take activated charcoal. So you can give activated charcoal in something like maybe acetaminophen toxicity. So never pick Ipecac syrup as the answer. Never. Just forget about it. Never pick this. You will never be correct. So don't pick this. Never pick this. So moving on to CO poisoning. So this is very common. People that get exposed to fumes from exhaust generator, old appliances, automobile, and the likes. The symptomatology usually begins with headache, and they can become confused with time. So headache is number one. You have headaches, confusion. You can see some skin changes, which is the cherry red discoloration, but it's not specific because it's not only carbon monoxide poisoning that can cause this. They can progress to coma, seizures. They can have chest pain from ischemia, angina-like presentation, and the like. Um, so sometimes when they present to the hospital and you see the singe, nose hairs, facial burn, you know that, oh, there's a likelihood that this person had an inhalational injury, and you quickly want to intubate. Please, this is not the time to be managing carbon monoxide poisoning. You see, once you see someone that having singe nasal hair, facial burn, wheezing, carbocation symptom, you want to look at the other respiratory parameters. Look at if they have placed the person on maybe max ventilation. Look at the SpO2. Is it improving? Like, is it good? Look at the respiration rate. Look at the sensorium. If you see that all those things are not fantastic, just immediately go and intubate that patient. Because if you check the airway of people that have this smoke inhalation, having all this singe nasal hair, facial burn, there's going to be edema of that airway. So in fact, you don't want to be doing fluid administration because you even worsen that edema. You want to intubate first. So, and people that get exposed to all this smoke inhalation can develop carbon monoxide poisoning. They can develop cyanide poisoning, and you have to manage all those things. But the most important one is to keep the patient alive, breathing, by securing the airway. So you want to assess for your serum by carboxyhemoglobin level by doing your carboxyl oximetry. So this is very good because your pulse oximetry might be normal because it will not be able to identify or separate carboxyhemoglobin from oxyhemoglobin. So it's going to appear being normal. So to identify it, you have to do a carbon monoxide oximetry test. And in normal individuals that are non-smoker, it should be less than 5%. While people that are smoking, they should have it less than 10%. So you must also perform an ECG. You should not forget that. The reason why you are doing ECG is because you can see some changes indicative of ischemia. Why? Carbon monoxide binds to hemoglobin. At the same time, it binds to myoglobin in the muscle. So if it binds to myoglobin in the muscle, it prevents the cardiac muscle from utilizing oxygen. So they can have cardiac ischemia. So that's why you can monitor with your ECG. And also you have to rule out pregnancy because it's very bad in pregnant people. So because it's going to bind to the fetal hemoglobin, reduce oxygen delivery to the baby, and can kill that baby. So rule out pregnancy test to ensure that the patient is not pregnant, because that's going to change the modality of treatment. If somebody is pregnant and is having carbon monoxide poisoning, you are not going to be giving 100%. You are going to give hyperbaric oxygen immediately. So it changes the diagnosis and it changes the treatment rather, not diagnosis. So um so a patient with carbon monoxide poisoning having confusion, having headache, nausea, vomiting, malaise, fatigue, they just took the person from a burning building. They're thinking this is carbon monoxide poisoning. Just give 100% oxygen, right? 100% oxygen until the patient is asymptomatic and the carbon monoxide level falls to normal. But if the patient is pregnant, give hyperbaric. If you measure the carbon monoxide level with your CO oximetry and it is more than 25%, give hyperbaric. If the person is having CNS complaints, seizures, patient is having myocardial ischemia, you can see it on ECG, give your hyperbaric oxygen. So signs of CNS injury, cardiac ischemia, pregnancy, severely elevated level, more than 25%, give hyperbaric oxygen. And don't forget, intubate early. You can see, in fact, most of the time that's going to be your answer. Intubate early. In airway burns, smoke inhalation, upper airway edema can lead to rapid, complete obstruction. So you have to have this at the back of your mind. Intubate early. So, key fact, in carbon monoxide poisoning, the measures O2 saturation is usually normal. I have given us the reason because you use your pulse oximeter to measure it and it does not differentiate oxyhemoglobin from carboxyhemoglobin. Methemoglobinemia. So this just means you have given an agent that has converted the ion in hemoglobin from Fe2 plus to Fe3 plus. And you call that methemoglobin. That usually occurs when the individual has been exposed to any of the oxidizing agents. Local anesthetic agents, benzocaine, dapsone, nitrites, all of them can oxidize to Fe3 plus. So now, how will the patient present? They can also have presentation similar to carbon monoxide poisoning, the headaches, the confusion, nausea, vomiting, and the likes. The blood is going to be turning chocolate colored. Have a suspicion for methemoglobinemia. And what do you want to do? So this one is not really associated with burn injury or smoking inhalation, so you might not be thinking of airway issue. So you just want to get the history of, have you used any of this? You are seeing cyanosis, you are seeing chocolate colored blood, you know that this is definitely meth you are dealing with. So don't rely on pulse oximetry. Don't rely on partial pressure oxygen because you will not get anything. You can't trust that result. So you have to do your direct methemoglobin measurement using carboxyl, like your CO oximetry reading. So your CO oximetry can also tell you the amount of methemoglobin that you have in circulation. So it can help you, and you can estimate. So your pulse oximetry is going to be low because your met is going to bind to maybe one part. For example, if you have hemoglobin, you have 4 ions attached to hemoglobin. One or two of them is going to differentiate to the Fe3 plus. The other ones will be normal. Now, the Fe3 plus part is going to be adhering to oxygen, and it's not going to be readily releasing oxygen, and it's going to reduce the binding of the other one, the Fe2 plus, the remaining Fe2 plus to oxygen. So that means that saturation is going to drop. So that might be picked, with your pulse oximetry as a low saturation. But the partial pressure of oxygen that is dissolved in plasma, the one that's dissolved in blood, is your PO2. So that's the one you measure when you say you want to do your blood gas, your arterial blood gas. So that's what you want to measure, PO2. So that to be falsely normal, because that's just the one that is dissolved. We are not talking about the binding one. So it's going to appear falsely normal. Yeah. So that is why you have these changes. So have that in the back of your mind. And the treatment is just methylene blue or vitamin C. Just give something that will help reduce the Fe3 plus back to Fe2 plus. So I'm not going to be taking all these parts. We just have to go and, just read them. They are just, the notes are there so that we don't waste time. There are a lot of simple stuffs. Just read, because it's just more like this, that, it's a lot of. So let's just go to trauma management, right? So trauma management, it's been said here, there's so many detailed stuff that is beyond the scope of USMLE question. So, going through the USMLE question, I've seen that there's some specific that you just want us to know. We don't have to know everything. Just know some basic stuff and you are okay. And the number one basic stuff is that establishing and maintaining airway patency takes precedence over all other treatment. If you know this, you have solved like 50% of the problem. Establishing and maintaining the airway patency takes precedence over all treatments. Remember to intubate when your GCS is 8 or less. I have said this, we have talked about this more than 20 times. So everybody knows it by now. Once your GCS is 8 or less, intubate that patient. The patient is having respiratory failure, hypoxemia less than 60, percapnia more than 50, hemodynamic instability, intubate that patient. So, what is the basis of management of trauma? Your primary survey and your secondary survey. Now, what is your primary survey talking about? You just want to quickly do your ABCD assessment. You quickly want to take care of emergent, injuries that can kill off the patient very fast. Stabilize the patient and now take in for your secondary survey. So ABCD approach: your airway, your breathing, circulation, disability, and exposure. So what are you looking at in the airway? Can this patient talk? Airway is intact. If your patient can talk, airway is intact. But if your patient cannot talk, you know that there's possibility of you having an impediment within the airway. Now, what are the things that can affect the airway? So it's being categorized for us. You can have a structural airway damage in which you have like maybe tracheobronchial, rupture, tracheobronchial injury. You have a rupture of the tracheal or the bronchial airway. And how are you going to know? Of course, if the trachea ruptures, it's going to start tracking, into the mediastinum. So, and the soft tissues of the neck. So the person is going to have subcutaneous emphysema. By the time you start touching the neck, you see that neck is swollen. You touch the neck, there's going to be crepitus, right? If the person is breathing, you are going to be hearing like gurgling noises, which is because of the hair. And if you look at the airway, you see, blood there, maybe from bleeding vessels, Then airway compression. So the airway might not rupture, you might not see subcutaneous emphysema or gargling noise, but you
I
might.
can't hear.
Hello?
Hello. I think it's your network.
Whose network? My own or Dr. Joy?
No, no, no. Doctor.
Okay. I think maybe you should join and reconnect. But Dr. Miriam, you can hear me well.
Yes.
Okay. So I think the doctor should reconnect. Is that Dr. Joy? I think Dr. Joy, please reconnect. So airway compression. Now, airway compression can occur if there's like hematoma. You can have compression on the airway. Now, how do you know? You start seeing dysphonia, hoarseness of voice, stridor, expanding neck mass. You see, once you are seeing that, you know that this airway is going. Intubate, dysphonia, stridor, hematoma, hoarseness, Please go and intubate. Airway compression. Somnolence, GCS less than 8 or less. Please, we are going to ICU. It's as straightforward as that. Thermal or inhalation injury, we have talked about this. This is like the 10th time I'm talking about this. So you see nasal hair that is burnt, carbonation sputum, facial burn. You know that this is likely to be inhalation injury. By the time you try to look into that airway, you see that the larynx, they are kind of inflamed already because of the inflammation. Intubate immediately. In fact, do not delay that intubation by giving IV fluid because it can worsen the edema. How do you do your airway management? Now we have said it. Okay, we don't hear you, sir. We want to intubate. We want to secure the airway. Now, what are we going to do? The most preferred method is to do endotracheal intubation. That's the best. I can assure you, you will pick endotracheal intubation tire in your exam. There's no way. You cannot go for that exam and you not pick endotracheal. It's not possible. It is not possible because you see surgery questions. This is surgery we are doing. You are not going to do surgery anywhere. This is surgery we are doing. So, you must intubate. Always have that at the back of your mind. That, okay, I am seeing intubation in this option. Please, before I don't pick intubation, let me rule out that there's nothing that will make me intubate before I ignore this intubation. Please and please, check that question. Look at the vitals. Look at the respiration. Look at the sensorial. Is there anything that can point towards intubation? If you see, you just need one thing. See it, go and intubate. And the preferred one is what? Endotracheal intubation. Very, very important. Then you can do nasotracheal intubation by passing the tube through the nose with a rigid fiber optic bronchoscope, particularly if a patient has a tracheobronchial tree that is ruptured. So, for example, if somebody has a ruptured tracheobronchial tree, how do you know? Dr. Antonia, if the tracheobronchial tree is ruptured, how do we know? Dr. Antonia is sleeping. Dr. Miriam,
Chief.
if there's ruptured tracheobronchial tree, how do we know?
I'm not sleeping, it's my network. There'll be
Okay.
continuous leakage of air.
I trust you. I trust you. I know that you are not sleeping. So there's continuous leakage of air. You'll be saying what? Crepitus, subcutaneous emphysema, right? Gargling noises. As the person is breathing, you're hearing gargling noises. That is tracheobronchial. It's very classic. We are going to start talking about the Hammond sign with time. We see it. Like all these crunching sounds as due to the lung movement. They are rubbing against the hair. Crunching sound. That's Hammond sign. It's classic for tracheobronchial intubation and rupture. Now, you want to do that. So the preferred one is to do nasotracheal intubation. But the only condition, because you need something rigid to help you guide it through the airway. Now, the only condition where you don't want to do nasotracheal intubation is when the individual has a basal skull fracture. So if there is basal skull fracture, because there's a tendency it can dislodge into the cranium, go to the brain and puncture the brain. You don't want that to happen. So don't do nasotracheal intubation because the nose is like at the level of the base of the skull, kind of. So you don't want to allow it to just dislodge into the brain and penetrate into the brain. The next is to do emergency cricothyroidectomy. So if you can't do endotracheal intubation and you can't do nasotracheal intubation, the next is to do cricothyroidectomy. So you make a hole within the cricothyroid membrane. You can do it if all these ones are not possible. Then the last resort, most of the time you won't get to this level because it's kind of debilitating. Emergency tracheostomy. In general, never to be done. Let's see. Choose cricothyroidectomy. This one is very fast. Just palpate, identify that membrane, puncture it, make a hole. That's that about the airway. We have secured the airway. Now the next thing is to check the breathing. Is the chest rising? Can we hear breath sound? If the chest rising, okay, this person is actually ventilating, right? Can we now hear breath sounds? Is the air moving into it? Can we hear breath sounds? Okay, we can hear breath sounds. It means air is moving into the lungs. Is the air that is moving into the lungs getting into the vessel across the capillary membrane, which is going to be reflecting as what? Increased oxygenation. So you must have these three to be able to say that the oxygenation is adequate and the breathing is good. Now, you can have some situation in which the patient will have bilateral breath sound, good chest rise, but cannot oxygenate. For example, an individual with ARDS, air is going to be entering, the chest is going to be rising. Of course, this person doesn't have flat chest. The chest will rise, the breath sound will be good, but your oxygenation status will not still improve. Why? Because of the fluid in the lungs, the collapsed lungs. There's no way they can, get the air into the blood because the respiratory membrane, everything is kind of damaged. So in that kind of person, you still need to intubate and mechanically ventilate that person. You intubate, open the airway mechanically, and ventilate that person. So all what is just here are just clinchers. They are not like reminders for us. If the patient has unilateral breath sounds, think pneumothorax and pneumothorax. This is basic stuff. It is very, very basic. Unilateral breath sounds. Only one side. It's either a pneumothorax or an pneumothorax. And what do you do to separate them? Per course. If it's resonant, pneumo. If it's dull, hemothorax. So you can do your x-ray if the patient is hemodynamically stable. If not, just insert your chest tube and drain. Don't forget. If the patient is having tension pneumothorax, do you insert test tube first?
No.
No. You put your needle. Oh, Dr. Antonia's network is dragging. So you put your needle at the second intercostal space, mid-clavicular line. Then you put your chest tube at your fourth intercostal space, mid-axillary line. So that's later, right? Now, if a patient is having tension pneumothorax, so that means you must be able to identify a large pneumothorax for a tension pneumothorax. It is important in surgery. Open pneumothorax, a large pneumothorax and a tension pneumothorax. Once it's tension, you are seeing tracheal deviation, needle. If it's large pneumothorax, tube. Very important stuff. Very, very important stuff. If after you have intubated, you are now hearing unilateral breath sound, you know that this is likely going to be, for example, you are hearing unilateral breath sound on the right side. So that means you have done a right main stem bronchial intubation. Instead of putting it at the carina, just above the carina, so that I can go into both bronchioles, you have now entered one bronchioles. So that is main bronchioles intubation. Now, if this person is on mechanical ventilation like this, what pressure parameter will be elevated in this patient? Let me see if you can remember our mechanical ventilation parameters. Which one is going to rise? Anybody?
The patient with pneumothorax.
Sorry, if the patient.
If the patient has received a right main stem bronchial intubation, how do you know?
Oh, that.
Okay, resistive pressure.
Yeah.
So which pressure will be elevated?
The resistive pressure.
What does resistive pressure indicate now?
Flow.
But this is not
As
flow. I said it that day. This is not flow. This is,
compliant.
yes, because the lung will see it as if that other one, your mechanical
Is
ventilator will see it as if that other one has collapsed. That is it. It will be as if it is not compliant, that it has collapsed. Whereas it's not the fault of the lung, it's because the lung is not getting oxygen. So which pressure is going to be elevated?
the plateau
The
pressure.
plateau pressure. The plateau pressure is going to be elevated. Please, you have to pay attention to all these things. If there's no kinking, if there's no mucus plug, if there's no narrowing of the tube, don't pick restrictive. Don't pick it, please. So that's that. Drop the tube above the carina so that I can intubate both bronchioles. Now for the circulation, evaluate for shock. Usually when the SVP is less than 90, that's when you can say the person is in shock. It's going to be fast ready, pallor, diaphoresis. And there are three major causes of shock in trauma that you have to pay attention to. Hemorrhage, which is number 1. Tension pneumothorax, number 2. Cardiac tamponade, number 3. So hemorrhage, the person is just bleeding, And the bedding bleeds into like 4 compartments, except the head. The head cannot take in blood because the skull is unyielding. As the blood is accumulating, the person will have cold. But the chest can take in blood, the abdomen can take in blood, the pelvis can take in blood, and the external person can be bleeding to the environment, they can take blood. So evaluate for injury to the chest, the abdomen, the pelvis, extremities, and the floor, which is external, if somebody is having hemorrhagic shock. So you cannot pick intracranial hemorrhage as a cause of hemorrhagic shock. That would be ridiculous. Chest injury, abdominal injury, pelvic injury, bleeding into the thighs. The femoral space can take like 4 liters, and of course the floor. So intracranial hemorrhage is never a cause of hypovolemic shock. And what do? You place your 2 white ball cannula and you administer isotonic solution. Now, there's another school of thought. I just want us to have it at the back of our mind that you only administer 1 liter of isotonic crystalloid. I put it here. And if you fail to get any hemodynamic response after administering 1 liter, you give blood immediately. You give blood. The reason is that studies have shown that if you repeat another liter again, there's a high chance of you tilting the person towards the later triad fast. The later triad of hypothermia, coagulopathy, and metabolic acidosis. Yeah, acidosis, coagulopathy, and hypothermia. So give blood immediately. Don't waste time giving acetonic fluid. Yeah. So most of the time you want to transfuse as you are giving. Now, if you want to give blood, you can give your packed red blood cell, particularly if the person is losing bleeding, maybe losing blood, not like person having dehydration or having like a burns injury, like someone is bleeding active from a trauma. So you can give packed red blood cell, right? While you look for the source of the bleeding, and if you have given 4 units of packed red blood cell, you must administer 1 unit of FFP. That's the ideal stuff. But if you know you are going to be giving somebody a lot of blood, massive blood transfusion, that is, you are giving like 5 liters in like 24 hours. Like giving like the whole blood, in like 24 hours. That's a lot of blood. So you have to use the 111 algorithm. So somebody with an obstetric emergency, someone with severe trauma that requires so many pints of blood, and you know you are going to do a massive transfusion, do the 111 approach. 1 FFP, 1 platelet, 1 packed red blood cell. So you are mimicking whole blood with this. So this is very important. With this now, you are going to reduce the lethal triad, blah, blah, with your isotonic crystalloid. And you are going to create, the same physiologic situation as you giving whole blood. So don't forget about this for massive transfusion. 111, 1 platelet, 1 FFP, 1 packed red cell. Now, that is hemorrhagic shock. The next is tension pneumothorax.
Dr. Baba, I had a
Yes, Dr. Antonia.
So with the like you said something about transfusing packed red blood cells. Apart from the 111, I understood it, but you said something that if you are transfusing blood after the 1 liter of IV fluid, isotonic fluid,
Yeah, so
you
what I'm saying,
transfuse packed red blood cells
yeah,
by
yeah,
4 pints.
that was leading to the blood transfusion. So what I'm saying is, if you have given somebody 1 and you are not getting any changes in the vitals, instead of repeating another 1 liter of
Mm-hmm.
crystalloid, go and give blood.
Mm-hmm.
Do you understand? Give
Mm-hmm.
blood.
Red blood
So
cells, okay.
yeah. So tension pneumothorax. I want us to go and solve questions. You will see them. Solve questions, you will see it. So tension pneumothorax, don't forget the clinchers, the hypotension, and most importantly, your tracheal deviation. Don't forget that, please. You are going to have unilateral breath sound and hyperresonance. That can help you. You do your needle decompression immediately, and you insert your chest tube later for definitive treatment. Do not wait for chest X-ray to intervene. It's very straightforward. So this is tension pneumothorax here. We can see the trachea deviating to the right. We can see the collapsed lung. We can see the hyperlucency. Very classic. Now, the third cause of hypotension. And the reason why they are going to have hypotension is why? Because of kinking of the SVC or the IVC. Don't forget that. So, cardiac tamponade is the last. And the triad of hypotension, muffled heart sound, and jugular venous distension is going to help you. You confirm your ultrasound, and you can open a pericardial window, do a pericardiocentesis to extract, or just do open thoracotomy, enter and drain the fluid. You know, if IVR cannot be obtained after multiple attempts, you put in a line in the bone, very important, intraosseous, very important. Don't forget that. So we are done with the circulation, and we have talked about the common problems of the circulation. Now, moving on to the deficits, deformity. So here you are just basically talking about neurologic approach, neurologic evaluation. That's what you are doing. Calculate the GCS, look at the pupils. Calculate the GCS, look at the pupils. Calculate the GCS. So somebody having uncal compression of the oculomotor, all those things. This is where you are going to pick them, right? So GCS will tell you, okay, the conscious level. If the person is going, there's a need for intubation, you will pick it from there. Now, you can also assess for the spinal cord. So basically CNS examination, check if there's movement of the limbs, the arms, any sensation abnormalities, synesthetic tone, just step of injury, like palpate along the spine to see if there's any indentation or step off, or deformities. This is also where you ensure that the person is euglycemic, euthermic. So measure the temperature, measure the blood glucose, because for all I care, it could just be like, so sorry, please 1 minute. So sorry about that. So it could just be that the person having hypoglycemia. So measure the glucose, body temperature, and treat accordingly. So then the exposure, including cover with one blanket for people with hypothermia and the likes. So these are another key facts. For the fact that you can palpate the carotid pulse, it means that at least the blood pressure is at least 60 for the systolic. If you can palpate the femoral, it is at least 70. If you can palpate the radial, it's at least 80. So that can give you an estimate of the blood pressure. So now secondary survey is now talking about ABCD approach, your head to toe exam, and taking the history. So this is when you now start taking your history. Usually they take the ample history in your primary survey, allergy, medication, I can't remember the other ones. We can check that out. So, but for secondary, this is where you start doing like your full examination. You take the history, detailed history right now. So then you can also do some imaging, check the x-ray to see if there's chest x-ray to see if there's any problem. ARDS, you can pick it in pneumothorax, hidden hemothorax, you see it on your x-ray of the pelvis, depending on the mechanism of injury, trauma that patient had. You can do it fast. We'll talk about this shortly. Ask information about the mechanism of injury, group and cross-match blood. You'll have resuscitated in your primary, so you want to insert your catheter to measure urinary output. Don't forget, I said that urinary output is the best measure. You show that the person is improving. Don't forget that. People on mechanical ventilation, if you have, intubated them, you need to put in an orogastric tube so that you can decompress the stomach, and sometimes you might need to order some radiologic studies, CT scan of the head, people with head trauma, people that had loss of consciousness, drowsiness, facial injuries, skull damage. There's no way somebody will come with trauma to the head and the person had history of loss of consciousness, neurologic deficit, altered sensorium, and audacity of the head. That's bad. It's unacceptable. So there is a cervical spine CT that needs to be done for patients less than 60. we call that the Nexus criteria. And I put in this acronym NSAIDs, NSAIDs, the S for the spinal cord, the A for third sensorium, the I for intoxication, the D for distracting injury. Then I think the S is also for spinal tenderness. So it's the same thing, yeah. So spinal tenderness for the S, A for the altered mental status, I for intoxication, D for distracting injury, and S again. So now, anybody that is less than 60 and the person has any of these, you have to do like your cervical spine CT scan to see if there's any problem with the spine. If you identify anything, then you proceed to do a full spine imaging, not confined to the cervical. You do full scan imaging. So distracting injury just means that somebody is having like bleeding in the lower leg that has a high chance of distracting you, you know, um, and the person is less than 60 and having ultrasensorium and the likes. Just do your cervical spine CT of it. So it depends on the mechanism of injury. If it involves the head, you have to do your cervical spine despite that distracting injury. So because your head is important, it can kill faster than any other thing. So the physician should always rule out urethral injury before placing a urinary catheter. We are going to talk about it. It's very simple. We're going to talk about it. Let me see if we have any question. I'm not sure I put in question here. Yeah. Okay. Let's just have that. This is just like the framework we're going to be working with. So this is the head. So penetrating injury is still a little bit simple. You don't really have much here. So penetrating injury to the head, what do you do? Injury to the face. More like if you have penetrating injury, like you have like knife injury to the face and acceleration. So, if the patient is hemodynamically stable, you can order CT. Now, what I want to say about CT is that if you don't know anything in the exam, you are confused. Now, if the patient is hemodynamically unstable, never pick CT. Don't make that mistake of picking CT. In 99% of the time, you'll be correct. If you don't know anything, I'm just confused. What do I pick? Eliminate CT. At least that will help you narrow down your answers. Once the person is hemodynamically unstable, don't pick CT. Just throw it out. So, for patients that are hemodynamically stable, you can do CT scan of the brain to assess for degree of intracranial injury. Probably the person had like laceration injury to the head, puncture the head with a knife or something. So for facial laceration, you have to test for the integrity of vessels, do your CT, do your testing of the nerves to see your facial nerves are intact, because facial nerves is basically what drives the motor function of the face, while your trigeminal is what is responsible for the sensory. So look at them if they are working fine. So if there's any facial laceration, just close with primary intention after a wash. So it's not very acute. For the eye injury, so you can have a penetrating injury to the globe. So, and you can have intraocular foreign bodies dislodge into the globe. Now, when you have a globe injury, there's some manifestations you are going to see. And number one is the volume loss. So the globe is going to look smaller because you'll be able to even see the bone. The high, like it will appear sunken because you are losing that eye content. You're going to see like teardrop shaped pupil. So this means that you have already lacerated the iris. So the pupil is more like an aperture in the iris. So if you lacerate the iris, you are going to widen the pupil and it's going to have a teardrop shape. That talks about globe laceration. There's going to be leakage of vitreous humor from the posterior chamber of the eye, the posterior segment rather of the eye. A positive CDEL test. So it just means that fluorescein is leaking from the anterior chamber. So it means that you have lacerated that anterior segment and you're having aqueous humor. So you can have drainage of aqueous humor, you can have drainage of vitreous humor. And sometimes you can see blood in the anterior chamber, which is hyphema, right? So so once you see all these things, think of penetrating injury to the globe. Now what do you want to do? So Once you're able to identify that this thing, so you just stop your examination. You stop your examination. You can place an eye cover. You try to do some adjustment to make the person not feel pain, so that the person will not cry and the person will not vomit. So you administer prophylactic antiemetics and analgesics, because if a person cries, if a person vomits, there's going to be increase in intraocular pressure, and you can have complete evisceration of the eyeball, and you don't want that to happen. So you don't want to place any pressure on that globe again. So that's why you don't even do any test. You don't do tonometry. You don't do anything. You know. Then you can do evaluation by doing a non-contrast CT through the orbit. Then you must pursue a surgical repair within 24 hours. Very important. Sometimes you can have what we call oculocardiac reflex, in which the penetrating injury can cause a trapping of the inferior oblique and the inferior rectus muscle. So, inferior oblique muscle and inferior rectus muscle might be trapped. And if they are trapped, there's what you call oculocardiac reflex, because there is an interplay, there's a relationship between trigeminal nerves and the vagus nerve. So, that pathway can be activated when there's this trapping of these muscles. So it's going to send a signal through the ciliary ganglion to the vagus nerve. Then the vagus nerve sends signal to the heart. And when there's increased vagal discharge to the heart, you're trying to have a slowing down of the heart. So you have to relieve the pressure on this inferior oblique muscle and inferior rectus muscle. So, because stretching of this muscle, tensioning of the muscles can, stimulate that pathway, through the trigeminal, ciliary ganglion, the vagus nerve to the heart, which can cause bradycardia. So you want to limit that traction, and that is what you call the oculocardiac reflex. So, because it can trigger severe nausea and bradycardia. So you have to relieve that muscle. So if you see somebody that has high injury and suddenly the person develops bradycardia, what is that? Oculocardiac reflex. So relieve that traction on the inferior oblique and the rectus muscles. So yeah. So I think the pathway is actually involving the oculomotor nerve to the vagus. I can't remember which is the afferent, but that's just what you need to know. Just know that it involves the vagus nerve to the heart. So I can't remember. Maybe I'll check and I'll confirm. So that's that about the eyes. Then the hairs. You can have laceration of the hairs. So the laceration can extend into the middle hair. So when you check the middle hair if there's any bleeding, they can have basal skull fracture, which we are going to talk about. Injury to the parotid gland is close to the hair. Can have facial nerve lesion from that. And if they have basal skull fracture, you cannot see otorrhea. So once you are seeing otorrhea, you know that there's definitely a basal skull fracture. There's definitely a basal skull fracture. So how do you test for basal skull fracture? You can do like beta transferrin analysis. Beta transferrin is the content of CSF, so it's going to be elevated. You can do a CT imaging of the temporal bone, so which is one of the bones that make up the base of the skull. So, just do a primary closure, just like the way you do for the face. Do a primary closure, and especially if the injury is exposing the cartilage of the hair, so that you can reduce the risk of infection and ischemic necrosis. So that's just that. Oral cavity, what you just want to pay attention to here is the fact that if somebody develops a penetrating injury to the oral cavity, there's a high risk of injuring the internal carotid artery, because it runs posterior to the pharynx in some people. So, for example, small children that falls on a pen or stick into the oral cavity, it can dissect the ICA, and from there they will have injury. So the approach to modality depends. The modality to treatment depends on the site of the dissection. If it's proximal or distal, we know all these things. Stanford A and B. So if it's A, proximal, there's a high risk of tamponading on the heart. You want to quickly do your surgery. So if it's B, downwards, you know that you might just give you medications, your nitroprusside, your beta blockers, and if there's an organ injury, you need to do your surgery ASAP. So if there's injury to the gingival or the buccal mucosa, just don't do anything, because they are very vascularized. They will heal, but you might need to do primary closure, just like the way you do for the hair and for the face. If there's foreign body in the wound after you removed it, or the wound is more than 2 cm, or there's like a tissue occluding the surface. Now, for nasal trauma, it can happen laceration to the nose. Just look at the nose anatomy. Is there any disfigurement? Is there any malalignment? You palpate for the bones. Are they intact? You check for crepitals. You can hear some funny sounds, and you also palpate for possible collection of blood between the nasal cartilage and the pericardium covering the cartilage, which is septal hematoma. We're going to talk about it shortly. So you can also see CSF rhinorrhea. So just like we have seen CSF arteria in the nose, you can see CSF rhinorrhea, which also indicates basal skull fracture, and it particularly occurs when there's injury to the cribriform plate of the nose. So the cribriform plate of the ethmoid bone of the nose. So CSF can start draining from the nose. Now, an individual from laceration injury to the nose can develop septal hematoma. So this just means blood is collecting between the connective tissue covering the cartilage of the septum and the cartilage. So the nasal septum has the cartilage, and you have a pericardium or the connective tissue covering that cartilage. So you can have like fluid collecting in between them, and that's going to cause septal hematoma. That can bring about pressure-related injury, compressing on the vessels within this connective tissue, reducing blood supply to the septum. So you can have a collapse of the septum and the nose will perforate at the end of the day. If you don't drain that fluid, that hematoma, abscess can set in, and you might need to drain, and give antibiotics. So usually what you do is that if somebody has nasal septal hematoma, just drain the hematoma, pack it so that it doesn't accumulate, and place on empiric antibiotic, usually amoxicillin. The way I remember is that the nose is kind of full of dirty stuff, so I have to give antibiotics, unlike the hair or the face. But the nose, give antibiotics. There's another you call the auricular hematoma. So this can be a complication of the hair laceration, and you have blood collecting between the perichondrium of the cartilage of the hair and the cartilage of the external hair. So what do you do? Just like nasal hematoma, same thing. You drain, you compress, and you pack, so that you don't have recollection. If you don't drain it completely, you can have permanent fibrocartilage tissue that will grow into the space, and it will lead to cauliflower hair. So let's see the way cauliflower hair looks like. Cauliflower hair. So this is a fibrocartilage tissue. So that means that the auricular hematoma that occurs in this hair was not completely drained. So it becomes filled with fibrocartilaginous tissue, more like a granulation tissue growing in within it. So it's going to cause disfigurement. So have that at the back of your mind. So now penetrating injury to the neck. So this where you now be getting questions, right? So now if they tell you that somebody develops injury to the neck, the next thing you want to ask yourself, are there any impending signs of arterial injury or not? Is there any hard sign? We call it hard signs of arterial injury or hard signs to the airway. If there's hard signs of airway injury or hard sign of emergence of arterial injury, immediately you want to go for surgery. Immediately you go for surgery. You secure the airway and you go for surgery. So, but if it's not that, if the patient is stable, just your CT angiography of the neck. That is the only thing you need to know for this exam. I'm serious. The ability to identify the hard signs. So what are the hard signs of arterial injury? So the person is having active bleeding from the neck. Of course, somebody is having active bleeding of the neck. Secure the airway, rush into theater for surgery. Expanding hematoma. That could be from like injury to the carotid artery or injury to the thoracic arc of aorta. And the hematoma will just start expanding and be compressing on the airway. So neurologic deficit. So the person is having stroke from carotid artery injury in the neck. The person is having hematemesis, vomiting blood. You know that this is bad. or the person is just having hemodynamic instability. So you have to fortify the airway. You can see, like, it's as basic as that. Fortify the airway and transfer to the operating room. Active bleeding, expanding hematoma, neurology deficit, hematemesis, carotid blue. The person is having carotid blue. We can see that all these things are not things that like are highfalutin. There are things that you can even reason out in the exam, right? So you imagine for immediate fortification of the airway and you take him to theater. Now, if the patient is stable, not having any of this, just do your CT angio of the neck to be sure that the vessels are okay. And if there's a need to treat with surgery or embolization, you proceed. Now, you also have to identify the hard signs of the tracheal and the esophagus, which include gurgling breath sounds, bubbling wound, pneumomediastinum, crepitus. All these things are hard signs of injury to the tracheal root. Please don't mind them and be saying you want to do bronchoscopy. Once you see this, check it anywhere. I believe this is a mistake. Once you see gurgling breath sounds, hoarseness of voice, dysphonia, bubbling wound, pneumomediastinum, please just go and secure that airway and do a surgical exploration, because definitely for a patient to be having this, there's a tracheobronchial rupture. If the patient is stable, that's when you cannot be doing esophagoscopy or bronchoscopy. So any wound that violates the platysmal muscle, that's where you can say it is a true penetrating neck trauma. But if it doesn't puncture the platysma, just do a conservative wound care, because that is not a penetrating. It has not gone deep. It hasn't gone deep, and there's no way it can get to the vessel. So it's not a penetrating neck trauma. Now, that's that about it. Let me see if we can just have one or two questions, because it's something we can answer at this point. Let me see. Okay, I think we can answer this. A 24-year-old man is brought to the emergency 15 minutes after he sustained a stab injury to the left chest. On arrival, he has a shallow, rapid breathing and appears anxious. The pulse is 135, respiration is 30 and shallow. There is a palpable systolic pressure of 80. Examination shows no active external bleeding. There is a 2.5 centimeter single stab wound to the left chest at the fourth intercostal space, mid-clavicular line. Cardiovascular examination showed muffled heart sounds and jugular venous distension. The breath sounds are normal. Further evaluation of this patient is most likely going to show the following findings. What's our diagnosis?
Hemopericardium.
Hemo what?
Hemopericardium.
Hemopericardium? Why? Okay,
It said
hemopericardium.
fourth
Okay.
intercostal
Yeah, hemopericardium causing what?
mid-clavicular.
Causing what?
Cardiac tamponade canal.
Cardiac tamponade. So what's our answer going to be?
Huh?
So what's our answer going to now be, option?
A drop in systolic blood pressure.
Okay.
Yes.
14.
So what do you call that?
Respiration.
What do you call that?
Pulsus paradoxus.
Pulsus paradoxus.
Good job. Good job. A 75-year-old man is brought to the emergency department because of 5-hour history of worsening chest pain and dyspnea. 6 days ago, he fell in the shower and he had mild pain in his left chest. He's pale and anxious. Temperature is this. Blood pressure is that. 115/58. Oxygen sat is 88. Examination showed decreased breath sound and dullness to percussion over the left lung. There's an hematoma over the left chest. X-ray of the chest shows fracture of atrium and nitrate, increased opacity in the left lung, and a mild tracheal deviation to the right. Which of following is the most appropriate next step in the management of this patient?
Needle thoracostomy.
Sorry, maybe we should read the examination finding again, maybe because I rushed it. Let's read the examination finding again.
Yeah. Examination shows decreased breath sounds and dullness to
So are we still going to
percussion
pick needle? Are we still going to be picking needle?
over the left lung base. There is a 3C.
Hello?
Okay, I thought it was my network. I'm like,
Emergency thoracotomy.
Ah. Hey. Wait, oh, guys, please let me show us the entire. I'm sorry, my bad. What is that? You see, that's the thing. You know, I always say it. What is your diagnosis? That is how we can know that you know what you are talking about. Always tell us your diagnosis. What is your diagnosis? Doctors,
Hemo.
this thing is not hard. Eh? No catch at all. There's no catch.
pneumothorax.
Eh?
Um,
Why? There's dullness to percussion.
Hemothorax.
Patient
Hemothorax.
has a hemothorax
So what's the treatment?
Hemo.
What's the treatment for
with
hemothorax? What's the treatment for hemothorax? Eh?
Chest tube.
Chest tube.
Chest tube.
Just put it on chest tube.
hemothorax, and there is a
You
Okay,
can
yeah.
see.
Chest tube.
Yeah. Always have your diagnosis. You see, once you have your diagnosis, everything becomes easy. I can assure you, it becomes easy. So let me see this one if this is something we can solve. I think this is something we can solve too. Okay, no, it's not something we can solve now. It's not something we can solve. Okay. So have your diagnosis, it will help you. So moving on to chest injury, you know, ABCD approach, and there are just 3 things they want us to know for chest. You know, if somebody that had a chest trauma becomes rapidly unstable, suspect here embolism. And we remember, what we are going to. Okay, yeah. So just suspect here embolism when the person just become rapidly unstable after being previously stable, just suddenly deteriorate. It could be that the person has thrown a thrombus. A new diastolic murmur after chest trauma. Think about aortic dissection. Of course, that's the only cause of diastolic stuff that's very common. Aortic dissection causing aortic valve insufficiency. So once you see new diastolic murmur, know that there's aortic valve insufficiency, and most of the time it comes from what? Proximal or distal dissection. Anybody?
proximal.
Proximal. Good job. Massive hair leak into the tube thoracostomy until otherwise proven. In fact, there was a day somebody got this question, and people were looking at the person as if the person was a magician. But it's basic stuff, like sitting here. Once you see massive hair leak into the tube, think of tracheobronchial injury. Even if initially you are thinking of pneumothorax, well, as you are draining, the stuff is just coming. That means that we have opened the hair tap. You have a tracheobronchial injury. Don't forget this. Key fact: leave impaired object in place till you take to the operating. It's as simple as that. Never remove the knife and apply pressure. No. Leave it in place until you get to theater. So that's for stab injury to the chest. Now, you procure a chest x-ray and you are looking for dates. Chest injury. Any problem with the diaphragm, any problem with the aorta, any problem with tracheobronchial tree, any problem with the esophagus. Dates. That's what you are looking for in your chest x-ray. Please, we're only going to be doing chest x-ray for patient that is stable, right? Or CT scan for a patient that is stable. But if a patient is unstable, are we going to be ordering CT scan first? No.
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 Patient is
No.
unstable, please don't pick CT scan. So that's why what I quickly do, once I see trauma-related question, the first thing I do is to check the vitals. By the time I check the vitals, I check the sensorium, I already know what I'm going to pick. I limit my option. I know what I'm going to pick. So, if patient is stable, you can do your CT, to look for date. For example, you can use your CT to evaluate for the diaphragm. You can use your CT angiography to look for the aorta if there's any problem. You can do your bronchoscopy, to look at the upper airway, which is the trachea. And you can do your esophagram or esophograph, which is more like a barium swallow for your esophagus. It's as simple as that. Just keep it simple. Now, how do you treat the problem that can happen in the chest? We have seen one of them now, pneumothorax. Place your chest tube. Now, there's something here about the chest tube. If you are having an initial output of 1005, or you are draining 300 mils per 3 hours, like you are draining 300 mil for consecutively 3 hours from the tube, you have to do an operative thoracotomy. Immediately open up. Or initial drainage is 1.5, open up. Just go and open up. Go and open up. It's possible that the tracheobronchial tree has ruptured. Just go and open up. So don't forget, if your output is 1005, please if you are going to memorize this figure, memorize it. Ask yourself, is it more than 1.5? Or am I draining within 3 hours? I'm draining 300. Open thoracotomy. Some people will still forget this, but please don't be part of them. I will not be part of them. I will remember it. Always ensure that you remember this. It is very, very important. Very, very important. Write it somewhere. Put it in like what's it called? Like all these small notes. Hang it in the wall of your room. Be looking at it every day, because these are stuff that are volatile. Once it's more than 1.5, 300 mils per 3 hours in 3 hours, open thoracotomy. They will put chest tube there. They will shade it. They will come out and be boasting. I've palmed it. I've gotten it. But they are not paying attention to the details. So, if you identify any of the injury involving the date, urgent surgical correction. There's none of them that you are going to treat conservatively. None. Surgical correction. So, if you have somebody that has penetrating chest trauma with cardiac arrest, immediate thoracotomy. Without transport to the you don't even need to take to theater. Immediate thoracotomy. Open up. So because you don't know what is there. It could be like tamponade. It could be a cardiac tamponade. You don't know what's there. So open up to see. Abdomen. Now, what I'm going to say first is that for you to consider that there's an abdominal trauma, the level of injury has to be below the fourth intercostal space. You know this, you are moving that is tough. That's what makes somebody stuffy. The fact that you know this, you are stuffy. Because you'll be able to use this to solve a lot of questions. Once you look at in the question that they are saying that injury is in the fifth, sixth, this is abdomen you are dealing with. So you are not going to be picking anything related to thoracotomy again. Laparotomy is going to be the word. It has changed. Penetrating injury to the abdomen can come from a gunshot or knife injury violating the peritoneum. So once there's a violation of the peritoneum, immediate surgical exploration. No need for CT scan. Immediate surgical exploration. If there is peritoneal signs, you are seeing guarding, rigidity, without tenderness. Guarding, rigidity, without tenderness. Without tenderness. You have to do surgical exploration. That is not the time you have to be doing supportive or conservative care. So, gunshot injury, knife injury below the nipple, at the level of the fourth intercostal space beneath, immediate surgical exploratory lap. You can see that they are not putting thoracotomy there. It is laparotomy. Now, I put a clause here with hemodynamic compromise. You can have gunshot injury below the fourth intercostal space or below the nipple that might not warrant immediate exploratory laparotomy. I had a patient when I was doing my house job. I was the only house officer on call, surgery, and they brought in the person gunshot injury. This one was even with evisceration. Like The bowels, they were outside. I still have a picture on my phone till date. They were outside like this. And the person was a Jehovah's Witness. Oh my God. That was the most difficult. Like, hey, I was like, God, what are we going to do for this patient? You know, they insisted that they don't have blood, but lo and behold, the patient still survived. You know, although we could not do laparotomy for the patient at that time, so but it indicated, we just had to pack, just covered with saline, wash bowel because of foreign object and the likes exposed. So you have to wash it, pack it with saline, and gradually return it back. You know. So once you see gunshot injury below the intercostal space with hemodynamic compromise, XLAP. Now that patient was still talking. The patient was communicating, although he was in pain, but the sensorium was still okay. So I guess that's the reason why, we didn't do the immediate XLAP. Aside some other reasons we cannot be discussing on this platform. Yeah. So, but once there's hemodynamic compromise, you have to do XLAP immediately. So the fact that there's a gunshot injury doesn't automatically translate that you have to go and do surgery. Look at it. Has it violated the peritoneum? Is there peritoneal signs? Is there any hemodynamic compromise? Then you can now say, okay, let's go on to do our SLAP. So if the patient exhibits hemodynamic instability, peritoneal signs, or extruded bowel or omentum, just like I said for my patient. So in fact, even if the patient is conscious or not, the fact that the bowel have extruded, it is an indication for SLAP. Ideally, it is. So we did XLAP, though. So you have to do it. It is important. There's no way you won't do it. So, if the patient doesn't have any of these, you can explore the wound to check if there's violation of the peritoneum. You can do your manual exploration, but it's good you do your CT scan to check if the peritoneum is intact. If a defect is found, do your laparotomy. So if the peritoneum is not violated, you can observe for 24 hours. If the patient is okay after 24 hours, go. The patient is not okay, and you are seeing a drop in the hemoglobin count because you have to be doing serial, blood checks. Hemoglobin less than greater than 3, leukocytosis, peritoneal signs now developing or hemodynamically unstable, then you now have to go your lab. So you see that the white cell is going up, the red cell is coming down. There's hemodynamic instability or peritoneal signs. Go and do your lab. So can we see that the abdominal stuff is very simple or is confusing? You are not responding.
No, it's not confusing.
It's very straightforward.
It's,
So
it's straightforward.
it's
No
very straightforward.
confusion.
Yes. So extremities. Somebody has injury to the extremity, you don't need to worry yourself. Just don't worry yourself. So just look at, are there any hard signs? So which includes expanding hematoma, pulsatile bleeding, absent pulse. So this is just looking like that of the neck. So the hematoma is expanding. Told us that the person is having pulsatile bleeding. There's absent pulse in the leg. Absent pulse care. The bleeding is pulsatile. Expanding hematoma. You need to do a surgical exploration immediately. But some soft sign for vascular injury might be neurologic deficit in that leg. You know that it's going gradually, or significant history. You just told us that the person had some significant bleeding on history, or the person having a weak pulse. Not that the pulse is absent, but the pulse is not weak. You now have to do your CTA. And of course, this person is going to be hemodynamically stable. Most of the time they will be able to talk, they'll be conscious, and so just do your CTA. But if the person is hemodynamically unstable, having pulsatile this, absent pulse, just go and do your surgical exploration. So you have to evaluate for the motor and sensory function of that extremity. So the person can still move it, if the person can still feel pain. Those are the things you want to quickly check. You want to quickly assess your pulse. So can you feel any pulse? Pulse is absent, surgery. Pulse is present, weak, CTA. Very easy. Palpate or do your Doppler. Can you feel any pulse? Can you see any vascular injury? If you do your Doppler, you are seeing hematoma expanding. Surgery. You do your palpation, you are not feeling any pulse. Surgery. But if it's just neurologic deficit, please, you are not going to do surgery immediately because of you have to do your CTA first to see if there's any problem, and weak pulse. So that's what it is. And for like amputation or like injury to the legs, so if it's bone, you fix the bone first, fix the bone. Then after the bone, the next thing is the vessel. Because if you fix vessel before fixing bone, you have fixed the vessel, you're not going to bone. Bone is hard. There's a chance that it's going to dislodge the vessel that you have repaired. So fix the bone first. Go to pick the vessel, arterial repair, then approximate the nerves. That's where you repair trauma to the extremities. And if there's amputation, so you just pack it with saline moisture gauze, put in a plastic bag, and put it in the ice so that you can reduce metabolism and can prevent preserved viability. Of course, you are going to irrigate that wound, debride, give antibiotics, tetanus, and all those basic stuff. So, what are the long-term complications of you know um, injury to the legs? Probably somebody had gunshot injury to the legs, to the thigh. You can have high cardiac output failure. This is very commonly tested from fistula, very commonly tested, and the person is going to have high cardiac output failure. So with symptoms of CCF, so you have to pay attention to that. Now, what are the complications of amputation? Called a post-amputation pain. So number one is DVT. That's the first two because they will not be moving that leg frequently. So there's a tendency to develop DVT. They can develop stump hematoma. And, this is very common in people on antithrombotic therapy because they can form clots, so hematoma. They can develop stump pain, which can be caused by ischemia to that leg. They have cut off that leg, so the blood supply is interrupted, so ischemia. Neuroma formation is you have cut off the nerve. The nerve will try to regenerate, they become bigger and larger, and they can be painful. Neuroma or infection at that side. Because of the hematoma, they can be infection and be painful. Neuroma is actually with localized pain. So due to regrowth of the nerves. So you have to put in anesthetic like lidocaine to reduce the pain. Infection can occur from osteomyelitis or the graft. So you know that you can cover the amputation site with like a flap or a graft. So it could have infection and osteomyelitis of the exposed bone. So phantom limb pain is commonly tested to diagnose of exclusion, and the person will be having this electric type pain, burning, achy pain in that limb that has been amputated. So it's more like a neurological stuff. We can't go to the pathophysiology now. So let's just know that you treat with all these neuropathic agents like gabapentin, ketamine, TCAs, or lidocaine, any one of them. And you can do mirror therapy, which you try to regenerate that area of the brain. The neurons in that area, you try to regenerate them by um, you know, placing a mirror beside the person. So there's a way they do the mirror therapy. They just place the mirror in between the legs. So the mirror is going to be showing the reflection of the intact leg, and it's going to appear as if the amputated leg is now back. We can check that, online. We see the way it works. So to give the brain a false sense of presence of the leg, and it can reduce the pain. Virtual reality means you are looking at yourself as with the leg being intact. So just play something and you'll be looking at it, and just deceive the brain. Then peripheral nerve stimulation. Yeah, let's go to interesting stuff. We have a lot of way to cover. And blunt and deceleration trauma. So head and face injury. Head injury, one of the most feared complications is what? Increase intracranial pressure. So remember the Beck's triad, bradycardial hypertension, respiratory depression, fixed and dilated pupil, vomiting, and papilledema. So all these things are cardinal signs of increased ICP, and you want to do your maneuvers to reduce your ICP by elevating the head for 5 degrees, hyperventilating, giving intravenous monitor. I know Dr. Babandi have said it like 100 times. All of us, we know it by now. So, and another thing we have to pay attention to with blunt and deceleration trauma that I must not skip is concussion. So it's more like a physiologic disturbance in the neurons, not a structural problem. If you do the CT to be clean, it's a physiologic problem. So the patient just presents headache. Headache is the commonest presentation. Headache, they have cognitive problems. They're not able to remember stuff, amnesia. They're not able to think. they cannot learn new memories, they cannot think, they have problems concentrating, attention deficit, and they can have vestibular problems, so problem with balance, they could be ataxic, that's concussion. So somebody having air trauma and develops all those symptoms, this is likely to be concussion. After you have done your imaging and it's clean, concussion straight up. So most of the time you just tell them to, if they are playing football, contact sport, take them out immediately and return them gradually to the sport. So for like 24 to 48 hours, you rest them from that sport. They can go back to start with aerobic exercise, non-contact sport. Then after like a week, they can now start, you can now repeat your imaging. And if it's clear, if it's still okay, you're not seeing any hemorrhage, any bleeding, then they can now go back to their normal life. So before all those time, you tell them reduce stimulation, reduce watching TV, reduce involvement in cognitive acts like reading books, reading for USMLE. Those things are brain, tasking. So you remove all those kind of neurocognitive stimulation and just tell them to rest. No contact sports, nothing. So that's concussion. And also remember the post-concussion syndrome, in which these concussion symptoms and signs persist for like 4 months. You know, uh, most of the time you still reassure it will go. Just do your imaging to rule out any problem, and after some few months it will eventually resolve. So, but just know that post-concussion syndrome is a thing. So linear skull fracture, you manage non-operatively unless there is comminuted fracture or it is displaced. You see, anytime you see the word displaced, it's all these things you can just use idea. You can't know everything, but the little you can apply them. It will help you. You don't have to be a genius. Once you see displaced, comminuted, you are going to do surgery. You have to do an intervention. So, but if it's not displaced, you can manage conservatively. So epidural hematoma, we know everything about it. I could not be wasting time here. So just know that the lucid interval, the time they have the injury, they come back again, then they deteriorate. Epidural, and it's located within the side of the head, temporal region, and it has a very high chance of leading to onchionation. And we know the onchionation, we know what's going to happen, we know the Canoa phenomenon. All these things are basic stuff to us by now. And it calls for emergent craniotomy. You have to go in. Don't pick ball. Emergent craniotomy. You open a flap of the brain and you evacuate. Very important stuff, because this thing is rapidly progressive. It's caused by an arterial bleed. I know that we know that, right? Which artery is that?
Middle meningeal.
Yeah, so it will keep expanding because of the medial meningeal. So it will keep expanding, keep growing, and compress. So you have to be active in your management. So this is the biconvex bleeding epidural. This is what? Which one is this?
Subdural.
So that's subdural. So subdural is going to be concentric.
Convex.
Yeah. Is it convex? Or this is not convex. This concentric or moon shape, half moon. So and it's below the dural, and it can be acute, it can be subacute, it can be chronic. So there's sometimes you might do conservative management for your subdural, particularly if you are not seeing any midline shift. This one now, there's midline shift. We can see this obliteration, right? Yeah. Can we see?
Yes.
Like it's shifting the brain already. So there's a midline
I'm
shift.
not seeing yours. I'm not seeing your
Hello,
screen. No.
who's speaking? Is that Dr. Antonia?
Is your network?
Dr. Antonia? Dr. Antonia? Okay. So
Yes, yes,
can you see the screen
yes,
now?
yes.
Okay. So that's subdural. I know we know it, so I don't want to waste time. So you know how to identify it. So once you are seeing midline shift, usually greater than 5 millimeter, or you are seeing like a collection more than 10 millimeter, and the patient is presented with worsening neurologic symptoms, you have to do something. So you go in and you evacuate. Your craniotomy, and you evacuate. But if the patient is okay, you are just seeing the collection, no neurologic signs, no midline shift, just prophylactically manage your ICP because there's a high tendency of cerebral edema. So elevate the head, hyperventilate if you can monitor just to help the patient prevent edema. Then the next is the diffuse axonal injury. You don't need to cram this. The only thing you need to pick in the question is they will tell you that there is a accelerating, decelerating injury, and when they did the imaging, they are seeing blurring of the gray-white junction and punctate hemorrhage. That is what you need to identify. Once you see that, diffuse axonal injury. So it's like shearing off the axons due to the sudden deceleration. So just imagine somebody speeding and just press brake. You are going to fall forward. So you're accelerating, then you decelerate and you fall forward. So that's going to shear off the white matter tract of the brain. So the axons of the white matter tract of the brain with punctate hemorrhage and blurring of the gray-white matter junction. So it's very bad because most of the time the patient might be in a vegetative state. So resuscitate the patient, and cerebral edema management, ICP, NG tube, all those things, you do it, and you try to prevent secondary injury by doing all those ICP management. So that's just the way it works. It's very simple. Now, basal skull fracture, it occurs when there's fracture to any part of the bone, this part, the ethmoid bone. So we remember that we said that if somebody has CSF rhinorrhea, what part of the bone is damaged?
Hospital.
What?
Temporal
Eh?
bone.
The CSF rhinorrhea.
Basal skull.
The CSF
Is it
rhinorrhea
not
in the
Temporal
nose.
hospital?
skull.
In the
Is it not
nose.
hospital?
In the nose. I mentioned I said,
The
hmm? If you are
nose.
talking about the hair, you can say temporal. In the nose, that is cribriform
Is it
plate.
not?
Cribriform plate of ethmoid bone. I mentioned it. Cribriform plate of ethmoid bone because it's indicative of basal skull fracture, and that is because the ethmoid bone also forms the
Mm-hmm.
base of the skull, just like the temporal bone forms the base of the skull. And someone that has temporal bone fracture can have basilar skull fracture, and they can have CSF what?
Sorry.
Autoria. So people with ethmoid bone, we have CSF rhinorrhea. It's as simple as that. So it's very common people that have fracture of the temporal bone. Very common with them. So they can, because of the high occurrence with temporal bone fracture, they can have epidural hematoma. Don't forget, epidural is actually with temporal bone because of close injury to the middle meningeal artery. So what are the things you look out for? We have talked about it. CSF rhinorrhea, CSF autoria, blood in the nose, in the hair, which is hemotympanel, and most commonly Bartle sign, which is mastoid, which is a periorbital ecchymosis, that is raccoon eyes, bleeding into the eyes, and post-auricular or the mastoid ecchymosis. You see, let's see Bartle sign. Let's see Bartle sign, what it looks like. So that means you have destroyed the mastoid process of the temporal bone. Mastoid. So let me say Bartle sign. Bartle sign. So this is it. So you can see this. So that is Bartle sign. Bartle sign. So mastoid hematoma. So you think of basal skull fracture. Raccoon eyes, basal skull fracture. So you can do a CNS analysis, just take a CSF, place it in a absorbent surface and see the way it settles. The blood is going to settle in the center and the clear white fluid is going to surround it. And also test for the beta transferrin, which I said is going to be elevated in CSF, right? So beta transferrin is going to be elevated and that. So most of the time you just do conservative management. You don't do anything unless the CSF leak do not stop after 7 days. So if it doesn't stop in a week, you need to operate, and also vaccinate them because they have high risk of developing meningitis from what? Strep. No response. Okay, so pediatric traumatic injury. So it's very common in people that experience falls, motorcycle accidents, and abuse. And you might need to pursue imaging in people with high mechanism of injury, high risk mechanism of injury. Probably they had a fall, they had they, they have a motorcycle collision, so that's high risk. So, or they are abused. You need to check it. Sometimes they might have a low risk, but they're having some signs like loss of consciousness, altered mental status, vomiting, headache, and progression. So that's what you call the Peckham rule. I thought I have the Peckham rule somewhere here. Yeah, it's here. So what is the Peckham? What are the indications for CT scan of the head in the child? So if the child is less than 2 years, the first three is common to all of them. Altered sensorium, of course. This is general knowledge. Everybody knows. If you have an altered sensorium, you have to do CT scan of the head. So loss of consciousness, you have to do it. Severe mechanism of injury, high fall, motor vehicle. If the child has a non-frontal scapulomatoma, so because the one that is actually with high risk, of injury, bleeding into the brain is the one that is involving other part aside the frontal part of the scalp. Or if you have a palpable skull fracture, get CT done. But for age of greater than 2 to 18 years, same altered sensorium, loss of consciousness, severe mechanism, but here, because this one they can complain of headache and vomiting. So they can complain of headache. So once you are saying headache, vomiting, you know that likely ICP. If you are saying basal skull fracture signs, you have to get it done. So so the children too can have all these things we have discussed: concussion, contusion. So contusion is more like a bruising in the brain. Just have a small contusion. They are managed conservatively. When I was in neurosurgery, I saw a lot of confusion, we manage them conservatively. So subdural hematoma, epidural hematoma, cerebral hemorrhage, all those things, they can happen in them. So usually in children, they usually experience this decreased cerebral perfusion. The reason is not known. You just know that whenever they have brain injury, cerebral perfusion reduces and there's an increased metabolic demand. So we don't know why. So they have increased risk of secondary hypoxic injury. So that's why you have to be judicious with, the fluid you give them, and also you want to measure their blood pressure from time to time to see that it's not falling. You want to avoid giving antihypertensive to prevent dropping of the blood pressure, because of the risk of hypoperfusion. So that's that. Then, so what they just want to test is that do you have the ability to recognize the signs that will make you go for CT scan in a child? Do you know what will make you intubate? Of course, GCSS and 6. So these are not stuff I'm to be teaching us again. You know everything. The first fractures of the midface. We don't need to waste our time cramming what is here. Just look at this image. That's what I'm going to show you. And this is just a fracture. This is dental stuff. So, but maybe it's good for us to have the idea, and there are like midface fractures that happen when there's fracture involving the pterygoid plate of the temporal bone, of the sphenoid bone. So we have three class 1, class 2, class 3. So it depends on the severity. Now, the class 1 is known as the horizontal maxillary fracture. And the only thing you need to know is that there's going to be a fracture line that runs through the maxilla, the tip of the maxilla, passing through the nasal aperture. You see, once you see this is class 1. You can see involvement of the nasal aperture. If the question doesn't say it involves the nasal aperture, please don't pick class 1. Don't ever pick class 1. So this is class 1. And if you want to examine, what the physician will do is to put one hand on this patient's head, put another hand here, and we'll try to rock. You see that this place will be moving independently. So it will be moving to and fro. You know that this is likely to be a class 1. Can we picture what I'm saying? Anybody pictures what I'm saying?
Yes.
So for the class 2, so here the reference was nasal aperture. For your class 2, the inferior orbital ring is your reference point. So you notice that there's involvement from your maxilla. This is your maxilla bone here. So it's from it runs across the inferior orbital aperture, the inferior orbital rim, across the middle part of the middle part of the orbit, the nasal, bone to the other side, then downwards like that. So the inferior orbital margin is involved. So once they say that the inferior orbital margin is involved, that's likely to be a class 2 fracture. And you know that there's a risk to a damage to a particular nerve. There's a nerve that passes through this hole. Anybody remember from anatomy? Anybody remember?
Inferior.
Inferior orbital nerve. Good man.
Inferior
Inferior
orbital
orbital
nerve.
nerve.
Yeah, so which is a band of maxillary. So you are going to
Yeah.
having so you are going to having reduced sensation here within the maxilla, the upper lip, and the like because of affectation of this nerve. So then the third is when you have the fracture starting from the zygomatic arch, going into the the upper plate of the eye, then passing across the nasal bridge, then downward to the other side. It's not involving the inferior optic margin. You can see that. So that's class 3. Class 3 is the baddest. In fact, somebody with class 3, you can open the skull. It should be as if you are like opening the head, because you can open this part, like you can flip it open. So that's class 3. So class 3 and class 2, they have a high risk of a concomitant basal skull fracture, right? As compared to class 1. So that's all you need to know. And how do you manage open reduction and fixation? That's all. You don't have to be a genius. Open reduction and fixation, ORIF, that's it. And if there's a concomitant mandibular fracture, what you do is that you do a maxillary mandibular fixation. So you fix both of them together if there's a mandibular issue. And you place the patient on liquid diet. The patient will not be able to eat, talk well. It's a bad stuff. So place on liquid diet, and you do that. So don't forget the open reduction and fixation. If the mandible twist displays, you fix the mandible, the maxilla with the mandible. That's the mandibular maxillary fixation. So, but the mainstay is what? Open reduction and fixation. You can see. So that's the way it is. It's very easy. Not you don't have too much stuff. Now, going to the chest injury, tracheobronchial tree destruction. That's one of our major focus here in the chest injury. We have a blunt trauma to the chest and we can injure the airway, the tracheobronchial tree. And we have talked about the cardinal signs. So what are they? Anybody wants to remind us? Okay. So there's going to be
Massive continuous leak.
there's going to be massive continuous leak causing subcutaneous emphysema. The person is going to be having hemoptysis. There's going to be sternal tenderness. So by the time you touch the sternum, it is tender. Subcutaneous, emphysema and the like. With a large pneumothorax because of the hair leak, or a large pneumomediastinum, which is going to present with a crunching sound. You see the Hammond sign, which is crunching sound. So you see like this crunching sound when the lungs are moving, and the heart are contracting. So persistent hair leak when you put in your chest tube should raise your suspicion for what? Tracheobronchial destruction. So the next is pulmonary contusion. You can have a contusion on the lungs. One thing that will raise your suspicion for pulmonary contusion is number 1, it's going to be unilateral. Number 2, if you do your imaging, you are going to see the opacity is within 24 hours, which is not in keeping with what?
ARD.
ARDS. Good job, Dr. Antonia. Which is not which is not in keeping with ARDS. So number 1 is unilateral. That's atypical for ARDS. ARDS is usually bilateral. You are getting a unilateral, and you are now seeing evidence of opacity within 24 hours of the injury. And now, what is the nature of this injury? You are going to be seeing patchy. You see, once you see the word patchy, unilateral infiltrate on X-ray, not restricted by lobar anatomy, just go and pick pulmonary contusion and move. They cannot even help you in the question. They will tell you that the difficulty in breathing worsens with fluid hydration. Why? Because the problem in pulmonary contusion is that, just imagine that you eat this part of the lungs, you tear the alveolar vessels, you are going to have bleeding into the pulmonary parenchyma, and it's going to cause the contusion. And now you're now giving more fluid, so that means that you are going to have more bleeding into that area. So that's why pulmonary contusion can worsen with high fluids. So what do? You just place them on non-invasive positive pressure ventilation, you know, and if there's pain, give them analgesia. Be careful with the IV fluid you administer. You might need to give them some IV fluid because of the bleeding, but don't overdo it so that you don't tilt them to overload from the fluid extravasation. So it's very common in children because of the less rigid protective chest wall. So don't forget the lesions, they appear within 24 hours of the insult, and it is unilateral, and they are going to have patchy opacity. So place them on your MPPV. If this doesn't work, intubate. So flare chest. Flare chest, we know this. This is just when you have 3 or more ribs that is adjacent to each other. When you have 3 or more ribs being fractured, that is flare chest. And what happens? Normally, during inspiration, your ribs move outwards. But in flare chest, everything moves in the same direction. Inward inspiration, in, you'll be moving the same direction. And what happens when this occur? If during inspiration the ribs move outward, they are going to generate more like an increased volume and a decreased intrathoracic pressure. So that decreased intrathoracic pressure helps to draw in more fluid, more air. But in people with flare chest, that broken ribs will not move out during inspiration. So it moves in and it doesn't allow for generation of sufficient negative intrathoracic pressure to get in here during inspiration. So that the individual is going to have an inspiratory problem, a problem with oxygenation. So what do you want to do? Just, put in your negative, your hand PPV and what? Do a positive pressure ventilation so that you can force out that air, you know, at both expiration and inspiration so that you can allow, for adequate gaseous exchange. And of course, because they are going to be very painful, give adequate analgesia. Because if you don't control the pain, you are going to have what we call pulmonary splinting. So it's going to be very difficult for the person to breathe. And if somebody doesn't breathe well, anybody remember what is going to happen for people that are not breathing well? What happens to the lungs? It's going to So that's why we have to do pulmonary rehabilitation to ensure it doesn't happen. What am I talking about? Anybody remember?
Stasis
Atelectasis.
pneumonia.
Atelectasis. Atelectasis.
Yeah,
So,
atelectasis.
so if your positive pressure ventilator doesn't work, you can fix it surgically, right? So anybody that has a trauma involving the
Lung
first rib,
collapse.
Dr. Antonia,
Atelectasis.
yes, we've gotten it. Yeah. So anybody that has um what is it called? Injury to the first rib, the scapula, the sternum, they are thick strong bones, so they are difficult to break. So fractures of any of
He said
these,
what?
Dr. Antonio, I've moved on from there. So fracture of any of these, you should raise your suspicion for aortic disruption because these bones are very difficult to break. So if there's fracture of the first rib, the scapula, the sternum, know that there's likely involvement of the thoracic aorta. And I'm going to show you what aortic disruption. You don't need to know everything. Just know the few points you need. Take it to your exam and you'll be fine. I can assure you. So there's another phenomenon which is unilateral diaphragmatic paralysis, and the diaphragm can be paralyzed when you have a motor problem with the diaphragm itself, or you have like a nerve injury, like the phrenic nerve affectation. And we know that the phrenic nerve is what supplies the diaphragm, and it originates from the C3 to C5 level in the neck. It wraps around the anterior scalene muscle, descends downwards to the anterior pericardium, then innervates the diaphragm. So any alteration within this descent part can cause injury to this nerve. So injury to the neck can damage it. Penetrating injury to the pericardium can damage it. Diaphragmatic laceration can damage it. So sometimes if they have a one-sided injury to the phrenic nerve, they will be okay. The only thing is they might have exertional dyspnea or they can have autopnea. Why? Because just imagine, what does your diaphragm do? Your diaphragm contracts and comes, is it upwards or downwards? Anybody? When diaphragm contracts, where does it go? Is it upwards or downward? Though?
Downwards.
Downwards.
Now imagine somebody is having diaphragmatic paralysis.
Downwards.
Now imagine somebody is having diaphragmatic paralysis and the diaphragm cannot go downwards. You are now lying down. If you are lying down, where do you think the abdominal viscera is going to be pushing the diaphragm? Is it going to be pushing it upwards or downwards?
Upwards.
Upwards. So that means that the diaphragm needs to be, working more to move itself downwards.
Upwards.
So that is going to be causing autopnia. So the only way you can make things easy for the diaphragm is just to stand, so that the diaphragm can be moving down. But when you lie down and your abdominal viscera is pushing the diaphragm upwards, it will lead to autopnia, difficulty breathing while lying down. So it's not only heart failure that causes autopnia, just for your information. So what are the cardinal signs? Diaphragmatic paralysis. You just see that the section of the diaphragm that's paralyzed will be raised. Paradoxically, it's going to be raised because when the diaphragm is active, it comes down. But when it's paralyzed, it comes up. But you might not be able to demonstrate bilateral paralysis by doing your chest x-ray. Why? Because both of them is going to be at the same level. Do we understand the analogy? Do you get it? So we're not able to see that one is higher than the other if it's bilateral. Does it make sense to us? Anybody?
Yeah.
So what you do in that instance is to measure your forced vital capacity, pulmonary function test, because you need your major inspiratory muscle is your diaphragm. Your diaphragm is gone, your forced vital capacity is going to be reduced. So what you do is to do a function test, pulmonary function test, to make diagnosis of bilateral paralysis. People with bilateral paralysis, most of the time they'll be symptomatic. You might even need to intubate some of them. So that's just that about bilateral paralysis. And most of the time, bilateral paralysis occur when there is like neuropathies or motor neuron injury, like somebody having ALS, somebody having Guillain-Barré. They can have bilateral. But for unilateral, think of trauma most of the time. Unilateral. And in unilateral, on imaging, you see that segment elevated. If you do, you can confirm aside your chest x-ray by doing your fluoroscopic sniff test. So what you are doing here is just that you are using fluoroscopy to monitor the movement of the diaphragm as you take the person to take a sniff. When you are sniffing, you are inhaling. And when you are inhaling, you expect your diaphragm to come downwards. But somebody has the diaphragm is paralyzed. If they are taking the sniff, it comes upwards. So you'll be able to see it on your fluoroscopy. So that's a fluoroscopic sniff test. Forget the big name. It is not stuff. So in lateral paralysis, most of the time, they don't require any treatment. They don't do anything. But sometimes you might need to do surgical application. So what you are doing is that diaphragm that is moving up when the other ones are coming down. Because if it's moving up, you'll not be able to generate enough intrathoracic pressure to bring in air. So what you do is you just placate it, you tie it down to the body. So once you tie it down to the ribs or to the surrounding tissue, it doesn't move up, during inspiration. So that is what you do, so that you can generate enough negative pressure to bring in air. So, and sometimes if it's severe, you might need to mechanically ventilate. But for bilateral, you must ventilate mechanically. And in some situations, if the cause of the paralysis is something outside injury to the phrenic nerve, and I've given an example, people with ALS, people with Guillain-Barré, people with polio, it's usually bilateral and the phrenic nerve is intact, it's not injured. So you can do a phrenic nerve stimulation in those people, coupled with your ventilatory support. So you can put like a pacemaker to power the phrenic nerve. Okay. So this is different from diaphragmatic rupture. Don't mix them up. In phrenic nerve injury, unilateral, diaphragm is just elevated. In bilateral, both of them will be elevated, but you will not know on X-ray until you do your what? Pulmonary function test, that your FVC will be low. But you will still be able to see the contour of the diaphragm, yeah. But for a diaphragmatic rupture, the contour is going to be lost. You'll not be able to see this outline, and you notice that there's going to be evisceration of your abdominal content into the thoracic cavity. You'll be hearing bowel sound in the lungs. By the time you are hearing bowel sound in the chest, there's evisceration of bowel content due to diaphragmatic rupture. Very, very important stuff. It's very common in the left because the liver is on the right to tamponade and doesn't allow for the injury. So, So what should I say? Yeah. So the most important thing for you to know is that the best diagnosis, the best way to make the diagnosis is to do your CT imaging. That is what you need to know. Once you confirm it with your CT imaging, go in and do your surgical repair. Go in and do your surgical repair. Go in and do your surgical repair. They have told us the way they will present. They've got him bleeding, dyspnea, bowel sounds in the thorax, loss of continuity of the diaphragm on imaging and the likes. So you repair surgically. That is it. That is what you need. So once you confirm your CT, go and repair surgically. So your blunt cardiac injury. So this means that you have a heavy blow to the heart. And the next thing is you can develop myocardial contusion. So that means like bruising in the heart. And what will happen? The heart will not be able to contract adequately. So the person can have cardiogenic shock. They can have hypotension from there. Because it disrupts the muscles, the cardiogenic shock. It disrupts the conducting system, arrhythmias, heart blocks, ectopic beats, bundle branch blocks. So you see somebody that had, chest trauma and suddenly develops feature of left ventricular failure, cardiogenic shock, and the biomarkers are elevated. Just know that this is cardiac injury. Most of the time, it's supportive and you just give your ionotrope to help power that heart again. Please have that at the back of your mind. Please don't forget it. Aortic disruption, very, very easy to identify. Very easy. So somebody had like motor vehicle accident, ejection from vehicle, fall from height, and suffers aortic disruption. So most of the time, the part of the aorta that disrupts, that tears off, is what we call the aortic isthmus, and that is a part that is just very close to the ligamentum arteriosus. So this is your aortic isthmus, just before you get to the descending aorta. This is step one stop. We know it. What are you going to see on X-ray? The most important thing you have to remember, once you see widening mediastinum, someone that had a trauma involving the chest, please, widening mediastinum, just go and pick aortic disruption because there's bleeding from the aorta into the mediastinum. That is why the mediastinum is widening. Another thing you notice is that the trachea is going to be compressed to the right. So you are going to have a right compression of the trachea and your esophagus. And because of that right shift in your esophagus, you put in NG tube is going to deviate to the right. The blood in the mediastinum is going to be compressing on the left main stem bronchus, which is somewhere here. It will make it descend. So if they tell you that there is depression on the left main stem bronchus, you think about rupture of the aorta. That is what you need to remember. Widening mediastinum, deviation of the tracheal and esophagus to the right, depression of the left main stem bronchus. Forget about the other ones. You don't need them. What do you need to do? Depending on the status of the patient, look at the vitals. Patient is stable. Do your CTA. Very important stuff. Do your CTA. Patient is unstable. What do? Do your what? Transesophageal echo. Don't pick transthoracic. You need to see clearly. Do your transesophageal echocardiography. Then schedule for surgery immediately. Any defect you see, you have to do emergency surgery because it's highly lethal. So you can do your co-ultrasonography to check for pericardial temporal because you can have aortic rupture, bleeding into the mediastinum, bleeding into the heart, pericardial tamponade. So because complete aortic rupture is fatal, most of them die at the scene. So if you see somebody that has aortic rupture and the person is still alive, it means that the bleeding occurs into the adventitia and it's torrential, widening. It's contained within the adventitia. Yeah, that's why you can form an hematoma. But if it's complete and it tears the entire, aorta, the person cannot survive it because the bleeding is not going to be confined. The person just keep bleeding uncontrollably till there's complete exsanguination. So, the hematoma can also compress on the recurrent laryngeal nerve and it can have hoarseness of voice. So just have that at the back of your mind. Hoarseness of voice. So don't forget, stable CTA, unstable transesophageal echo. Very important. Abdomen. So abdomen, what you just need to know for your step 2 CK is what? Stable abdominal injury, CT. Unstable, You can be doing all this fast and your DPL usually, but most of the time it's stable. Just go and do your CT. Just go and do your CT. Now, what are the organs that are high risk of being injured? So for the spleen. So if they tell you that there's a fracture of the left 9 to 11th rib, have a suspicion that it's going to involve the spleen. So you might need to do a splenectomy if it's bad, and you give the person vaccine 2 weeks after you have removed the spleen. Please, if they ask us, pick the vaccine 2 weeks after you have, done the splenectomy, not before you do the splenectomy. And you're going to be giving things that cover the encapsulated organisms, like all these things. Liver is the next one. So it usually requires surgical evaluation too, and it's very common with fractures of the lower ribs in the right side. The kidneys too. And what you are going to be seeing is gross or microscopic hematuria. Don't forget this. Loin pain, flank pain, gross or microscopic hematuria, suspect the kidneys. The duodenum, usually they will paint situation of maybe a child that is riding a bike and falls on the handlebar. So if the child develops epigastric pain with bilious vomiting, just go and pick duodenum straight. Duodenum, duodenal hematoma. That is duodenal hematoma. And because duodenum is a retroperitoneal organ, it can rupture, hair can extravasate, and you can see retroperitoneal hair on X-ray. Then the pancreas is another one. Presents similar like duodenal. You're going to be in epigastric pain, but you won't get any bilious vomiting. So diaphragm, we have talked about diaphragm. Look for abdominal viscera on X-ray, in the thorax. So look for abdominal viscera in the thorax on the chest X-ray. And it occurs more on the left side because the liver protects on the right side. So what's the algorithm? Blunt trauma to the abdomen, the next thing is you want to ask yourself, examination findings. Is there guarding, rebound tenderness, rigidity that's in keeping with peritonitis or not? So if you are seeing peritonitis, guys, just go and do a slap. Don't waste your time doing imaging. Just go and do a slap. But if you don't have any feature of peritonitis, then you can now calm down and say, okay, is the patient stable or not? So patient is stable, do your CT scan. Patient is unstable, do your fast or your what? Peritoneal lavage. So peritoneal lavage just in seal fluid and see, you measure the content of blood and the likes and see if it's severe to make a diagnosis of, okay, hemoperitoneum. Fast is like a focused sonography assessment for trauma. So you do your portable ultrasound to quickly look at the chambers. You look at the peritoneum, you look at the pericardial space, you look at the pleural cavity. You can look at the pelvic region too to see if there's any collection of blood within that area. So if you identify anything on your fast or your DLP, blood is there, SLAB. No sign of extra bleeding in your fast or DLP, then you have to look outside. Is the person actually bleeding outside? What could be causing all this instability in this patient? Then you look outside, the person bleeding into any other compartment. If you can identify, you manage accordingly. If you can't see anything, just decide. Either you do a slap or you stabilize for CT. Okay? But if the patient is stable and you are doing CT scan, now, if you see any bowel injury or any hollow organ injury, or you see hemodynamic, large volume intraperitoneal fluid collection on your CT, or signs of diaphragmatic injury, you have to surgically repair. So do your SLAP. Don't forget, I've said it. Diaphragmatic injury calls for surgical repair. We must do surgery. Hollow organ, surgery. Large volume intraperitoneal fluid, surgery. So seatbelt sign is a high risk sign that, okay, there's abdominal injury. So if the patient is stable, just do your CT scan to evaluate. So this is like seatbelt sign. So patient can have retroperitoneal hematoma after blunt abdominal trauma, especially those of them that are anticoagulants or people that undergone cardiac catheterization, because they can puncture the femoral vessel and they can bleed into the retroperitoneal space. And what are the cardinal signs of retroperitoneal hematoma that you must not forget? They'll tell you patient has flank pain, has back pain. You can see hemodynamic instability. So the flank pain, the back pain, they are classic. And it's something you call the coolant sign and the great tunnel sign. So when you are seeing ecchymosis within the umbilical region, so that is your coolant sign. If you are seeing it within the flank, that's your great tunnel sign. All of them, they are classic for retroperitoneal hematoma. But there's so many things that can cause retroperitoneal hematoma. So you need to analyze your SAT-POCA And C, the ones that are shared with the abdominal viscera like the kidneys, the pancreas, the rectum, and C, any one of them that is involved. So, patients with spinal cord injuries, put a urinary catheter, to evaluate for urinary retention because it's very common in them. What do we call this? Urinary retention in people with spinal cord injury. Neurogenic issue. So neurogenic bladder. Um, so now for the pelvis, like it's very straightforward, very simple. Um, you know, it also occurs with the motorcycle accident, fall, and the like. So they can bleed into the pelvis, they can be hypotensive, they can enter shock. So what you do is that you can just place a hand on your anterior superior iliac spine, try to move it, and see if there's any, instability or open book fracture. Open book fracture means that you have like opening of the anterior part of the pelvis, which is your pubic rami, it's opened, and the back of the pelvis too is opened. So it means like you can just open the pelvis like a book, right? So most of the time, the patient is stable. Still do your CT scan. You can see the algorithm is just there. Do your CT scan. The patient is stable. Some might prefer to do X-ray, but CT is better. You can well define the lesion. But if the patient is unstable, you might need to take the person for surgery. Usually they wear what you call external pelvic binder. So you wear like a binder, you bind the pelvis together, before you take him for surgery. Pelvic trauma is the only one that surgery is not the immediate stuff. I forgot to mention. I'm so sorry. Permit me. So forgive me rather. If the patient is stable, you CT scan. Patient is not stable, bleeding. Apply external pelvic blinder. Don't take him for surgery immediately. So you can also rule out injury to other pelvic structures by doing your DRE, your proctoscopy to look at the rectum because rectum is a pelvic organ. Check for the bladder by doing your retrograde cystogram to check for the functionality of the bladder, is it ruptured or not. Do a pelvic examination to check for the vagina in females, and a retrograde uretrogram to check for the urethra in males. So these are stuff that can weaken the health, Ehlers Danlos, syphilis, Marfan. We know all these things. Step one. So transfuse the patient, pelvic fractures, transfuse them because they can be bleeding massively. Patient is unstable, place an external pelvic binder. Don't forget, see, that's all you need to know. Just place your pelvic binder and do your angiographic embolization if you can do it. You can also do S-fix or internal fixation, but this is surgery and it will take time. You can bleed. So external pelvic binder is a treatment for unstable patients with pelvic trauma. Don't forget. Now, rectal sheath hematoma is just when you have a tear of the deep inferior epigastric artery bleeding into the rectus sheath space. And you are going to be having a bulge in the abdomen, abdominal tenderness, abdominal pain, abdominal swelling, right? And this usually occurs below the arcuate line, which is the point where the posterior aspect of the rectus abdominis is no longer supported by the posterior rectus sheath. So it makes this vessel liable to, shear forces and can lead to bleeding. So you don't need to know all the story. Just know that once you see acute onset abdominal pain, abdominal mass, with leg pain or back pain due to compression of the femoral vessel or femoral nerves, think about rectal sheath hematoma. Now, there are some signs they will demonstrate in the question that will heighten your suspicion, and that is the Carnet sign or the Fortagil sign. So you want to know if that collection is within the abdomen or confined to the rectal sheath. So your Carnet sign, what you are doing is that you are telling the patient to move from like supine to upright. Tell them to sit up from a supine position. When you do that, you contract the abdominal muscles. So your point of maximal tenderness is unchanged if it's rectal sheath hematoma. If it's an abdominal stuff, it's going to move. But for Fortagil, what you are doing is you are telling the patient to contract the abdominal stuff by either elevating the head, or moving the legs upwards. That will contract the abdominal muscles too. And you notice that the mass will not shift, will not cross the midline. It doesn't cross the midline, it means it is a rectal sheath hematoma. So that's the 4G sign. So after you have done this sign, you have a high suspicion, you do your CT of the abdomen and pelvis to see the hematoma. So sometimes you might need to do a CT guided surgical evacuation of hematoma and ligate any bleeding vessel. That's how you treat it. And of course, you have done your normal resuscitation, transfusion, and the likes. Then you put in some drain to prevent reactivation of the hematoma. So, bladder injury is very straightforward. Just classify it into the extraperitoneal and the intraperitoneal. It is very straightforward. We already know this step one, very easy stuff. Once there's involvement of the dome of the bladder, because the dome of the bladder is covered by peritoneum. So once you have a tear of the dome of the bladder, definitely urine is going to extravasate into the peritoneum. And if you have urine entering into the peritoneum, there's going to be peritonitis. That's a chemical peritonitis. So the person is going to be having peritoneal sign. So you have somebody that has a pelvic injury and the person presents peritoneal sign, difficulty urinating, suprapubic pain, damage to the bladder. And which one is this? It's likely to be the dome of the bladder. If you do your BUN, it's going to be elevated because your urea from the urine that's entering the peritoneum is going to be absorbed into the blood. Remember, the surface area of the peritoneum is very wide. Anything that enters the peritoneum can be absorbed easily into the blood, and you are going to have elevated blood urea nitrogen level. So that one requires a surgical repair because of the peritonitis. But for the extraperitoneal bladder injury, so that means that you are talking about injury involving the trigone or the neck of the bladder. So you are not going to be seeing elevated BUN. So what you are going to be seeing in the question is what? High riding prostate. Because let me see if I can show us an image so that it doesn't be as if I'm just anterior neck of the bladder injury. So by the time you do your DRE, you see that the neck of the prostate is high riding. So I need to see it. I need to see like a lateral image so that we can see it anterior posterior view. So I don't know. Yeah, so this is a lateral image. So we can see we can see this. This is the neck anterior aspect. So when you have a tear here, urine is going to accumulate here in the retropubic space here. And what is going to happen is going to elevate this prostate. So you call that high riding prostate. So by the time you do your DRE, you put your hand here and you move here to palpate. You see that this thing is very high. So that is suspicious for anterior neck, anterior bladder injury, neck of the bladder injury, blah blah blah. And that is extraperitoneal, not intraperitoneal. This is intraperitoneal because the peritoneum covers this place. You can see the peritoneum here. This is the peritoneum. And if you have a tear of the trigone and it bursts like this, for example, people that take too much alcohol, they're now driving, they now use seat belts, they now have accidents. That one can easily damage the dome of the bladder because of the increased pressure, sudden pressure, boom, can rupture that dome and you have bleeding into the intraperitoneal space. So you need to do a surgical repair. But this, just put in your Foley catheter and be emptying the bladder. The patient is going to be fine. So that is that. For urethral injury, the patient is going to tell you that they cannot pee. You are going to notice in the question stem that there's blood at the meatus of the penis, right? You are going to see that the patient is going to present with scrotal pain, or scrotal hematoma, depending on the side of the urethra that is involved. High riding prostate, difficulty urinating. So you need to separate into two forms. Are you dealing with the anterior urethral injury or posterior? So anterior are like the penile urethra and the bulbar urethra. While the posterior are the ones that are back, which is what? The membranous urethra and the prostatic. So now, what will cause injury to the ones that are back, which is the posterior, is if the patient has a pelvic fracture. If a patient has pelvic fracture, the patient can injure this. So this is your prostatic urethra. This is like your membrane or somewhere here. So it will tear this off and you have bleeding into the retropubic space, just like anterior bladder injury, and you're going to be having a high riding prostate. So you see blood at the meatus of the penis, you know that this is likely to be urethral injury. difficulty in voiding. They now tell you in the question stem that the person is having high riding prostate. You know that this is definitely going to be a posterior urethral injury. Shikena, very easy. You put in your suprapubic cystotomy or catheter here, drain urine from the bladder so that you have little urine getting to this place. Very easy stuff. Then you can also have anterior urethral injury, in which you are tearing any of this part here. And there is what we call the superficial perineal fascia here, that urine can track along. And if you have a tear of the bulk fascia somewhere here, you can have acceleration of the urine into the scrotum, and there's going to be scrotal enlargement. Now, that patient is not going to be having high riding prostate. You are just going to be seeing scrotal enlargement, difficulty urinating, and they are going to tell you that the patient fell astride, or is riding a bike, riding a horse, fell, perineal injury, or maybe they are trying to catheterize and rupture it accidentally, or penile trauma, just give like a kick to the penis, all those kind of things, perineal injury. But for the posterior one, it's going to be a pelvic injury. So have all these things at the back of your mind. And how do you treat the posterior? I've said it. Posterior pelvic fracture, just manage with urinary catheters. That's just what you need to do. For the anterior, put in your suprapubic catheter or urethral catheter for bladder drainage. That is it. Rectal and vaginal injury, just manage non-operatively and reconstruct if it's necessary. Let's look at one or two questions so that we can call it a day. We have tried. It's been a long time. Long ride. So, let me see if I can solve one or two questions. A 24-year-old man is brought to the emergency department after his head was hit with a bat during a baseball game. His teammates stated that he was unresponsive after the incident, but regained consciousness after 15 minutes. The patient refused to go to the hospital side of the bench for the remainder of the game. He was initially fine, but increasingly confused, became lethargic, and he opens his eyes to loud verbal commands. He's oriented in time, place, and person. Vitals are okay. There is a soft area of swelling at the left temporal region. CT scan of the head shows a biconvex lens-shaped hypertensivity in the problem. So what do we do?
That's epidural hematoma.
So what do we do? What do we do?
Hemorrhage, sorry.
Craniectomy. Good job. A 28-year-old man, let me just go to the history straight, the finding. Auscultation of the lung shows decreased breath sound on the right side. So, auscultation of the lungs shows decreased breath sound on the right side. A crunching sound, which is synchronous with heartbeat, is heard over the pericardium. There's donors and percussion on the right hemithorax. The lips and the tongue are cyanosed. There's open fracture. Blood gas is as follows. Patient is intubated and mechanically ventilated. Infusion of normal saline began, which is the following is the most likely diagnosis. Okay. What are we picking? So there's crepitation. There is crunching sound, which synchronous with heartbeat. Donors with percussion on the right hemisphere. The answer is there. So what do we pick? What's the diagnosis already?
Bronchial rupture.
Bronchial rupture. Good job.
Bronchial rupture.
Good job. So there is dullness to percussion, decreased breath sounds over the left lung base. Abdominal examination shows diffuse tenderness with no guarding abounding or abound. Hemoglobin concentration is low. X-ray of the chest shows a fractured left second rib, depression of the left main bronchus, deviation of the NG tube to the right, left pleural effusion, and the wide mediastinum. What's our diagnosis?
Aortic rupture.
So this one now has chest pain, shortness of breath, multiple abrasion over the trunk and the upper extremity. There's a coarse breath sound over the right lung base. Cardiac examination shows no murmur, blah, blah, blah. Infusion of 0.9% normal saline is begun, and it subsequently develops increasing shortness of breath. Arterial blood arousal is 60%. X-ray of the chest shows patchy, irregular, infiltrate over the right lung field, which actually is the most likely diagnosis.
Pulmonary contusion.
Good job. Good job. Good job. A 24-year-old man is brought to the emergency department because of left shoulder pain after falling from a height approximately 10 feet while rock climbing 5 hours ago. He initially thought the pain would resolve with rest, but it became severe over the last 2 hours. Now, there is severe tenderness to palpation in the left upper quadrant with voluntary guarding. Focus assessment for trauma, which is the FAST, shows no evidence of free intraperitoneal fluid. Okay, now let's just try. I'm not sure I mentioned this, but somebody have all this presentation. I just want us to just reason it out. And they did FAST, and it was negative. What do you think you want to do?
Abdominal CT.
Good job.
Abdominal.
So just look at this vital. Patient is stable. Just do your CT. CT will review better than your what's it called. So that is it. Because FAST is ultrasound. Don't forget, FAST is ultrasound. You cannot compare ultrasound to CT. So let me see if we can get this last one. Motor vehicle collision is unconscious. The tachycardia, there's irregular pulse. Blood pressure is 60. Imagine, blood pressure is 60. There's multiple bruise over the chest. JVP is increased. Bilateral crackles are heard at the lung base. 2 white ball cannula are set. 0.9% saline is infused. FAST is negative. ECG shows absent P wave. After 5 minutes, pulse is 160. Blood pressure drops to 50. Vasopressor administered. 1 hour later, patient dies. What's the diagnosis?
Tamponade. Cardiac tamponade.
Dr. Antonia.
Cardiac injury, cardiac confusion.
Yeah. So, Dr. Antonia, like, this will not be cardiac tamponade because they are giving this fluid. They are giving fluid, and patient still died. And they told us that fast was negative. If it was tamponade, fast would have seen it because the ultrasound, it will see the tamponade. You get? So if you see somebody like this, you are not seeing anything about muffled sound. You are seeing ECG abnormalities, hypotension. The give fluid is not working. It's confusion. Dr. Miriam, what do you think will have saved this patient?
Chief, what do I think killed the patient?
What do you think will have saved this patient that they didn't do right or they didn't pick early? What do you think they should have done to save the patient? Probably you didn't hear when I said it. I said it. What you can do for patient with, just picture it. Someone that's having cardiac contusion, what do you think is happening to the heart? Can it contract well?
Inotropes.
Give inotropes.
Okay, I thought they already gave. Okay.
No, they did not give. What they were doing is what? They were giving fluid.
Fluids, yeah.
Do you think they were helping this guy by giving fluid? You're administering vasopressor. Do you think vasopressor will even help? Vasopressor will be increasing the afterload, and they had to be finding it more difficult. So the person will die. So let's look at one more question in abdomen, and I think we have tried. I think we have actually tried. I think we have tried. Let's just look at the pelvis one or two. Pelvis.
Yes. Contract.
So a 54-year-old man is brought to the emergency. 25 minutes after he was so application of downward pressure of the pelvis shows no springy resistance or instability.
Yes.
Please, what's happening to Dr. Antonia network? she's speaking when we
It's
have
lagging. That's why.
like she's like I think she's like 30 minutes behind us. We have spoken about all these things. Dr. Antonia, please. Oh. So there is no blood at the urethra meatus. That was really very funny. Placement of Foley's catheter shows gross hematuria. A focused assessment with sonography shows no free fluid in the abdomen. X-ray of the pelvis shows a stable fracture of the anterior pelvic ring. What's the best next step? Ah, I'm not sure I mentioned this thing. Oh. Did I
This
mention
is
it? I did not mention it. So, like if you have uh injury to the pelvis to investigate, I just talked about the treatment only. I did not talk about the investigation. So you have to do retrograde ureterogram to look at the urethra, right? And you can do retrograde cysto cystography to look at the bladder. Okay, I think we have it here. So that's the investigation. We have it. Yeah, retrograde ureterography. You know, to look at the urethra if it's open before you can even insert a urethral catheter. Once there's a urethral injury, you might not want to insert catheter immediately. So you can do your retrograde ureterography to confirm it. Then if you are thinking of injury to the bladder, you do your retrograde cystography. So here now, this individual is most likely having um, suprapubic tenderness. This one is having suprapubic tenderness. There is blood at the urethral meatus. CT scan of the abdomen shows. This is another question, Abby. This is another question.
Yeah, I think there's another question. Maybe is it? I think it's the same.
Okay, same Abby. Okay. So let's look at it. Let's just look at the investigation. Abdominal examination shows suprapubic tenderness. There's blood at the urethral meatus. CT scan of the abdomen shows fracture of both ipsilateral pubic rami. Now, pubic rami fracture. What type of fracture is that? Is that perineal or pelvic? Hello? We're not saying anything. Oh.
Hello.
Pubic rami fracture. Is that pelvic fracture or oh.
Can you hear me?
Dr. Miriam, what are you saying?
Hello, Chief. Can you hear me?
Yes, yes. What did you say?
Dr. Mobo, I'm not following again, no.
Dr. Antonia,
I'm
sorry
not
about this,
following
but
again.
Chief.
I don't understand your question.
So I said that CT scan of the abdomen shows fracture of the ipsilateral pubic rami. I said, what type of fracture is this? Is it pelvic or perineal?
Pelvic.
Pelvic fracture. Now, this individual is having
Yes.
suprapubic tenderness. So, what investigation do you want to do and why?
But they said he has urethral blood at the urethral meatus. I was going to go for retrograde ureterography.
Yeah, but Dr. Miriam, you know that if somebody has injury to the bladder, blood can also trickle from the bladder to the
Yeah,
urethra. But a
true.
urethral injury will not cause suprapubic tenderness. You get.
Okay.
So what do you think now?
Retrograde
Yeah,
cystography.
yes.
Retrograde cystography. Good job. Okay, please. Let's go and solve more. I think the question is different, Dr. Miriam. It's different. It's different.
Dr. Babawala, I have a question.
I'm listening, Dr. Antonia.
Please, when you are saying something about my network is so bad today. I missed a lot. When you are saying something about concussion, you said you repeat CT scan And if everything is normal, the patient will not go back to the normal activity. So what's the time period? Like 48 hours of rest, they can now start on non-dependent, non-contact, mild activities or something.
Yeah.
So is it like after 1 week
Mm-hmm. So
that you do the CT?
so this is where you do it. So uh about some will say 24 to 48 hours, but at least 24 hours. Take them off that contact spot. Rest.
Mm-hmm.
Minimal, you know, cognitive stimulation. They're not watching TV, they're not doing playing want to be a millionaire, reading for USMLE, limited academic stuff, right? Then
Mm,
after that 48 hours, they can now start doing like aerobic exercise. They're just jogging. You get jogging.
mm,
Then gradually they can start doing like non-contact sports. Non-contact sport. Maybe they are playing tennis, badminton. Then from there they can now return. So um after you get to that non-contact sport, maybe after like 2 days, then at the end of 1 week, you can now repeat your imaging. Do you get it, Dr. Antonia?
Okay, at the end of
One
at the
week.
end of 1 week
1 week,
that they
yes.
start those non-contact sports. Okay.
No. At the end of 48 hours,
Oh,
you take them back. Be doing your
okay.
aerobic exercise.
Non-contact sports.
Maybe at third day, you can tell them be doing
Okay.
your what's it called? Uh non-contact sports. Do you get it?
Mm-hmm.
Before you tell them to
Yes.
return to contact sport, do your imaging at least after 1 week. Do you
Okay.
get it? So if it's okay, you can now tell them to now return to their contact sport after 1 week.
Mm.
Do you understand? That's the way it works.
Okay.
Yeah. So we have come to the end of this is like a 7-hour video. Oh my god. Let's just stop here. You know, we have to go and
That's a
have a
big
very
one.
good night rest, a very long one. Thank you so much for participating in this discussion. I'm
Thank you, too.
Thank you so much
you're
for your
welcome.
time.
You're welcome. All right.
It's really not easy.
Bye bye everyone.
All right,
All
good
right.
night.
Bye. Mhm.